Hello student, I hope all of you are doing good. Now we are going to discuss the answers of physiology questions. So the first question that was given, a patient with heart failure. If you look at the question, a patient with heart failure with preserved ejection fraction. What is the primary mechanism responsible for exercise intolerance? So basically, first of all, you try to understand heart failure with preserved ejection fraction means whenever the person is suffering from heart failure but the ejection fraction is greater than 50%. That means in this patient, systolic dysfunction is not a problem, but the problem is the diastolic dysfunction. So basically, this is a kind of heart failure which is known as the diastolic heart failure in other sense, right? So they are asking question that why the person will suffer, okay, or the person will feel more problem when the person is doing exercise, that is exercise intolerance, right? They cannot tolerate exercise. So there are multiple mechanisms for exercise intolerance in a heart failure case patient. Like for example, this I have taken from a journal article where all the mechanisms which are responsible for exercise intolerance in heart failure patient have been shown. Like for example, stiffening of the large elastic arteries, microvascular dysfunction, chronotropic incompetence means heart is not able to increase the heart rate, increase central filling pressure, microvascular dysfunction, multiple problems are there. But if you try to understand this topic in a simplified way, try to remember that the main problem or the main cause of exercise intolerance in case of diastolic heart failure patient is elevated atrial filling pressure, and second one is the chronotropic incompetence means because of the diastolic dysfunction the atrial pressure, the filling pressure is increased in the left atrium. Okay, and second is the chronotropic incompetence means heart is not able to increase the heart rate appropriately. So if you look at the options, coronary artery disease limiting the myocardial functions, not answer. Reduced cardiac output due to systolic dysfunction, I told you this is not systolic dysfunction related. Pulmonary embolism causing right heart strain, this is not the answer. So the correct answer is option number D, that impaired ventricular filling due to diastolic dysfunction and leading to elevated filling pressure. So option D is the correct answer in this question. Now the next question is coming here. The question is, in chronic kidney disease, patient often develop anemia. There are multiple causes of development of anemia in CKD patient. But look at the question. Anemia earlier than many other manifestations. So earlier than means why the anemia is developing in the early stage before the development of the uremia or severe chronic kidney disease. So iron deficiency from uremic bleeding, this is a thing which is true for the CKD patient, means in CKD patient this is going to happen. Okay, this is one of the cause of the anemia. Erythropoietin production decreases earlier than other kidney function, this is also true for chronic kidney disease anemia. Bone marrow suppression by uremic toxin, this can also develop in a uremic patient or chronic kidney disease patient. Increased red cell destruction, this also true for a chronic kidney disease patient. But if you look at the question, they are asking why anemia earlier than many other manifestation. So the most important answer in this question will be option number B, that is the deficiency of the erythropoietin in the early stage, right? So please remember that in case of chronic kidney disease, the anemia which happens, that is normocytic normochromic type of anemia, and it's a hypoproliferative kind of anemia. Severe erythropoietin deficiency is the main cause of development of anemia at the early stage. And you also remembered that erythropoietin production happens from which cells in the kidney? The peritubular cells of the renal cortex, as well as there is a recently discovered cell which is known as the NORN node cell, which is also the main source of erythropoietin in kidney. So this has been discovered recently. Even in the main lecture, I have not talked about this cell. So peritubular capillary cells of the renal cortex and the node cells, they are the source of the erythropoietin in kidney. These two important additional information you have to remember. Next is that, next question. Question is, in mitral stenosis, why does atrial fibrillation significantly worsen symptoms? So you have to understand that mitral stenosis means, suppose this is the left atrium. Okay, suppose this is the left atrium and this is the left ventricle. In between this valve, the mitral valve is stenosed, and because of which the filling of the ventricle is defective, right? So now we know that ventricular filling, from physiology concept, what you know, ventricular filling happens because of the passive filling phase and because of the active filling phase. Passive filling phase means the 70% of the ventricular filling happens when atrium is not contracting, that is the passive filling phase. But the last 25 to 30% of the ventricular filling occurs because of the atrial contraction, and that is known as the active filling phase, and this is known as the atrial kick. So the atrial kick is responsible for the last 25 to 30% of filling during normal cases. But whenever a person is developing atrial fibrillation, as you can understand that atrium is not able to contract significantly because of the fibrillation, the rate is so high that it is not pumping properly. So what will happen, the atrial kick will be deficient, and in that case the feeling will be more impaired and the symptoms will be more severe. So what will be the answer? The answer will be the atrial kick is lost and the arrhythmia impair feeling process through the stenotic valve. So option A is the correct answer. Other options are not true in these cases. Okay, so this is the answer of the question. Next question, which physiological adaptation at high altitude enhances oxygen delivery to the tissue? So in high altitude there are multiple changes happens at the level of tissue, at the level of lung, at the level of cardiovascular system. Those are known as acclimatization. If you look at the acclimatization, so what are the steps? Increase 2-3 dpg facilitate oxygen delivery, this is true for the high altitude acclimatization. Decrease cardiac output. Okay, so decreased cardiac output is a false statement in high altitude because there will be increase in cardiac output, increase in heart rate in the high altitude. Third is the reduced respiratory rate to prevent alkalosis. This is also a false statement because you all know there will be increase in the respiratory rate. Last one, decreased red blood cell production. This is also false because there will be increased RBC production, there will be increased hemoglobin because of the erythropoietin which is stimulated by hypoxia. So only one option is correct and that is our answer, increase 2-3 dpg. So whenever the increase 2-3 dpg is happening, we all know that there will be right shifting of the oxygen hemoglobin dissociation curve, and because of the right shifting of the oxygen hemoglobin dissociation curve, more oxygen delivery will happen at the level of tissue. So A is the correct answer of this question. Next question, during pregnancy, cardiac output increases markedly. What is the main underlying mechanism of increased cardiac output? So you have to remember that during pregnancy, cardiac output increases approximately 40%, right? This cardiac output increment is because of the increment of the stroke volume and the increment of the heart rate both. Stroke volume increment occur 30%, heart rate increment occur 15%. So that's why the blood pressure also increases, although it's fall during the first 24 weeks but raises again up to from 28 week onward. Okay, and peripheral vascular resistance decreases because of the decrease in the peripheral vascular resistance, diastolic blood pressure fall. So systolic blood pressure increases mainly because of the increased stroke volume and heart rate which is leading to cardiac output, and peripheral vascular resistance is falling because of which diastolic blood pressure reduces a little bit during pregnancy. So what is going to be the answer here? Why the cardiac output increases markedly? Fetal oxygen consumption, not the answer. Increased stroke volume and heart rate, absolutely correct. This is the main cause of increased cardiac output during pregnancy. Maternal weight gain, this is not the reason for increased cardiac output. Decreased peripheral resistance only. This is true, but this is not the answer in this question because peripheral resistance is directly related to diastolic blood pressure, not the cardiac output indirectly. Okay, so answer is option number B. Next question, if you look at the next question, again a question about the high altitude physiology. An unacclimatized individual rapidly ascend to high altitude. The decreased partial pressure of oxygen result in respiratory alkalosis. Absolutely correct. Which of the following renal compensatory mechanism is primarily activated to normalize this condition? So in my lecture, you have noted that whenever I have discussed that whenever you ascend to high altitude, there will be increase in respiratory rate. Because of the increased respiratory rate, carbon dioxide washout will be there, because of which alkalosis will develop in the body. Now this is respiratory alkalosis. So how the respiratory alkalosis will be compensated in the body? By the kidney. So how the kidney is going to compensate? Within 2 to 3 days, kidney is going to conserve more and more H plus ion and it is going to excrete more and more bicarbonate ion. So bicarbonate ion excretion is the main steps for alkalosis which is developing in the high altitude for the compensation of the alkalosis. So the answer of this question, increased bicarbonate excretion and H plus retention. So option C is the correct answer of this question. Other options are not true in this scenario. Now the next question, during maximal exercise, oxygen extraction, that is artery venous, AV is the artery venous oxygen differences increases compared to rest. What limit further oxygen extraction? So try to understand this topic. The question is asking that the heart is pumping blood, okay, and the blood is going to the level of the tissue capillary. So suppose this is the capillary, and the muscle is extracting oxygen from the arterial blood, and then the remaining blood is going to the heart. So artery venous oxygen differences will increase because during exercise muscle will take up more and more oxygen from the supplied blood. Now there is a limit beyond which AV differences cannot increase further. Okay, so what is that limit? The research articles are saying that the main limit is because of the cardiac output limitation. So heart cannot pump more blood, because of which the muscle cannot take more oxygen, cannot extract more oxygen. So normally, if you could recall, what is the oxygen extraction? So oxygen extraction is normally 25%. 25% means 1/4 of the oxygen is taken up by the muscle. During exercise, this extraction can increase to 70 to 80%. Okay, it can increase to 70 to 80%. Not beyond that, because venous blood there should be a little oxygen in the venous blood. So if you look at the options, venous oxygen content cannot fall below a critical threshold. This is true. But if you look at the remaining portion of this statement, threshold needed for venous return to the heart, venous oxygen is not a cause of venous return to the heart. So this option A is absolutely false. But what I told, that why during exercise the extraction of oxygen cannot goes beyond 70 to 80%. Most of the cases the limitation is cardiorespiratory limitation, and the main limitation, if you have to choose, then you have to answer cardiac output is the main limitation, because stroke volume cannot increase beyond a limit. That's why the artery venous oxygen difference and oxygen extraction cannot goes beyond 70 to 80%. So the answer of this question will be cardiac output limitation, option number C. Arterial oxygen saturation decreases. This is false. During exercise this cannot happen. Muscle oxygen demand decreases. This is also false. So only correct statement in this question is option number C, and option number C is our answer of this question. So this is the next question. A 25-year-old mountaineer ascends rapidly to high altitude. So again a high altitude related question. And he develops hyperventilation, mild dizziness, blood gas, reveal respiratory alkalosis. Similar type of question. Several days acclimatization as tissue receive oxygen more. Okay. So the question is saying that which of the following explain the long-term improvement in oxygen delivery to the tissue? We have already discussed this question. Okay, that there are multiple reasons. There will be increased hemoglobin, there will be increased RBC, there will be increased cardiac output, there will be increased diffusion of the oxygen. But the options that is given here, the persistent alkalosis is not the answer. Decreased hemoglobin is a false one. Increased partial pressure of oxygen, this is also false one. Okay, so the only thing that is true here is the increased production of the 2,3-DPG. So I already explained that increased 2,3-DPG means there will be right shifting of the oxygen hemoglobin dissociation curve that will leads to more unloading of the oxygen. More unloading of the oxygen means oxygenation will improve at the level of the tissue. So the answer is option number B. So this is all from physiology. I believe you have answered most of the questions correctly. Thank you so much and best of luck.
Hi everyone, welcome to this session in which we will be discussing the solutions for all the 9 biochemistry MCQs that were asked in the latest INI-CET model test that you attended. And this will be a high yield session because I will not only be giving you the solution for all those 9 MCQs, I'll also help you to understand how to exclude other choices. We will also be learning relevant facts and concepts. Okay, let's start with the first MCQ. A newborn screening test shows elevated 17-hydroxyprogesterone. So the first positive finding here is elevation of 17-hydroxyprogesterone, and confirmatory testing reveals 21-beta-hydroxylase deficiency. So they've given you the cause. It is 21-beta-hydroxylase deficiency causing congenital adrenal hyperplasia. But what is the question about? The question is which biochemical pathway is affected and what is the appropriate clinical management? I'll straight away give you the right answer. The right answer here is choice B, cortisol synthesis pathway is affected, but you should not only give hydrocortisone, you should also give fludrocortisone because there is salt wasting form. I've already told you this. 21 beta hydroxylase defect, 2 has wasted to become 1. Right? So 21 beta hydroxylase defect is a salt wasting form of congenital adrenal hyperplasia, wherein there is no aldosterone, so no sodium and water reabsorption. Sodium gets lost. To avoid that, you should replace aldosterone as well. That is done in the form of fludrocortisone. Okay, so the answer here is choice B. But as far as congenital adrenal hyperplasias are concerned, you will have to know 3 defects. The first one is 21 beta hydroxylase defect. This is the first condition. The second condition that you have to know about is 11 beta hydroxylase deficiency. The third one is 17 alpha hydroxylase deficiency. Let's start with 21 beta hydroxylase deficiency. As you can see here, in this condition, when the block is here, there is low level of cortisol and low level of aldosterone. When there is low cortisol, there is feedback stimulation of ACTH, which causes congenital adrenal hyperplasia. When there is low aldosterone, sodium and water do not get reabsorbed, that causes salt wasting form. So logically, what should you treat this patient with? You should replace cortisol using hydrocortisone. You should replace aldosterone by giving fludrocortisone. That is about 21 beta hydroxylase defect. Now, what if there is 11 beta hydroxylase defect? Even when there is 11 beta hydroxylase defect, you see that there is low cortisol. That causes feedback stimulation of ACTH and congenital adrenal hyperplasia. And there is also low aldosterone. But this does not present as a salt wasting form because the 2 precursors that accumulate here, 11-deoxycorticosterone and 11-deoxycortisol, they have mineralocorticoid activity. When there is excess mineralocorticoid activity, excess sodium and water reabsorption causes hypertensive form of congenital adrenal hyperplasia. So in this case, you're going to treat only cortisol deficiency by giving hydrocortisone. You should not treat aldosterone deficiency. Actually, you should treat hypertension. Do you understand this? So here you're going to give only hydrocortisone. You should not give fludrocortisone. Clear? Now what if there is 17 alpha hydroxylase defect? In 17 alpha hydroxylase defect, do you see that androgens are not synthesized, which means estrogens will also be not synthesized. So additionally, in this condition, there is low androgen, low estrogen, and there is low cortisol. The block is here, so what will not be synthesized? There is no cortisol. That causes feedback stimulation of ACTH, which causes congenital adrenal hyperplasia. Okay, so in this case, what should you treat? You should treat low cortisol by giving hydrocortisone, and you should treat low androgen and low estrogen respectively. If it's a male, you give androgens. If it's a female, you give estrogen. And there is excess cholesterol that is taken up to form aldosterone. When there is excess aldosterone, this also presents as a hypertensive form of congenital adrenal hyperplasia. So here you'll have to treat the hypertension. So the only salt wasting form here is 21 beta hydroxylase defect, for which fludrocortisone is necessary. For the other two, it is hypertensive forms for which you'll have to treat hypertension. Okay, so that is the clarity that you should have. So the answer here is choice B. The next MCQ. A 32-year-old man presents with recurrent episodes of acute pancreatitis. Lab tests reveal triglyceride level to be more than 2000 milligram per deciliter, which is a massive elevation of triglyceride, because you know normal serum triglyceride is less than 150 milligram per deciliter. Whenever you see a massive elevation of triglyceride, please suspect type 1 hyperlipoproteinemia, which is caused by the defect of lipoprotein lipase enzyme. And that is why in this case, they have done genetic studies and they have confirmed that it is lipoprotein lipase deficiency. Okay. So what is the dietary management strategy for this patient? The answer, okay, I'll first tell you the answer. The answer is severe fat restriction, less than 10% calories. They should be supplemented with medium chain triglycerides and they should be supplemented with omega-3 fatty acids. What is the rationale? Whenever there is lipoprotein lipase defect, both chylomicron and VLDL cannot be metabolized in the blood. So both chylomicron and VLDL are elevated. Both carry triacylglycerol. Chylomicron carries exogenous or dietary triacylglycerol. VLDL carries endogenous or liver triacylglycerol. And that is why you see a massive elevation of triglyceride in this condition. Okay. In this case, your aim should be to avoid further elevation of triglyceride. How can you avoid that? By reducing the source. What is the source? Dietary source. So restrict fat intake to less than 10%. That does not mean the person can be alive without fatty acids, right? Somehow we should give fatty acids. So let me give fatty acids which don't depend on chylomicron to get absorbed. I know medium chain fatty acids get absorbed all by themselves. They are not dependent on chylomicron formation. They are not dependent on chylomicron metabolism. So the diet should have medium chain triacylglycerol which get absorbed all by themselves. Okay. And then to reduce VLDL formation, I am going to give omega-3 fatty acids. So omega-3 fatty acids suppress liver synthesis of triacylglycerol. Hence the answer. So whenever you make a diagnosis of type 1 hyperlipoproteinemia, fat should be restricted less than 10%. The diet should have medium chain triacylglycerol and the diet should have omega-3 supplements. Okay. So the answer is choice A. So this is a complex medical oncology MCQ. A Western blot from a breast cancer tissue shows an overexpression of P53, MDM2 and cyclin D1. What is the most appropriate targeted therapeutic strategy? Let me give you the answer straight away. The answer is choice C. MDM2 inhibitor therapy to restore P53 function will be the right answer. Let me explain this for you. What is the actual role of P53? P53 stops the cell cycle at G1S transition so that the DNA can be proofread and repaired. Okay, that is not its only function. What P53 also does is P53 increases MDM2 expression. Okay, and that MDM2 expression degrades P53. So this is like a feedback cycle that is operative in cell cycle. Sometimes in some cancers, there is overexpression of MDM2. Whenever there is overexpression of MDM2, P53 gets degraded too much. So we are not able to stop the cell cycle. On continuous or repetitive cell cycle, that can result in neoplasia. And because the question says there is an overexpression of MDM2, I am going to start MDM2 inhibitor therapy so that I can keep P53 under control. Right? So P53 optimum concentration is maintained and that can stop the cell cycle. So the answer for this question is MDM2 inhibitor therapy to restore P53 function. Okay. The next MCQ. A patient presents with homocystinuria. So this is a case of homocystinuria. They have additionally given you that there is elevated plasma homocysteine and cysteine levels. Cysteine levels are also high, which means conversion of homocysteine to cysteine is happening normally. Okay, but what have they given you? Cystathionin beta synthase activity is normal, which is quite evident, right? Cystathionin beta synthase is the enzyme which converts homocysteine to cysteine. That activity is normal. So homocysteine is becoming cysteine. Still homocysteine accumulates, which means another fate of homocysteine is blocked. So what is another fate of homocysteine? It becoming methionine is blocked. That is done by methionine synthase enzyme. So whenever you see elevated homocysteine with elevated cysteine, the implied fact is cystathionin beta synthase is active. Okay, your inference is methionine synthase is defective. Okay, that is why there is excessive homocysteine and excessive cysteine. This methionine synthase is dependent on B12 and folate. So for this patient, I would supplement B12 and folate. So what is the right answer here? The right answer here is choice D. Methionine synthase defect. The person has to be supplemented with folate and B12. Okay. But let me tell you a bit about homocysteine metabolism. You should understand that homocysteine has got two fates. One major fate of homocysteine is that it becomes cysteine. The minor fate of homocysteine is that it becomes methionine. Conversion of homocysteine to cysteine is done by cystathionin beta synthase. That is dependent on B6 or pyridoxal phosphate. Whereas the enzyme which converts homocysteine to methionine is methionine synthase. That is dependent on B12 and folate. Okay, so what are the causes of homocystinuria? Logically, homocystinuria is either because of the block in the major fate or because of the block in the minor fate. If it's because of the block in the major fate, it means it is cystathionin beta synthase defect, in which case cysteine level should be low. And this case responds to B6 or pyridoxal phosphate supplementation. But what is given in the question? Homocysteine and cysteine are elevated, which means this is not the case. So what is the other cause? It is because of methionine synthase defect. If it's methionine synthase defect, you will see low methionine and high cysteine. So what is your inference? This patient is suffering from methionine synthase defect. Because methionine synthase is dependent on B12 and folate, this person responds to B12 and folate administration. So the answer here is methionine synthase defect, and the person responds to B12 and folate supplementation. Okay. The next MCQ. Enzyme kinetics, we have learnt about this in and out, right? In detail we have learnt. What have they given you? There is a type of inhibition wherein there is an increase in the Km while Vmax remains unchanged. I've told you whenever the Vmax is unaltered, close your eye and mark it as competitive inhibition. So what is the right answer here? We already know the answer. It is competitive inhibition, and it is statins inhibiting HMG-CoA reductase. Okay, but let's quickly recall or recap whatever we have discussed about the 4 types of enzyme inhibition. What happens to Vmax and what happens to Km. Okay, competitive inhibition is the only type of inhibition wherein Vmax remains unaltered but Km is high. Okay, for uncompetitive inhibition, I've told you parallel. What do you mean by parallel? Both values are altered in the same direction. Vmax is low, Km is also low. Mixed inhibition. Both the values are altered in the wrong direction. I want my enzyme to have high Vmax. In the presence of a mixed inhibitor, Vmax is low. I want my enzyme to have low Km. In the presence of a mixed inhibitor, Km is high. So if both the values are altered in the wrong direction, that is mixed inhibition. Non-competitive inhibition. What is the shortcut I gave you for non-competitive inhibition? Write non-competitive inhibition as NC. It is normal Km. Right? NC is normal Km and Vmax is low. Do you understand this? Normal Km but Vmax is low. So what is the right answer here? The right answer here is choice D. Statins inhibiting HMG-CoA reductase competitive inhibition because Vmax is unaltered. Okay, simple, right? Now the next MCQ. Sickle cell disease results from a beta globin gene mutation, which we know, and they've given you an additional information. In sickle cell anemia, in the 6th position, glutamic acid is replaced by valine. They've given you every fact that you're expected to know about sickle cell anemia. But what are they asking you? They're asking you for a reason. They're asking you, why does this single amino acid change cause hemoglobin to sickle? Okay, I'll give you the answer first and then I'll explain. It is because of abnormal protein interactions and polymerization. The answer is choice B. But the explanation is Whenever glutamic acid, which is a polar amino acid, is replaced by a non-polar amino acid, which is valine, all non-polar amino acids exhibit hydrophobic interactions. So in this case, if you look at this RBC, you know RBC cell membrane is also non-polar. It is also made up of lipid. And here the globin chains, beta globin chains have valine. Valine also is a non-polar amino acid. So it creates a sticky patch. Because of this sticky patch, multiple globin chains get polymerized. And these globin chains go and deposited on the RBC membrane. So RBC membrane loses its deformability. So whenever RBCs try to squeeze through splenic sinusoids, because the deformability is lost, RBC membrane gets pinched off and that causes sickling. So what is the reason for sickling? Polar amino acid is replaced by non-polar amino acids which exhibit a sticky patch. They stick to each other and they get deposited on the RBC membranes. So answer is abnormal protein interactions and polymerization. A good conceptual MCQ, right? The next one. A neonate presents with recurrent vomiting, lethargy and developmental delay. Lab evaluation shows elevated methylmalonic acid levels. I've told you whenever you see an elevation of methylmalonic acid level, you should think of supplementing with B12. Because B12 deficiency causes methylmalonic aciduria. So tell me what is the right answer? We already know the answer. If a neonate presents with methylmalonic acid elevation, we are going to supplement the neonate with vitamin B12. Okay, a bit about B12, nothing much in detail. You need to know that there are two coenzyme forms of B12. One is adenosyl B12, the other one is methyl B12. I'm going to stick to only adenosyl B12 here. Adenosyl B12 acts as a coenzyme for methylmalonyl-CoA mutase. And that is why whenever there is B12 deficiency, triple M, whenever there is B12 deficiency, methylmalonyl-CoA mutase is inactive. That causes methylmalonic aciduria. So whenever you see methylmalonic aciduria, give B12. That B12 will activate the enzyme methylmalonyl-CoA mutase, which converts methylmalonyl-CoA to succinyl-CoA, avoiding methylmalonic aciduria. Do you understand this? So what is the right answer for this question? Vitamin B12. The next question. Which of the following is correctly classified regarding apoptosis regulation? Right? Correct classification. The answer is BCL2, which is anti-apoptotic. How do I remember this? Okay. So BCL2. B has grown to become C. Right? B has grown to become C. So the cell is growing, the cell is multiplying because it is anti-apoptotic. Do you understand this? BCL2 is anti-apoptotic. And as far as BCL2 is concerned, also remember that there are two splice variants of BCL2. One is BCL-XS, the other one is BCL-XL. XS is extra small, XL is extra large. Okay. So the short splice variant of BCL is BCL-XS, the large splice variant of BCL is BCL-XL. And both BCL2 and BCL-XL, they are large, right? So they are anti-apoptotic. Whereas BCL-XS is apoptotic. XS is apoptotic, and that is why this is not the right answer. Okay. So what does BCL-XS actually do? XS goes and binds to BCL receptor, does not allow these two proteins to go and bind. So the anti-apoptotic effect is inhibited, and that is why BCL-XS is apoptotic, the other two are anti-apoptotic. So the answer for this question is choice B. Okay. The next one. What is the mechanism of CRISPR-Cas9 technology? All that I want you to know is it helps in gene editing. Right? CRISPR-Cas system helps in gene editing. So the right answer here is choice A. Because do you see the phrase precise gene editing? And apart from this, what should you know? Cas is an endonuclease which creates double-stranded DNA breaks at specific sites. Okay, what is an What is a Cas enzyme? It's an endonuclease which creates double-stranded DNA breaks at specific sites. So what if this Cas enzyme goes and creates double-stranded DNA breaks at sites causative of a disease? Mutation sites causative of a disease. The enzyme creates double-stranded DNA break, after which you can repair it. When you repair it, you will be successful in gene editing. So what is the right answer here? The right answer here is it's a programmable nuclease system for precise gene editing and therapeutic mechanism for targeted DNA double-stranded breaks. So the answer is choice A. So all these 9 MCQs are conceptual MCQs which are expecting you to think and answer, and this is the kind of MCQ that you can expect in INI-CET. Yeah, my best wishes. Thank you.
Hello guys, so welcome to the INI-CET discussion series, and we will start with pharmacology, and I am Dr. Ankit, your pharma educator at PrepLadder. So the first question is asking, there is a patient with stable INR of warfarin. Remember, INR is international normalized ratio, which is the prothrombin time increased with the use of warfarin. And the normal value of INR which we keep in our patient is between 2 to 3, and yes, now it is 2.5. Now this patient develops urinary tract infection and he has been prescribed one antibiotic, that is cotrimoxazole, which is also known as trimethoprim sulfamethoxazole. Short form is TMP SMX. Now what changes in INR is expected and what is the underlying mechanism? So let's understand first point that warfarin, when it comes into the blood, warfarin is attached to albumin. It is a protein bound drug. Now, when we give trimethoprim sulfamethoxazole, which is also known as cotrimoxazole, it is also an acidic drug just like warfarin. It also binds to albumin. So when it binds to albumin, can we say it will displace warfarin from albumin site? And that is why this warfarin will become free. And this free warfarin will enter into the liver. So it will inhibit vitamin K, which will decrease the production of clotting factor, and it will increase INR. Prothrombin time will increase. Now another thing with trimethoprim sulfamethoxazole is, remember this warfarin in our body, it is also degraded by CYP2C9 enzyme, that is cytochrome 2C9. Trimethoprim sulfamethoxazole also inhibit CYP enzyme. Because of this reason, the warfarin levels in the blood will increase, and again this warfarin will go to the liver, inhibit vitamin K dependent enzyme, and it will increase INR. So there are overall two mechanisms by which trimethoprim sulfamethoxazole will increase INR or warfarin toxicity. First, it will displace from albumin this warfarin, and second, it will inhibit the degradation of warfarin by CYP2C9 enzyme. So the correct answer for our question comes out to be B. The INR value will increase due to displacement from protein like albumin and CYP2C9 inhibition. Now let's come to the second question. A 65-year-old patient on digoxin. Digoxin is used for heart failure and it was given for atrial fibrillation. Now this patient is presenting with nausea, vomiting, visual disturbance. The classical visual disturbance seen with digoxin is yellow vision or known as xanthopsia, and we can very well see in our question there is yellow halos. Now lab value shows the serum levels of digoxin, the blood level of digoxin to be 2.8, and the normal range is given, which is therapeutic range 0.8 to 2.0. So can we say the serum levels of digoxins are elevated? Can we say the digoxin is producing toxic effect like nausea, vomiting and yellow vision because of digoxin toxicity? Now the serum potassium level is 3.0. Remember, the normal potassium level in the blood is 3.5 to 5.5 milliequivalent per liter, and in this case the serum level is 3.0. So can we say the patient is suffering from hypokalemia? So which factor increases the risk of digoxin toxicity in this patient? Remember one rule, that hypokalemia increases digoxin toxicity. Hypokalemia increases digoxin toxicity. Now, how it increases? Understand, on our body cells, there is an enzyme known as sodium potassium ATPase. And the function of this enzyme is to throw back sodium after repolarization has been completed and bring back potassium inside. And it requires ATP, so we call it as sodium potassium ATPase. Now, digoxin comes from outside, and digoxin blocks this potassium binding site of sodium potassium ATPase. So that is why digoxin inhibits sodium potassium ATPase normally. Now just think for a second that if the blood level of potassium is less, can we say there will be more digoxin binding to? There will be more digoxin binding to sodium potassium ATPase, and that will increase the risk of digoxin toxicity, because both potassium and digoxin, they are competing for the same site. So hypokalemia will increase digoxin toxicity. So the correct answer of this question is option number A, that hypokalemia potentiate digoxin toxicity by increasing the binding to sodium potassium ATPase enzyme. Now the next question is, a 45-year-old patient with CML, which is chronic myeloid leukemia, and this patient is on imatinib therapy. Yes, imatinib is the drug of choice for CML, and this patient develops rising BCR-ABL transcript level. That means the amount of this BCR-ABL transcription has been increased. Now, when we have done mutation analysis by genetic testing, there is some T315I gatekeeper mutation. So which tyrosine kinase inhibitor retains activity against this mutation? So let's understand this concept that in a cancer or a tumor, chronic myeloid leukemia, the most common mutation is BCR-ABL tyrosine kinase mutation. So this BCR-ABL tyrosine kinase is a type of a receptor present on cell membrane. So let's make BCR and ABL. And if this receptors becomes activated, it causes uncontrolled cell division, which is also known as cancer, and here the cancer is CML. Now, the first drug of choice for CML is we give imatinib. And this imatinib inhibit ABL kinase. It inhibits ABL kinase enzyme. That is why cell division will stop. But what happens? This cancer or CML, it can become resistant to imatinib. Why? Because this imatinib will not able to attach on ABL kinase, because there is on ABL kinase there is a mutation. We call this as point mutation, where there is a change in amino acid sequence. That is why imatinib will not able to bind it. And this mutation is known as T790M mutation. So imatinib resistance occurs because of T790M mutation. So what to do? In imatinib resistant cases, we have developed other new drugs. So we can use 3 drugs in imatinib resistant cases, that is nilotinib, dasatinib, and bosutinib. And these drugs are known as second generation BCR-ABL tyrosine kinase inhibitor. But the cancer cell will not stop here. Cancer cells now, it will develop another type of mutation known as T315I mutation, in which again there is some changes in ABL kinase enzyme, and these 3 drugs will not able to bind to them. In that case, we have developed another drug, ponatinib. Now ponatinib, remember, it can even bind to T315I mutant variety of BCR-ABL tyrosine kinase. That is why it is known as third generation BCR-ABL tyrosine kinase inhibitor. So this is the treatment of CML. Start with imatinib. Imatinib resistant cases give nilo, dasa and bosutinib. And if still there is a resistance, give ponatinib. So the answer of this question is A. Ponatinib is the only approved tyrosine kinase inhibitor for T315I gatekeeper mutation. Now, next question is, a patient is on immune checkpoint inhibitor, develops grade 3 pneumonitis, which is symptomatic, and it is limiting the adverse drug reaction. It is a very dangerous adverse drug reaction. Now, what is the appropriate treatment? Now, let's understand what do you mean by immune checkpoint inhibitor. Remember, cancer cells, they bypass our body immunity. That is why, because cancer cells, they bypass the immunity of our body, that is why immunity will not able to kill the cancer cells and cancer cells grow. Now, how cancer cells, they bypass the body immunity, they develop certain molecule, they release certain chemical, which I'm going to tell you in the upcoming MCQ, which chemicals are released. And these chemicals, they will go to lymphocyte, and these lymphocyte, they will stop working because these chemicals are inhibitory chemical. Now we have developed certain immune checkpoint inhibitor. Immune checkpoint inhibitor, they inhibit these chemicals so that lymphocyte will again start working and it will increase immunity of the body. And if there is increase in immunity of the body, don't you think this immunity will kill the cancer cells? So these drugs are known as immune checkpoint inhibitor. So many drugs are there, which I'm going to tell you shortly, like nivolumab, ipilimumab, and pembrolizumab. So these monoclonal antibody are immune checkpoint inhibitor. In simple word, they increase body immunity. Immunity will kill the cancer cells. Now they are used in variety of cancers like melanoma, lung cancer, etc. Now there is a great problem with using these drugs. Don't you think if immunity of the body will increase, this excessive immunity will produce certain side effects? The first side effect is cytokine storm. There will be lot of cytokines released by these lymphocytes, and these cytokines will cause organ damage. So in organ damage, there will be kidney damage like nephritis, liver damage known as hepatitis, lung damage known as pneumonitis, and remember, they can be life threatening. So because they are life threatening, what we have to do if they are producing these excessive immune response syndrome kind of a thing, we have to give the treatment. The first treatment is stop these drugs. We have to stop these drugs. And we have to add corticosteroid to reduce the immunity of the body again. So we can give prednisolone to check or counteract the excessive immunity produced by immune checkpoint inhibitor. So the correct answer will be B, hold immunotherapy and start prednisolone. Remember, we should not continue with them because these side effects can be life threatening. We cannot reduce the dose. Switch to different, there will be no use. So the correct answer will be B. Now next question, a 55-year-old man with colorectal cancer and isolated liver metastasis. So this patient has metastasis of colorectal cancer into the liver. Now this patient has been started on a chemotherapy agent which is administered directly into hepatic artery. So let's say this is hepatic artery. So if there is isolated liver metastasis, we can give a drug directly into hepatic artery. Now this drug acts by producing thymidine deficient cell death. So which of the following is the most likely receiving? The correct answer of this question is floxuridine. So floxuridine is a specific drug which is directly injected into hepatic artery for liver metastasis. Now, what is this floxuridine? So floxuridine, first point you will write, it is a prodrug. It gets converted into 5-fluorouracil. 5-fluorouracil is also a separate anti-cancer drug, but remember it is given IV directly into the vein. It is not given into hepatic artery. Now, what is the action of 5-fluorouracil which is produced? Remember, it's an anti-cancer drug. This drug will inhibit DNA synthesis and cancer cells will not divide. So you know that for DNA synthesis, first we need to convert uridine into thymidine. Why? Because DNA contains thymidine. It does not contain uridine. And this thymidine is required for DNA synthesis. So the logical enzyme which is required to convert uridine into thymidine must be thymidylate synthase enzyme. Now, don't you think this uridine, which is the normal uridine, and 5-fluorouracil, it is also a kind of a uridine. It is also a kind of a uridine or uracil. This enzyme will become confused between normal and fake uridine. So that is why 5-fluorouracil, which is produced, it inhibit thymidylate synthase enzyme. And because it inhibit thymidylate synthase enzyme, it will reduce thymidine production. So can we say it will lead to thymidine deficient cell death? Because DNA will not be produced. So the correct answer is floxuridine. Now, next question, what is the mechanism of action and clinical application of monoclonal antibody therapy targeting PD-1 pathway? Now, PD-1 stands for program death receptor. Program death pathway. Now, what is this? Again, it's a type of immune checkpoint inhibitor which we just discussed. So I have just told you that cancer cells, it makes certain chemicals which will bypass our body immunity. How? Because they will go to lymphocyte, and lymphocyte they will stop working, and that will decrease the immunity of the body. So one very important chemical which is released by cancer cell is PD-1. PD-1 is program death 1 chemical. So this program death 1 chemical, it goes to the lymphocyte, and the logical receptor will be program death 1 receptor. And this is a type of inhibitory receptor. Inhibitory means it will stop the functioning of lymphocyte, that will reduce immunity of the body, and cancer cells will grow. So that is why we have developed a class of anti-cancer drug known as immune checkpoint inhibitor. Immune checkpoint inhibitor, what they will try to do? They will block this pathway. So we have developed certain monoclonal antibody that will inhibit program death 1 ligand, and we have developed a class of a drug that will block program death 1 receptor on lymphocyte. So the drug that will inhibit PD-1 directly is atezolizumab. One drug you have to remember, durvalumab. Although there are other drugs also, but never ask. And the drug that will block program death 1 receptor, a very, very important drug, pembrolizumab. And another drug is nivolumab. So they are used in variety of cancers. They were initially developed for melanoma and lung cancer, but now, especially pembrolizumab, it is used for more than 50 cancers. So what do you think is the correct answer of this question? The correct answer of this question should be A. They block inhibitory checkpoint, allowing T cell activation, T lymphocyte activation against tumor cells. Next question. When a post-operative patient who is CYP2D6 poor metabolizer, that means the activity of cytochrome P2D6 enzyme is very less. Now this patient is prescribed codeine for pain. Codeine, remember, is an opioid. It is used as an analgesic or a painkiller. What is the clinical outcome? Now understand this point, that codeine, it becomes converted into its active form. Active form of codeine is morphine, and it gets converted into active form with the help of CYP2D6. Okay, D, how we can remember? D for dimag. Opioids, they act as an analgesic through dimag or brain. Now understand, if the activity of CYP2D6 is very poor, can we say codeine will not be converted into morphine. Very less amount of morphine will be produced. And if very less amount of morphine will be produced, don't you think it will produce very poor pain relieving effect or poor analgesic effect? Because morphine is not produced because of low activity of CYP2D6 enzyme. So the correct answer for our question comes out to be option number B. There will be inadequate or very poor analgesic effect. Next question, a kidney transplant recipient on tacrolimus therapy. So tacrolimus is an immunosuppressive drug. It is given in organ transplant people like kidney transplant. Now this patient develops nephrotoxicity, which is increasing creatinine level despite therapeutic tacrolimus level. What is the best alternative approach? So remember, in organ transplant people, we have to give immunosuppressive drug. Now immunosuppressive drugs can be classified into either they are nephrotoxic or they are renal safe. The first drug, always we start our nephrotoxic drug because they have a great advantage. They have no risk of bone marrow suppression. That is why we start them. So if there is kidney damage, we switch over to renal safe drug. But renal safe drug, they have a side effect of bone marrow suppression. So don't you think their side effect is opposite to each other? But first we start with nephrotoxic drug. So in nephrotoxic drug, we have only one class of a drug known as calcineurin inhibitor. So calcineurin is an enzyme present in T helper cells or lymphocyte. If we inhibit it, it will reduce cell mediated immunity, and the drugs are cyclosporin or tacrolimus. They are now considered to be the drug of choice for organ transplant people. But remember, if there is any risk of nephrotoxicity, we have to stop this drug. If there is nephrotoxicity, we have to stop the drug, and we have to start now renal safe drug and monitor for bone marrow suppression. So renal safe drugs, among immunosuppressants, we have the first drug is CTLA4 immunoglobulin. CTLA4 is again a inhibitory receptor on lymphocyte, and the drug which is approved is Belatacept for organ transplant. Second we have is mTOR inhibitor. That is some mammalian or mechanistic target of rapamycin. We don't have to remember the full form. So the drug is mTOR inhibitor. We have is sirolimus and everolimus. If still not controlled, we can give a monoclonal antibody that will block CD25 receptor. The drug name is basiliximab. If still not controlled, we can give mycophenolate mofetil, or we can give corticosteroids. So these are the renal safe drugs we have. In cases of any organ transplant people. So can you tell me now what should be the correct answer? So if the tacrolimus is producing nephrotoxicity, we have to stop it, and we have to start any of the following drug, which is renal safe drug. In this case, remember, Belatacept is given in the option. So now, can we give cyclosporin? No, cyclosporin itself is a nephrotoxic drug. We will never think of increasing the dose of tacrolimus. Okay, so the best answer is option number A. Next question, a 68-year-old man with atrial fibrillation has been on long-term warfarin therapy. Now the patient has stable INR of 2.5. Now he started on amiodarone for rhythm control. Because of atrial fibrillation, we have to control atrial rhythm by giving antiarrhythmic drug amiodarone. So what is the expected effect of amiodarone on INR and how it should be managed? So remember, we have just discussed that warfarin in our body, it is degraded or metabolized by with CYP2C9. And amiodarone, remember, an antiarrhythmic drug is an inhibitor of CYP2C9. Now, can we say that will increase warfarin level? And increase in warfarin level will lead to warfarin toxicity. And warfarin toxicity means prothrombin time will increase, which in other word means there will be increase in INR value. So because there is an increase in INR value, there is a risk of bleeding now. Now, because to reduce the risk of bleeding, we must reduce the dose of warfarin. So that INR should come back to the normal range. So the best answer is the INR will increase with amiodarone. So we have to reduce the dose of warfarin. Next question, when selecting an appropriate gentamicin, which is an aminoglycoside dosing regimen for neonates, extended interval dosing, that means we must increase the interval between two successive doses, is commonly used. Instead of frequent dosing schedule, that means we should not give more frequently, we should increase the gap between doses. That means in some way we are reducing the dose of gentamicin. Now, as compared to typical in adult, what key physiological factor in neonates supports the use of this extended interval therapy or strategy? Remember, aminoglycosides like streptomycin, gentamicin, they are highly polar drug. They are excreted through kidney. They are excreted through kidney in urine only with the help of glomerular filtration. So they are simply filtered out into the kidney and they are excreted out in urine. Now remember, in extremes of age means either neonate, a newborn child, and old age. In neonate and old age, there is decrease in renal function or GFR as compared to adult people. So in neonate or old age people, the kidney functions are less. So don't you think if there is less kidney function, aminoglycosides like gentamicin, they will accumulate more in blood. It can lead to toxicity. To reduce this accumulation, we must increase or extend the dosing interval of gentamicin or aminoglycoside. So what is the main reason why we increase the dosing interval? Because of immature renal function in neonate, which will increase the half-life or length of action of aminoglycoside. Next question, a 40-year-old male who is presented on clozapine for schizophrenia for past 6 months presented to emergency department with 2-day history of fever, sore throat and profound fatigue. Now his CBC or complete blood count reveals WBC levels of 2000. We know that total WBC count should be between 4000 to 11,000. Now here, don't you think patient is having low WBC count? And in low WBC count, especially absolute neutrophil, it is also found to be less. So normal neutrophil count should be more than 3000. But here it is only 800. So yes, the patient is developing neutropenia. Now this neutropenia is also known as agranulocytosis. And we very well know clozapine can cause agranulocytosis or simply bone marrow suppression. And this agranulocytosis due to clozapine is a dose independent side effect. Dose independent side effect means that it may occur at any dose level of clozapine, low dose, normal dose, high dose. And remember, it can be permanent also. So that is why we should stop clozapine if the patient is developing agranulocytosis. So the answer is discontinue clozapine immediately. Now why the second option is incorrect? Reduce the dose? No, because it is a dose independent side effect. Remember, there is no effect of reducing the dose of clozapine. Continue clozapine? No, it's a dangerous thing. Bone marrow suppression can be life threatening. Patient can die. Now add GCSF. Yes, GCSF like granulocyte colony stimulating factor, which is also known as filgrastim. It is given for the treatment of neutropenia. Yes, it can be given while continuing clozapine therapy. No, clozapine should be discontinued. Yes, we can give filgrastim. So the correct answer is only and only option number A. Next question, a 60-year-old male with metastatic melanoma whose tumor harbors BRAF V600E mutation. Remember, in pathology, when you will learn melanoma, in melanoma, the most common mutation is BRAF V600E mutation. And so in melanoma, what is BRAF's this 600E? Again, just like BCR-ABL tyrosine kinase, BRAF receptor is also a tyrosine kinase receptor. It is also responsible for cell division. How it leads to cell division? This BRAF receptor, it starts one pathway known as MEK pathway. And this MEK pathway, which is associated with mitosis or cell division, it can lead to cell division or cancer. So that is why for the treatment of melanoma, the first class of drug which we have made is BRAF inhibitors. So BRAF inhibitor drugs are vemurafenib. How we can remember this drug? Remember, this drug also have RAF word in it, just like BRAF. Now, when you have started vemurafenib, initially it will respond, but cancer cells can develop some alternative mechanisms also. So when there is resistance to vemurafenib, there is overactivation of MEK pathway. There is overactivation of MEK pathway and the cancer cells can become resistant to vemurafenib. So if there is resistance to vemurafenib, now we have to add a drug which is a MEK inhibitor. The drug which is MEK inhibitor is cobimetinib, tremimetinib. So they are having MET word in it. Okay. So this is how we treat melanoma tumor. Now let's read the question again. So initially the patient responded well to vemurafenib monotherapy. Now he is presenting with progressive disease confirmed by imaging indicated by acquired resistance to vemurafenib. Now, which of the following best describes the common mechanism of resistance to BRAF inhibitor like vemurafenib, and what is the appropriate next therapeutic strategy? So, what we have to do in this vemurafenib alone cases, we will also add cobimetinib so that both pathway gets inhibited simultaneously. They will have additive effect. So, the best answer is MEK pathway becomes reactivation. This is the common cause of resistance. So that is why now we should combine with BRAF and MEK inhibitor in cases of melanoma. Next question, what is the mechanism of action of CAR-T T cell therapy and their main toxicity management? Now what is the full form of CAR-T? First we will write the full form of CAR-T as chimeric antigen receptor T cell therapy. So this is known as CAR-T. Now what are these T cells? Here you can see T cell word is coming. Remember, let's say this is a cytotoxic lymphocyte or T cell. What we have done, we have genetically engineered these T lymphocyte. Let's say there is a cancer cell. There is a cancer. And let's say this cancer has an antigen on it. Let's say that antigen is CD19. For a moment, remember CD19 antigen is present on cancer. And CD19 antigen cancers, they can lead to lymphomas. Now what we have done on this T cells, on this T cell, we have attached a receptor, a genetically modified T cell with a special type of receptor. And let's say this receptor is CD19 receptor. So can we say this type of T cell is chimeric? Chimeric means modified. And it is having some antigenic receptor. So this is known as CAR-T, chimeric antigen receptor T cell. So now don't you think if we will give this T cell to our patient, it will directly go and recognize CD19 on cancer cells and it will directly kill cancer cells which harbor CD19 receptor. So right now it has become a very famous therapy for the treatment of lymphomas which harbor CD19 lymphocyte. Right now we have CD19 CAR T cells available as a treatment option for our patient. Now what is the problem? When these T cells are working, don't you think these T cells will release cytokines? And these cytokines will increase immunity and that will try to kill the cancer cells. So it can lead to cytokine storm syndrome. It can lead to cytokine storm syndrome. So cytokine storm syndrome can be managed. If this side effect comes, first we can give corticosteroid. And in corticosteroid resistant cases, we can give a monoclonal antibody, tocilizumab. We give a monoclonal antibody, tocilizumab. It blocks the main cytokine which is responsible for cytokine storm, that is interleukin 6. That is the main cytokine which causes storm. So what is the correct answer? Yes, now the correct answer is very well explained and understood. That is A, they are genetically modified T cells against CD19. Watch for cytokine release syndrome. If it occurs, you can give tocilizumab. Now let's talk about next question. What is the mechanism of action and major clinical application of rituximab? So we have discussed one technique that there is a girl known as Ritu, and Ritu age is 20 years. Ritu age is 20 years. So it blocks CD20 receptor. And remember, CD20 receptor is present on B lymphocyte. So if we block B lymphocyte by rituximab, can we say rituximab is given for the treatment of lymphomas? So it has been approved for two lymphomas. One is NHL, that is non-Hodgkin's lymphoma. It is also approved for CLL, chronic lymphocytic leukemia. Plus, it is also given for various autoimmune disease. It is also given for various autoimmune disease like rheumatoid arthritis, ITP, idiopathic thrombocytopenic purpura, autoimmune hemolytic anemias, SLE or DLE, drug-induced lupus erythematosus, etc. So we have already discussed a mnemonic known as Reliance, the uses of rituximab in our regular lecture and RR revision. So the correct answer for our question is CD20 monoclonal antibody, which kills B lymphocytes, and it is given in lymphomas and autoimmune disease. Now, what is the next question? TNF alpha inhibitor for inflammatory disease. Remember, TNF alpha inhibitor is infliximab, which is mainly used for rheumatoid arthritis. It is also given for IBD, inflammatory bowel disease. Then we have interleukin 6 antagonist. Yes, we discussed just tocilizumab. So tocilizumab is given for rheumatoid arthritis. It is also given for the treatment of cytokine storm, which we just discussed. PD-1 checkpoint inhibitor, which we have just discussed, pembrolizumab, nivolumab. So here the correct answer is option number A. Now, which of the following is not a common side effect of tacrolimus? So tacrolimus, which we have just discussed, is a calcineurin inhibitor. So it is used as an immunosuppressive drug mainly in the patients of organ transplant people, and its main side effect, which we have just discussed, was nephrotoxicity. Its main side effect is nephrotoxicity, and if this side effect comes, we have to stop this drug. Dose limiting side effect. Now, what are the other side effects of tacrolimus? Other side effects of tacrolimus, they will start with the word hyper. So first is they can cause hyperkalemia. They can also cause hyperglycemia because they can lead to insulin resistant diabetes. They can also lead to hypertension. They can also lead to hyperlipidemia. Lipid levels will also increase. They can also lead to hyperpigmentation. Agreed? So everything is starting with the word hyper. So remember, which is the option out here with hypo? The answer is hypoglycemia is not a side effect because tacrolimus can lead to insulin resistance diabetes in which there is hyperglycemia. So now, next question is, a 28-year-old man is being counseled about thalidomide therapy for multiple myeloma. Yes, remember thalidomide, it is given for 4 uses. Thalidomide is a very commonly asked question. It is used in 4 cases. First use of thalidomide is type 2 lepra reaction. To reduce immunity, if we reduce immunity, this hypersensitivity lepra reaction, which is also known as ENL, erythema nodosum leprosum, it will also get cured. It is also given for oral ulcers, which is seen in Behçet's disease. Now, there are 2 tumors or cancers where we give thalidomide. First is multiple myeloma, and next tumor or cancer where it is given is MDS, myelodysplastic syndrome. So obviously multiple myeloma we can give thalidomide. Now, which of the following is the most important teratogenic risk associated with thalidomide? Thalidomide, we all know, causes phocomelia. Phoco means short or malformed. Melia means limb. So these limbs will become very short, which are also known as seal-like limbs. So you must have seen an animal seal. No fingers are there, है ना? Very small limbs. A sea animal seal. So the correct answer is limb malformation. So this is all for Pharma INI-CET. Best wishes. Keep learning always.
So hello friends, we are starting a very important discussion of INI-CET Champions Exam Forensic Medicine question. So first question is this autopsy finding in 30-year-old female reveal the following injury and toxicology shows therapeutic level of sertraline based on the information. What is the most likely manner of the death? Here two images are given. One image is of palmar surface and the second image is of this one, flexor aspect of your forearm or wrist. Now, options are, is it a case of suicide with evidence of self-inflicted injury and hesitational mark? Two injuries are given, okay? Homicide based on the defense wound pattern, second option. Undetermined due to mixed injury pattern, third option. An accidental death from medication overdose. My dear friend, here two injury are pattern. If you see, the first injury is the kind of defense wound. You have two type of defense wound. One is active when you grasp the weapon, and second is a passive when you defend yourself like this. This is active and passive. So most common site of active defense wound is palmar surface and first web space. And passive defense wound, as you can see when you protect yourself. So these are the common site of passive defense wound. Okay. Now this is active defense wound. Now self-inflicted injuries, which are suicidal wound, which are hesitational cut, tentative cuts, trial cut or intentional cut, generally present on the wrist, this one area, and the neck and the flexor aspect of forearm, and multiple superficial wounds are there. So these are suicidal in nature, multiple superficial, parallel in nature. These are self-inflicted, or you can see this is the picture. So my dear friend, here if you see the picture in this question, the first picture is of palmar surface or this area, and the second picture is multiple superficial wound. So one thing is clear, this answer of the question is undetermined due to mixed injury pattern. So here answer is option C. The pattern of the injury, the manner of the death is undetermined because we have mixed injury pattern. So here answer is C. You can see here also we have injury, here also we have injury. That means the manner of death is undetermined. That's a very important question and I discussed in a very important manner. Now see. Second question. A body is discovered outdoor in cold winter condition, approximately 40 degree Fahrenheit. Winter condition is there. Rigor mortis is fully established. Livor mortis is fixed. Means rigor mortis is all over the body. And livor mortis, that is a postmortem staining, is fixed and purplish in color. And there is no sign of decomposition. Climate is cold climate. If you see, अगर आप देखते हो, तो climate is a cold climate and rigor mortis is fully established, means all over the body. Now, these are the four options. What is the time since death? First option, cannot determine for given information. 2 to 4 hours based on the rigor mortis. 1 week based on absence of decomposition. And 12 to 36 hours considering cold temperature slowing postmortem changes. Now, sir, if you see the postmortem staining, it begins in 30 minutes, visible in 2 hours, maximum in 6 to 12 hours, fixation in 7 to 8 hours, and decomposition, it persists, it becomes green in color. So as you say in the question, it is fixed. It is fixed. So it is 7 to 8 hours. Okay, we are taking it 7 to 8 hours. Now rigor mortis is a stiffening, as you can see. It starts in 1 to 2 hours, but it is well established. So there is a rule of 12. In first 12 hours, it appears in all body muscles. In next 12 hours, it remains in all body muscles. And in next 12 hours, it disappears from all body muscles. 12 घंटे में आती है, 12 घंटे रुकती है और 12 घंटे में चली जाती है. तो what is 12 plus 12 plus 12? It becomes 36 hours. Okay, that is very, very important. And it disappears in the same order. So you can see the rigor mortis develops all over the body, that is 36 hours. But only important point we can see, putrefaction changes. First putrefaction change is the greenish discoloration of right iliac fossa in summer in 12 to 18 hours and in winter it is 1 to 2 days. But here decomposition or putrefaction changes have not been started. Now see, rigor mortis is fully established, that means around 36 hours. Postmortem staining fixed, that is 7 to 8 hours. now rigor mortis fully developed, postmortem staining fixed. Rigor mortis पूरी body में develop हो गई है, postmortem staining fix हो गई है. That indicate it is 36 or 12 hours, between 12 to 36 hours, but no sign of decomposition. Why there is no sign of decomposition? Because of cold climate. Here you can see the 40 degree Fahrenheit. The decomposition changes has been slowing down. So here answer is 12 to 36 hours is a time since death. And because of the cold temperature, my dear friend, because of the cold temperature, postmortem changes are slowing down. Rigor mortis developed fully, 36 hours. Postmortem staining fixed, yes, but it is slowed down. That's why I am delaying it 12 to 36 hours. Okay, the answer is this one. No postmortem changes of decomposition are seen because of cold climate. So this is very important one. Now, sir, the third question. A person is found deceased in the closed garage with the vehicle running. Forensic examination reveals cherry red discoloration and carboxyhemoglobin level of 60%. It's very simple. If carboxyhemoglobin level is elevated, it is carbon monoxide poisoning. So, is it a natural death from cardiovascular disease? Carbon monoxide poisoning from accident, suicide or homicide? Cyanide poisoning, definitely homicide, undetermined cause of death. Now, sir, two very, very important things are given here. Number one, cherry red discoloration. Second, carboxyhemoglobin level of 60%. If you see, this is the question. Carbon monoxide poisoning may be accident, may be suicide, may be homicide. Very, very common in car engine, chimney and heater, which is a gasoline heater. Now, sir, these are carbon monoxide level. So, if your carbon monoxide level is 50 to 60% or 60%, that can lead coma and death. All the symptoms at the carbon monoxide level or carboxyhemoglobin level are shown here. Okay. Now you can see this is cherry red discoloration of your tissue, organ and your skin. That's a postmortem staining in carbon monoxide. Because of carboxyhemoglobin, it is cherry red. So if you get two important points here, these are 2 points. Cherry red discoloration and carbon monoxide or carboxyhemoglobin level of 60%, that indicate it is a carbon monoxide poisoning. It could be a case of accident, homicide or suicide. Now, sir, the question number 4. And a decomposed body is discovered submerged in water, showing clear adipose hair formation. Toxicological results are unavailable due to decomposition. So it is not available. Unavailable due to decomposition. What is the estimated time since death? So it is clear-cut case of adipose hair, as you can see, because if the body is in water or warm and humid area, two important things are there. या तो body पानी में हो या warm and humid climate में हो, there will be adipose hair. It is a grave wax or saponification. As I told you, warm and humid area or body in water, the bacteria is Clostridium welchi, but enzyme is intrinsic lipase. What is this? It is fatty tissue changes, hydrolysis and hydrogenation. That's why it is known as saponification. Now, sir, the site are mainly the fatty area, the face, buttock, breast and abdomen. Now, sir, you can see adipose hair time is few days to few months or few weeks. So it gives the idea about time since death. In India is a very humid country. It starts in few days. That's a 3 to 4 days, but it can take few months. The smell is ammoniacal or rancid water appearance, my dear friend. Fetus below 7 months, it is absent, and this is adipose hair. So if you see, my dear friend, this is a clear-cut question. Here, what is the time since death? Several weeks to several months. Several weeks to several months. So it takes few weeks to few months for getting adipose hair. The complete adipose hair is there because it's a clear adipose hair. So it is several weeks to several months. This is very important question. What is the time for adipose hair formation? So as it is mentioned, 3 days to 3 months. So you can write down several weeks to several months for adipose hair formation. Now, sir, this is another very, very interesting question. In a sexual assault case, a vaginal swab shows mixed DNA profile. That is a mixture of few DNA profile. एक नहीं है मतलब. दोस्तों, multiple DNA profile. The victim is the major contributor and the minor contributors DNA yield a likelihood of 10,000:1 in the favor of suspect versus unrelated individual. So, suspected 10,000 and unrelated individual 1. That's the ratio of this DNA yield, my dear friend. How should the result be interpreted? It's very simple. The 10,000 for suspect, 1 for unrelated. So here strong contribution, that is evidence suggestive of suspect's DNA contribution. So this is strong evidence supporting suspect's DNA contribution because the ratio is 10,000 is to 1. It is a mixed DNA profile. So it's a very important question. That is suspect's DNA contribution is strong evidence. Option C is the correct answer. High-speed motor vehicle collision involving a unrestrained driver result in death. Autopsy reveals aortic transection at the isthmus. So here the main part is there is an aortic transection at the isthmus. What is the most likely mechanism of injury? My dear friend, I discussed in detail कि भैया जब आप you are inside a vehicle and there is aortic dissection or there is aortic transection and isthmus is involved, if you see, that's very important. These are steering injuries. If you see the word steering, ST sternum fracture, yes, RI rib fracture, and ladder rung tear is very, very common. So you can see all the injuries. The sternum fracture, rib fracture, chest injury, and organs involved are lung, heart, and aorta, and especially the descending aorta that is compressed. And my dear friend, the mechanism of injury of aorta, that is a deceleration injury. That is a shearing and stretching force on aorta. Shearing and stretching force on the aorta, that isthmus is ruptured. So here very, very important question. The isthmus ruptured and the transverse tear in the intima of the aorta, which is known as ladder rung tear. So what actually happens? The sternum and thoracic vertebra, between these we have aorta that compressed. So that is a torsion force. And the second, isthmus ruptures due to deceleration of injury, shearing and stretching force on the aorta. That will cause a tear, that is a transverse tear. And descending aorta, that is known as ladder rung tear. So again I am telling you, the first mechanism is osseous punch. That is, you can see, this is aorta that is compressed between sternum and vertebra. And if you see the descending aorta, because of deceleration, because of the shearing force, that is leading transverse tear. So that is a very, very important part. The isthmus is ruptured. So you can see there is an injury which is known as ladder rung tear. So if you see, isthmus is ruptured because of deceleration injury. So here answer is, what is the question and option? Rapid deceleration causing shearing at the aortic stimulus. Yes. Rapid deceleration causing shearing at the isthmus. So this is very, very important question. So again, here it is ladder rung tear at the isthmus area because of deceleration injury, and because of deceleration, shearing strain on the isthmus. That is a very, very important part. So two questions can come in an exam: ladder rung tear and shearing strain on isthmus causing isthmus injury because of deceleration. So these are some very, very important question, my dear friend. Again, I'm summarizing all the question again. First question, that is very important. You can see the question was, important question of the carboxyhemoglobin level and the cherry red discoloration. That was very important. Second, if you see the deceleration injury of the isthmus, that's a transverse tear. That is very important. The third, if you see the suspect ratio is more, so more evidences of suspect. Very, very important. Fourth question, if you see the two type of mixed pattern, the cause of death is undetermined. So these are the question. And fifth, adipose hair formation in few weeks to few months. Very, very important. Warm and humid climate, or body is in water or submerged in water. So these are some very important question of this exam, and very important pattern has been followed, my dear friend, in this pattern. So just go through these questions, which are very important. Explanation is given. This is all about this exam explanation. Okay. So good luck. Goodbye. Thank you very much.
Okay, so let us look at the questions that came in your exam. The first one, a case control study investigates the association between smoking and lung cancer. Among 100 lung cancer cases, 80 are smokers. Among 100 controls, 20 are smokers. Calculate the odds ratio and interpret its clinical significance. And you have four options. Now, we all know that whenever we talk about odds ratio, you all know that odds ratio is also known as cross product ratio, and it is calculated from a case control study. It is calculated from a case control study. Whenever you get a numerical, the first thing that you have to try to remember is the formula. So you know it's a cross product ratio, so it is AD upon BC. Now we need to figure out what is A, B, C and D over here. Okay, so now you have cases lung cancer and controls this thing. So here you will have lung cancer, here you will have no lung cancer. All right, as we make a 2 by 2 table, and over here you're going to have smokers, over here you're going to have non-smokers, smokers and non-smokers. Okay, now if you look over here, 100 lung cancer cases, so that means this is 100 lung cancer cases, 80 are smokers, so this is 80, right? And among 100 controls, so no lung cancer, so these are your 100 controls. How many are smokers, guys? 20. 100 controls, 20 are non-smokers. So now we know what was the order of ABCD. It's a Z, ABCD. So over here we have a we have a B, we have a C, we have a D. So C would become 100 minus 80, 20, and D is 100 minus 20, 80. Now what is odds ratio? It's a cross product ratio, which is AD upon BC. So 80 into 80 by 20 into 20. So this comes out to be how much? This comes out to be 16. Now you have an option where it is clearly written odds ratio is 16. And what does it mean? That it's a strong association. It's a positive association. So that's what we've calculated. Very strong association between smoking and lung cancer. So the correct answer is option A. Okay. Let's move to the next question for the day. It was in a clinical trial involving 200 patients. The treatment group N is equal to 100 experienced 20 events, while the control group N is equal to 100 had 40 events. What are the absolute risk reduction and number needed to treat? Now, basically, this kind of numerical can turn up in INI-CET, not very important for the other exams. So again, whenever you get a numerical, you have to try to remember the formula. So we know that absolute risk reduction is event rate in control group or control group event rate minus experimental group event rate. All right. And what is number needed to treat? It is 1 upon absolute risk reduction. So now all we need to do is figure out that what are given in the options to us, right? So over here, total there were 200 patients. The treatment group N was 100, experienced 20 wins, while control N was 140 wins. So what is the event rate in control group? So total there were 100 patients, they experienced 40 had adverse events, right? And in experimental group we had also 100 patients and they experienced 20 events. Now absolute risk reduction would be CER minus EER. That means 40 by 100 minus 20 by 100. You can do this very easily. It's 20 by 100. Always express it as a percentage. So 20 by 100 into 100, that will become what? Absolute risk reduction would become equal to how much? 20%. So any option that has 20%, yes, you have this one as 20%. So automatically you've got the answer. But otherwise also, guys, what is number needed to treat? It is always 1 upon absolute risk reduction. So it is what was absolute risk reduction? It was absolute, if you look over here, absolute risk reduction was 20 by 100. So it will be 1 by 20 by 100. So that would become 100 by 20. So that would be 5. So your correct answer was option A. Just need to recollect the formula and accordingly solve the answer. Okay. Moving ahead to the next question. Yeah, this again was a pretty decent. We've tried to give you certain numericals because, you know, now they are asking numericals. So I'm just trying to give you a way. You need to remember the formula and accordingly mark. See, in a foodborne outbreak investigation, 40 out of 50 individuals who ate potato salad developed illness, while 5 out of 150 non-eaters were affected. Calculate relative risk and attributable risk. Now, both of these things we know are calculated from a cohort study. Okay. Now, as soon as you get a question, you have to again remember the formula. So, relative risk or risk ratio is incidence among exposed divided by incidence among non-exposed, right? Incidence exposed by non-exposed. Now, if you look over here, incidence among exposed. So incidence among exposed. So who are the exposed? The people who ate potato salad. So who ate potato salad is 50, out of them 40 developed the incidence. So 40 by 50. And what is incidence among non-exposed? So if you do this, incidence among non-exposed, so over here 150 are non-eaters. So 150 did not eat, out who did not eat, 5 developed the illness. So 5. So now what is relative risk? If you try to solve it, it is nothing but the ratio of this, right? Which would become 40 by 50, okay, into 150 by 5. Okay. So this is definitely 3 and this, so we have relative risk 24. Now any option, of course we had an option over here, relative risk 24. But yeah, let me tell you how to calculate. See, you didn't actually had to go to calculate here, because if you were running out of time, because you already got relative risk, which was a pretty easy one, that it is 24. So automatically you could have marked D. But even if you get to calculating, you all know attributable risk. What is the formula? It is incidence exposed, okay, incidence exposed minus incidence non-exposed, incidence exposed minus non-exposed, divided by, guys, incidence exposed into 100. So now you have all the values, and if you solve it, it will come out to be like it's 95 and something around 96%. Okay, so over here the correct answer was option D. So you just had to remember the formula and accordingly solve it. Okay, even if you get one part of the formula, automatically you get the answer, right? Okay, moving to the next question. Now look at this. Now yeah, this might take a little bit of time. This is actually based on a theorem, but we're not going to solve it by that because it's difficult to remember. We have a way to solve such questions. Let me just make you practice once. See, in a population of 10,000 women where the prevalence of breast cancer is 1%, mammography demonstrates a sensitivity of 85% and specificity of 90%. If the woman receives a positive test result, what is the probability that she has breast cancer? So even if they did not mention PPV, you should know that if my screening test is positive, what is the probability of being actually positive if I'm tested positive, actually having the disease, is PPV. That's what we had to calculate. Now, when you get PPV, remember, I've always taught you PPV or NPV. PPV is everything positive, NPV is everything negative. So this will be TP upon TP plus FP and into 100. So we need all of these values. Now, what is given to us? Prevalence of breast cancer is 1%. Total population is 10,000, right? So how many women have breast cancer? How many women have breast cancer? Now that would be very easy to calculate. How many women have breast cancer? Prevalence is given as 1% and total population you know is 10,000. So that would be how much? That would be 100. So women who have breast cancer is 100. Now you know screening test, we have to make a 2x2 table. So column and rows. Disease always goes on the column side, right? Disease. So breast cancer, and here you will have no breast cancer, and here you're going to have screening test result, which is mammography, in this case positive, negative. Now again, what was the order, guys? A, B, C, D, and we've learned already that A over here is TP. First row everything is positive, this is FP. Second row everything is negative, FN, and this is TN. Now where are you going to place this 100? Women who have breast cancer. So is it A plus B or is it A plus C? So who have breast cancer, that means this is 100. Okay, and what have you been given? You've been given sensitivity. Now what is the formula for sensitivity? It is TP upon TP plus FN into 100, of course, into 100. So here you have been given this as 85. You have to find out this. You know TP plus FN is 100 into 100. If you do it, TP comes out to be 85. Automatically you will get FN. FN would be 50. Okay, now if this is 100, what about no breast cancer? So you have total 10,000 people, okay, in that 100 have breast cancer. So how many do not have breast cancer, guys? 9,900. So that is going to come over here. Right, that is going to come over here. Now we know that specificity. What is specificity? Specificity is Tn upon Tn plus FP into 100. So now you have been given specificity as 90%. You have TN. You have been given this value 9900 into 100. If you calculate it, guys, 99 into 90, roughly 9 9s are 81, 9 9s are 81 and 9. You have to just add up and you'll get this value. Okay, so that I have also showed you a table, like you this is 9900. Okay, so this you will get it 8910. That's how you do it. Over here it is 9900, so you had to calculate, you will get 8910. so if this is 8910, this is 9900, so if you do it a subtraction of this, what is it that you're going to get? You're going to get 990 for this one. You're going to get 990 for this one. Okay, so I know it's a little time taking question, but it's INI-CET, so we're just looking at the broader aspect. You got the prevalence and accordingly you had to calculate everybody. Okay, so this is it. So this is the formula that finally comes out to be PPV is going to be how much? TP upon TP plus FP into 100. So now you have this 85, you have this 1075, you're going to multiply it with into 100. So if you solve this question, you will get around 8%. Clear? So that is it. Okay, so you just have to make use of the formulas. You just have to try to do it. Okay, now look over here. A pharmaceutical company is evaluating a novel oncology drug. The new drug costs rupees 50,000 per month, extends life years by 3 months with quality of life 0.7. The current standard care costs 10,000 per month, extends life by 1 month with quality of life 0.5. So there are only relative costs and benefits. What is incremental cost effectiveness ratio? Now, why did I give you this question? Because last time they asked about this, and this time they could ask you about the calculation. So basically, when you have incremental cost effective ratio, you have certain steps to look at. So you have two types of treatment. So look over here. First, you have to calculate the total cost of each treatment, okay, for the new drug and for the standard care. New drug cost per month is 50,000. Duration of life extension is 3 months. So what is the total cost? It is going to be 50,000 per month. It's extending life for 3 months. So total cost would be 1,50,000. Standard care cost per month is 10,000. Okay, it's extending our life for 1 month. So total cost would be 10,000. Easy. Next, you calculate the quality for each treatment. How do you calculate the quality for each treatment? For new drug as well as standard care, you have to multiply the years of life extension by the quality of life value which has been given to you. For new drug, it's extending 3 months. That means you have to always take it in terms of years. So 3 by 12, 0.25 years. Quality of life that it's extending is 0.7 as it was written over here. Okay, so quality for the new drug is this one, 0.7 into 0.25. So you will get that answer. Okay, this could be asked as a separate question also. Similarly, for standard care, months that it added was 1 month. So 1 by 12, 0.8. Quality of life given 0.5. So quality for standard care would be so much. Now, next step that it is, we have to calculate the incremental cost and the incremental quality because of the new drug. So incremental cost would be total cost of the new drug minus total cost of the standard care, which was given to us, which we have calculated. Similarly, quali would be quali for new drug minus quali for standard care, which we have done. And the thing is, what is ICER? It is incremental cost upon incremental quali. So that would roughly come out to be this. So by rounding off, we get to the nearest value, which of course could be this much. Okay, see what they can do is next time they can just give you calculate ICER and they can give you that we have calculated some setup they can give, and they can just ask you incremental cost is this much, incremental quality is this much, calculate ICER. So you have to know it is incremental cost by incremental quality. Okay? Yes, now that's a very simple formula. Again, just wanted to share it with you because these are certain things that INI-CET is fond of giving. Calculate the infection rate you have to see for each group. For placebo group, it is the number of infections divided by the number of participants. Simple. For vaccine group, it is again the number of infections divided by the number of participants. Then for vaccine effectiveness formula, the rate unvaccinated minus the rate vaccinated by the rate unvaccinated. So you just have to put it in these and you will get the formula. Okay, so that's the formula that you have to use, and if you use it, your answer is 94.6% using formula. Got it? So just see, these were certain tricky questions that we've given you. Maybe they could give you an INI-CET, so just to give you a heads up for the question. All right, so that was it. Thank you so much. Have a good day and all the best for your exams.
Hi everyone, and welcome to this video solutions for the INI-CET ENT questions that you had taken for the Champions exam. So we will review all the ENT questions in this session so that all your concepts are clear before you go to the final INI-CET exams. So wishing you good luck, and I hope you've done all of these questions right in your practice exam. So the first question here states to you about a 45-year-old patient who develops stridor and dyspnea following thyroidectomy. So after a thyroid surgery, we always think about nerve injuries in ENT, and they're clearly mentioning to you that the patient has dyspnea and stridor, which should prompt to you in your head that there could be a possibility of bilateral RLN nerve palsy. Unilateral recurrent laryngeal nerve palsies do not cause any stridor. They can cause dyspnea, but stridor is the feature of bilateral recurrent laryngeal nerve palsy. So the first line, when you hear this in your head, you should be absolutely clear that are we thinking about bilateral RLN palsy, and then you go ahead and see the rest of the question. So the next part of the question says laryngoscopic findings are given to you in the image below. What is the most immediate and definite management of this condition? So if you see the laryngoscopic findings, you can see one vocal cord is in the midline position, the other one is in the paramedian position. So whenever the vocal cord is either in the midline position or in the paramedian position, the only thought that should come to your mind is RLN nerve injury, which is quite a common occurrence after thyroid surgery. And when you're talking about thyroidectomy and stridor, you should think about bilateral recurrent laryngeal nerve palsy. So what is the management of bilateral recurrent laryngeal nerve palsy presenting to you with a vocal cord in midline or paramedian position causing stridor? You have to first give an airway access, which is by doing a tracheostomy. So you will have to do an immediate tracheostomy, and then you will have to create a space for airway, which means that you're going to do the arytenoid removal, which is bilateral arytenoidectomy at 6 to 12 months, meaning initially you'll do tracheostomy and then you will wait to see if the nerve is going to recover and function. If it is not going to recover and function, then at the end of 6 to 12 months, you're going to do a bilateral arytenoidectomy. Once you have done that, you have created this much amount of space for air to enter into the subglottis and from there into the trachea. Now, there could be different types of surgery that we do for bilateral RLN palsy. When we talk of bilateral RLN palsy, we know that it can cause stridor. So we can do either bilateral arytenoidectomy, we can do chordectomy, we can do removal of the posterior 2/3 of one vocal cord to create an airway space. We can do chordectomy with arytenoidectomy. So one cord, 2/3 is removed, the posterior 2/3, and along with that we remove one arytenoid. This procedure where we do chordectomy plus arytenoidectomy, we call this procedure as Kashima's operation. So what is this called as? This is called as Kashima's operation. So these are different types of thyroplasties, which is also called as type 2 thyroplasty. So in type 2 thyroplasty, it could be bilateral arytenoidectomy, unilateral chordectomy, chordectomy with arytenoidectomy, which we call it as Kashima's operation, and which is why option A is the right answer. High dose corticosteroids won't help because you are not expecting that the vocal cords will go into abducted position to give airway because of steroids. Emergency cricothyroidectomy can be done if there is a stridor. So this can be partially right, but do you do immediately vocal cord surgery? No. You will do vocal cord surgery at the end of 6 to 12 months because you're going to observe if the nerve is going to recover. And if it recovers and the vocal cord starts to move and function, then very good, you don't have to do a further procedure. So you're going to give that 6 to 12 months of waiting time to see if the nerve is going to recover. Nebulized epinephrine and intubation, not possible, because intubation in the midline position of cord is going to be extremely difficult. In fact, after thyroid surgery, when you're extubating, you check the vocal cord position and then you extubate the patient, because if the vocal cords are in midline position, you will prompt the surgeon to do tracheostomy before you extubate the patient. So these are some key points that you should take in mind when we are solving any questions on thyroid surgery. Next, we have a question on a 65-year-old man who's presenting to you with gradually progressive difficulty in hearing, especially in crowded environments. Audiometry reveals the following findings. Which is the most likely etiology and management? So if you see here, this is a graph. Red color depicts the right ear and blue color depicts the left ear. So in both the ears, there is a decline in hearing as we go towards higher frequencies. So at 1000, 2000, 4000, 8000, if we see, the hearing loss is more as compared to 125 hertz, 250 hertz. So this downsloping type of a graph, which is bilateral. So whenever you get a bilateral downsloping type of a graph, it should prompt you about presbyacusis, which is age-related sensory neural hearing loss. And what will you do for it? Hearing aid fitting and auditory rehabilitation. Now, why not chronic otitis media? Because in chronic otitis media, there will be a conductive hearing loss where BC will be in the normal range, AC will be in the abnormal range, and there will be an airborne gap, which is not seen in this graph. Again, it is not otosclerosis, because here we again see the conductive hearing loss, and we see a dip at 2000 hertz in BC curve, which is called as Gerhardt's notch, which is not seen in the image that has been given to you. And it is not acoustic neuroma. Now, acoustic neuroma can also present to you with SN loss, but what's the difference? Acoustic neuroma is unilateral. Most often it is unilateral. Bilateral acoustic neuromas are seen only in neurofibromatosis type 2, and if they have not given you those features, then you have to think of presbyacusis, which is a very, very common condition as compared to acoustic neuroma. So with this, we know the answer is option D, presbyacusis. The next question says to you about a 25-year-old man who presents to you with after a road traffic accident with flattening of the left cheek, and there is periorbital ecchymosis and anesthesia over the cheek. The CT image is given to you and they're asking to you that what is the most likely diagnosis. A word has been mentioned here which is called as the step deformity. So whenever you see that there is a fracture involving the face causing flattening of the cheek, periorbital ecchymosis, and on the CT scan look at the zygoma here. This is absolutely normal, but look at the zygoma here, it's completely fractured and displaced, and you can also see the fracture in the posterior wall of the maxillary sinus. And when they use the word step deformity, this word step deformity should again prompt to you of zygomatic fractures. The most common is the nasal fracture, but you cannot see the nasal bones in the image, which is why you rule that out. The second most common is going to be your zygomatic fracture, which presents to you with a step deformity, and it is also called as tripod fracture because it will have fracture at the zygomatico-maxillary suture, zygomatico-temporal, and zygomatico-frontal suture, and it will cause flattening of the cheek. So these are important words, and the CT findings suggest to you that it is a zygomatico-maxillary fracture. LIFO2 is only maxillary fracture where you'll see a pyramidal fracture hanging off the maxilla, and they would probably give you a coronal view, not an axial view of the CT scan as given in the image. And orbital blowout fracture will present to you with teardrop sign, not a sign like this. So with this, we are sure of the answer, which is zygomatico-maxillary fracture. So let's see the next question. This is a question on a 42-year-old woman who's presenting to you with a 6 months history of vertigo. So when we talk about any question on vertigo, the first thing that we look for is the duration of vertigo. Is it associated with hearing loss and tinnitus or not? These two are mandatory things that you should look for in the question. So if we look here, the episodes of vertigo last for several hours. It is associated with a sensation of fullness in the ear with difficulty in hearing during these attacks. It is also associated with tinnitus, nausea. So this is prompting to us to a very important diagnosis, which could be Meniere's disease, where we see V, S and T. Vertigo, sensorineural hearing loss, tinnitus. And the audiometry typically will show you an upsloping type of a graph where there will be low frequency hearing loss. So we know all of this is prompting us towards the diagnosis of Meniere's disease. So now the answer for us is very clear. It is Meniere's disease or endolymphatic hydrops. Now why not other options? When we talk of vestibular neuritis, there is inflammation of only the vestibular nerve and the cochlear nerve is not involved. So here there will be no hearing loss. Also, very importantly, here the vertigo lasts for days and weeks together. So here we will see that there is a single long episode of vertigo and not recurrent or intermittent hours of vertigo. So here when we talk of vertigo in vestibular neuritis or labyrinthitis, there's a single but a long episode of vertigo. So this is ruled out. In benign paroxysmal positional vertigo, we see that the vertigo lasts for a few seconds to a few minutes and it's not lasting to you for a few hours. So this is also ruled out and it is not associated with hearing loss, because we see in the pathology there's displacement of the otolith in the posterior semicircular canal. The cochlea is not involved. So again, there is no hearing loss. Acoustic neuroma can have vertigo. It could be intermittent, recurrent. It could be there for initially in the initial period and later it is not present. So it could present to you with vertigo. It could present to you with tinnitus. It could present to you with hearing loss. But very importantly, here we see that low frequency is not seen, and here we would see unilateral hearing loss which is constantly present rather than fluctuating one. So they're telling to you during the attacks the patient is having difficulty in hearing, and it will be constant hearing loss, not a fluctuating one, which is why it is also ruled out. So this is a pretty simple question. I'm sure all of you got it right. So let's move ahead to the next question. A 45-year-old man presents to you with sudden pain and swelling of the right parotid region and the right parotid gland, accompanied by fever and purulent discharge from the Stenson's duct, which is the duct of the parotid gland. What is the most likely diagnosis and appropriate management? So whenever we think of sudden pain, fever and discharge, we're thinking of acute infections or acute conditions. We're not thinking of something that's chronic. So in my head, I'm thinking more of acute bacterial parotitis, and I would probably start off with antibiotics. HIV-associated salivary gland disease is not very common, will not present to you with sudden symptoms and not associated with fever and purulent discharge. It could cause to you parotid inflammation, which is chronic inflammation and not acute inflammation. Sjogren's syndrome typically presents to you with dry mouth, but very rarely presents to you with any purulent discharge or pain or fever. And of course, parotid tumor will not present to you with any of these symptoms, but with a visible swelling that we see on the cheek. So with this, we are very sure the diagnosis is acute bacterial parotitis, and you have to start off with antibiotics. Let's move on to the next question, where we have a 68-year-old male who recently underwent a total laryngectomy for laryngeal cancer and now develops a pharyngocutaneous fistula on the 7th postoperative day. After 3 weeks of conservative measures, the fistula shows no signs of closure and the output remains significant. What is the most appropriate next step in the management of pharyngocutaneous fistula? So what happens is, whenever we have removed the entire larynx, now between the skin and the pharynx that is lying behind, there could be a communication resulting in a pharyngocutaneous fistula. Now, often this kind of fistulas which are there for 3 weeks or more and have failed conservative measures will not heal by itself. We will have to do a surgery. We will have to close the fistula or repair the fistula using flaps. And of course, we want a pedicled flap because then the uptake will be better. But if you take a free flap, which is a non-vascularized flap, again the chances of failure could be present. So what do we take? We take the pectoralis major myocutaneous flap to close the fistula that is present between the skin and the pharynx. Why not conservative management to be continued? Because 3 weeks of conservative management has failed. I don't think it's going to work any further, so no point of doing any conservative management. Again, there's no role of hyperbaric oxygen therapy for this condition because this condition typically requires closure of the communication and hyperbaric oxygen has got no role. Esophagectomy is a morbid procedure and it has no role for pharyngocutaneous fistula because it's a communication high above the esophagus. So again, this is not the answer. So with this, let's move on to the next question. A 32-year-old professional singer presents to you with progressive hoarseness for 4 months. Video stroboscopy shows bilateral small nodules at the junction of middle third of the vocal cord. She is concerned about losing her career. What is the most appropriate initial management? So this patient is having hoarseness since 4 months. The patient has not come to you. And when you have examined, you are seeing that there is a vocal nodule because the patient is a singer by profession. And if you see that there is a nodule at the junction of anterior to middle third, that is a vocal nodule case only. The initial management for vocal nodule will always be voice rest and speech therapy. If this fails, then we go for microlaryngeal surgery. So this patient will definitely require voice therapy with speech pathology and vocal hygiene measures. We don't do it for 6 months. Absolute voice rest is given for 7 to 10 days, maximum 2 weeks. You don't give it for 6 months, okay? And then we train them on how to modulate and how to use their voice so that they don't develop these nodules. Immediate microlaryngeal surgery is not the treatment option. And botulinum toxin is given for spasmodic dysphonia and not for vocal nodules. So this sorts the question. Let's move ahead to the next one. A 52-year-old man presents to you with a hoarseness of voice since 3 months, and indirect laryngoscopy shows that there is a lesion confined to the middle 1/3 of the vocal cord. Biopsy confirms squamous cell carcinoma stage 1. The patient has got no nodal involvement or metastatic involvement. What is the treatment of choice in this case? So whenever we talk of laryngeal cancer, stage 1 and stage 2, if it is the primary cancer, a first timer, a patient developing cancer for the first time, stage 1 and stage 2, the treatment of choice will be radiation therapy. There is only one exception to this rule. What is that exception? The exception to this rule is if there is a lesion in the middle third of the vocal cord, then we will do microlaryngeal surgery because it's easily accessible. You can go and remove the lesion via one surgical procedure, whereas radiation requires multiple cycles. There will be no damage to laryngeal tissues or laryngeal cartilage, which can happen with radiation and does not happen with surgery. So all these factors considered, we take that for any lesion in the middle third of the vocal cord, we would choose to do a microlaryngeal surgery over a radiation therapy. But all other lesions, all the other lesions which are in stage 1 and stage 2, we would go for RT. Now stage 3 and early 4A, what would we do? We would go for chemo RT. And if it is advanced 4A and 4B, what will we do? We are going to go for total laryngectomy. So this is the basic way to understand the treatment for laryngeal cancer. And since the patient is in stage 1 in the middle third of the vocal cord, we are now going to answer it as microlaryngeal surgery. If it was not mentioned middle third of the cord and just stage 1 cancer, then you would have marked RT. And if it was stage 3, you would go for chemo radiation. Advanced 4A or 4B, you would have gone for total laryngectomy. Yes, so that's about this question. And I hope all of you understood all the important topics or questions that were tested during the Champions examination. Wishing you good luck. If you have any doubts, feel free to reach me out and I will be more than happy to help you all. Take care and all the best.
A very big hello to all my dear students. Let's discuss these ophthalmology questions here. Okay, coming to the first question. I'm not like very happy with this, but of course we are going to get questions where you are not very happy with the questions. So let's see what it is. A 45-year-old patient, so he's a middle-aged patient with high myopia, right? So he has high myopia, presenting with sudden painless loss of vision. Fundus examination is revealing the following characteristics. So all of you, what is the characteristic here? What do we see on a fundus examination? Let's see here. We are seeing a tear. Can we see this retinal break or tear here? So this is what we call regma or tear or break, right? So this is horseshoe shaped tear. And what we see is a gray reflex out here. And what is this gray reflex indicating? That there is a retinal detachment, right? Okay. So now we know what the fundus examination is telling us. Coming to what is the most appropriate surgical management priority in this case? Now, option 1, pneumatic retinopexy with SF6 gas injection could be an option. Why it can be an option? Because the brake is on the superior quadrant. When the brake is on the superior quadrant, revise your pneumatic retinopexy, where we are creating gas injection, creating a tamponade, and sealing the brake with a cryo. But of course, most important is posture management after the procedure. But since in this image, I can see a giant tear, I would better go for putting a scleral buckle, right? So I would say let us go for scleral buckle with cryotherapy. So the ideal answer here looks like scleral buckle. What is the third option? Observation with serial OCT monitoring. Of course, we are not going to sit on this and we are not going to observe. We have to take immediate action. Immediate pars plana vitrectomy with, of course, pars plana vitrectomy has a role if there is any vitreous hemorrhage or we are doing an RD surgery, right? He is a high myope. My mind goes immediately to pathological myopia. Any lattice degeneration, any break, whatever may be the reason, we can see in the image there is a break. Now, this is mainly a tear that is shown in the image, though we could have expected also some hole formation. I told you any regma can be a break or a hole, right? So that's why I'm not very convinced with the image in the question. But of course, if we are placed in this situation, how are we going to think about it? I am just guiding you with this. Okay? So in this case, what should you answer? Our answer would be because, of course, A and B both are correct. Nothing is wrong here, either A or B, but still we prefer B, right? Because the size of the break looks quite large, I will better go for scleral buckle, right? Okay, we come to the next question. He's a 40-year-old executive, okay, presenting with sudden central vision blurring, okay. He reports significant work stress and recent history of systemic corticosteroids for his asthma. Now, OCT, what is this OCT showing us? That there is a detachment which is only a foveal detachment. Can we see that? Because this is what is the diagnosis on OCT, all of you? I think we all know this. We are talking about CSR. So, OCT of the macula reveals the following findings. What is the most appropriate initial management? So, we all know in an acute case, CSR is self-limiting, whereas if it is chronic, we have to go for PDT. What are the options we have? Discontinue corticosteroids, observe for 3 months, consider PDT if persistent. Immediate anti-VEGF injection, emergency laser photocoagulation, vitrectomy with membrane peeling. We all know this. Obviously, our answer is A. So, why we have to discontinue steroids aggravate CSR. So, immediately discontinue. This could be one major factor why this patient is having this CSR, right? So, what we do is discontinue, and of course, we observe because majority of the cases are self-limiting, and if it is not working, then only we will see to the option of photodynamic therapy, that is PDT. Right, guys? Okay, we come to the next question. Next question says a 60-year-old man with angle closure glaucoma presenting with intraocular pressure of 28 despite maximum medical therapy with gonioscopy showing more than 270-degree peripheral anterior synechia. Fundus is revealing that he is an old case of glaucoma with a CD ratio already 0.8. What is the most appropriate next step? We have learned in angle closure glaucoma, what are things we have learned? That, of course, if we talk about the choice of treatment, it is or definitive treatment, it is peripheral iridotomy, but that is only when there is an element of pupillary block. Here the situation is, patient is having anterior synechia already, right? So, when there is a peripheral anterior synechia which is more than 180 degree, now we will not look at the option of peripheral iridotomy. What we have to go for is trabeculectomy. So, because of this, my answer would become trabeculectomy with mitomycin C. I hope you know why mitomycin C or 5-fluorouracil, to prevent any closure of the fistula that you have created during trabeculectomy. What is trabeculectomy? Which is you are making connection from anterior chamber to the subconjunctival space. Is this clear? Yeah. Therefore, laser iridotomy we will not mark. Of course, maximum therapy means 2 or 3 drugs therapy is more than enough. And of course, this is also wrong. So our answer would be this. We come to the next question. A 45-year-old female presenting with persistent headaches and galactoria, visual field testing showing bitemporal hemianopia. MRI is most likely to reveal what? The history itself is telling you, and what do you first of all tell me? What is this picture all about? So we are looking at, what are we looking at? Bitemporal hemianopias, isn't it? So if it is a bitemporal hemianopia and looking at the history, obviously what should be our answer? Should it be retinal detachment? We all know these are very simple options given. So I think the question becomes automatically very easy. Retinal detachment, if the superior retina is gone, we get inferior field defect, inferior retina, superior field defect. Please keep this in mind. So this is not an option. Occipital lobe stroke, we get macula sparing homonymous hemianopia. What is the picture here? Bitemporal. And glaucoma with advanced cupping, of course, this is none of the glaucoma. What do you get if there is a glaucoma with an advanced cupping? What should I expect? Arcuate scotoma, double arcuate, you remember all that field effects in glaucoma that you've studied, right? Yeah. So our answer becomes obviously pituitary adenoma with suprasellar extension. So go back to your anatomy. So pituitary adenoma, above that is your optic chiasm. Sorry, pituitary gland, and above that is your optic chiasma, isn't it? So any adenoma in the pituitary can affect the optic chiasma. When it is directly affecting the decussation of the two nasal fibers, what are we getting? We are getting a bitemporal hemianopia, right? Okay, we come to the next question. So next question says a 35-year-old presenting with 4-month history of blurred vision. Okay, photophobia and redness in the right eye with gradual onset. Slit lamp finding is given below. So what is the slit lamp finding which is given below is showing me? I can see mutton fat capes. I can see some posterior synechia which is giving an irregular look to the pupillary margin which we call festoon shaped pupil, right? Okay, so these are the mutton fat capes I can see at, right? And what I see here is your festoon shaped pupil. That means this is a frank case. Anterior uveitis is, all the features of anterior uveitis are in front of us, right? Okay. So once she is a 35-year-old with history of blurred vision, of course, all these features of anterior uveitis she is going to complain of. What are those? Redness, photophobia, blepharospasm, blurred vision, and so on. Now comes a very important point here, that the systemic workup is revealing hilar lymphadenopathy, elevated AC levels. Automatically we are talking about sarcoidosis. How does a sarcoidosis present? It is a granulomatous panuveitis. We know this. It's a granulomatous panuveitis. Okay, so what is the most appropriate treatment approach? First, topical steroids with systemic evaluation of sarcoidosis, antibiotics for infectious uveitis, immediate surgical intervention, observation without treatment. As I said, the question becomes automatically very easy when you look at the options. So here our answer is A, that is sarcoidosis. And don't forget candle wax drippings, right? The segmental venous sheathing of sarcoidosis. That is also your exam question. We come to the next question. He's a contact lens user with ocular pain and blurring of vision, right? So there is pain and blurring of vision. On an examination, central corneal thinning with intact epithelium, Descemet's fold, stromal. So once there is a Descemet's fold and stromal edema, it cannot be thinning. It has to be thickening, isn't it? But what we mean to say, what are we trying to hint on this? Any contact lens user, can you see what is the history all about? What is the finding telling you? There is edema, there are Descemet's fold. When do you get an edema? When there is break in the Descemet's membrane, when there is a compromise of the endothelial sodium-potassium pump, isn't it? So why is this happening? So majority of the time, if it is due to a contact lens wear, we have seen that we are talking about patients in keratoconus wearing some rigid gas permeable, or any trauma due to contact lens. This is leading to all this sequelae, and this is what is causing the high drops. What is high drops? When suddenly there is more edema in the cornea and water in the cornea due to the dysfunction of the endothelium, due to the tear in the Descemet's membrane, isn't it? So here What should be the management? Corneal eye drops, discontinue contact lens and start with hypertonic saline? Or is it a bacterial keratitis? Give fortified antibiotics, viral keratitis, antiviral, allergic conjunctivitis, antihistaminics. Again, the options have made your life very easy. Our answer would be corneal eye drops. Right? Okay, don't forget about giant papillary conjunctivitis, which is asked in exam, which can be one of the side effects of using soft contact lenses. Don't forget the most common infection after contact lens use is Pseudomonas. And don't forget that it is only the soft contact lens users who are prone to develop acanthamoeba keratitis. So these are some more important points and questions around this contact lens. Okay, next is a 68-year-old patient presenting with progressive central vision loss. There is a progressive central vision loss. Optical coherence tomography. So OCT is showing this picture. Can you see this macular hole? Typical picture of macular hole, isn't it? Okay, so we now know that this patient is suffering from macular hole. Naturally, his central vision is going to go down. Measuring 500 microns with surrounding cystic changes and vitreomacular traction is also there. What is the best surgical approach? Surgical approach of macular hole, of course, has to be pars plana vitrectomy with, if there is internal limiting membrane peeling required, and of course also add here tamponade. This is how we treat a macular hole. Pars plana vitrectomy with tamponade and ILM peeling. Okay. Of course, the other options that are mentioned have no role. Coming to the next question, a 70-year-old male is presenting with progressive peripheral vision loss. And on examination, IOP is 24 with even maximal medical therapy. Fundus photography. Okay, I can see a typical CD ratio. It's a cupping of the disc, and we can see nasal shifting of vessels, and we can also see that the cupping is significant of around 0.8. Isn't it? Okay. So once you know this, what is the most appropriate next step in the management of this patient? So if he is a case, so the one question was on angle closure, and now we are here. Again, tell me yourself, if maximum medical therapy has been done and you have to still manage, what can you do for an open angle? Either I could have done argon laser trabeculoplasty, right? But there is no option of laser trabeculoplasty. The option is laser peripheral iodotomy or regular monitoring. So what is the best next option? If we don't have the option of laser trabeculoplasty, we are going to go for trabeculectomy or tube shunt surgery, right? So trabeculectomy, along with that, you can go for set-in surgery, which I've taught you, where you can put a implant. Generally, the commonly used is AGV. But generally, implants may not be put in the single sitting. If there is a failure, then we can go for it. Anyway, the answer here would be option A. We come to the next question. It says 36-year-old man with advanced HIV infection is presenting with progressive blurring of vision, right? So below is the fundus image. What is the most likely diagnosis and appropriate management? So if you look at the fundus image here, this is what is your sauce and cheese retinopathy, right? And because this is sauce and cheese retinopathy, we are talking about CMV retinitis, where the CD ratio is also less. CD4 count, I'm very sorry, CD4 count is less, and which is correlated with the less CD4 count is your opportunist infections like CMV retinitis. This is what I meant to say. So here in this patient, progressive blurring of vision, less CD4 count, and typical diagnostic is your fundus picture, where we can see this is mainly necrosis and hemorrhage. It is the retinitis. Therefore, our answer becomes CMV retinitis. How do you treat it? Ganciclovir, foscarnet, and of course, for the HIV, we should start with HART therapy. What is HART therapy? Highly active antiretroviral therapy. Right, guys? So that would be the best option. Coming to the next question. Infant is born at 28 weeks of gestation and now at 36 corrected age, presents with leukocoria. Fundus examination shows a mass in the posterior pole. Now, this is a very confusing description because initially we start thinking in terms of retinopathy of prematurity, and then the question says that when the fundus examination is done, right, he is presenting with a mass in the any mass or growth in the posterior pole, what is the most likely approach? So naturally, if I am talking about a growth or a mass, we will answer here, that is retinoblastoma. And what should be the treatment here? So the best option is retinoblastoma enucleation. Please revise your retinoblastoma very nicely. And of course, if it had been a retinopathy of prematurity, we all know demarcation line, ridge formation, then neovascularization, subtotal retinal detachment and total retinal detachment. Right. So these were the questions. I hope you enjoyed the session and the discussion. Any doubts, you can directly DM me. Thank you so much. Stay blessed and keep smiling.
So this is a sort of an integrated question that they have asked you. Now, a 28-year-old woman in her third pregnancy, her previous two pregnancies ended in neonatal deaths due to renal failure. So there's some renal anomaly that is happening in the fetus. And current prenatal MRI reveals findings suggestive of renal abnormality. What is the most likely diagnosis and appropriate management? Okay. So this may look like a difficult question immediately. If you look at it, so this is radiology and obstetric, integration. So let's just rule out what it isn't, right? So for example, what you're seeing here, and this arrow is also pointing out in this image, as you can see, this is the fetal kidneys, they're in the abdomen, right? And there's also saying that it is, the fetus has a renal abnormality that they're clearly telling you. And they're pointing it out by the arrow also, as you can see. And this is the fetal lungs and this is the fetal kidneys. So much of, they've enlarged to so much size that they sometimes, fill up the abdomen also, they push the diaphragm up also, so they can become huge, right? So these are enlarged kidneys. So it's not renal agenesis. It's not Potter sequence secondary to renal agenesis. You know what Potter sequence is, right? You know what Potter sequence is when there is renal or Potter syndrome is. Potter syndrome is with renal agenesis, and sequence is when there is another cause apart from renal agenesis. But the presentation is that there is severe oligohydramnios or anhydramnios, and apart from that, there is lung hypoplasia, compressed facies, that syndrome that happens, right? Now again, with acute tubular necrosis also, the kidney should be shrunken. So it's not acute tubular necrosis in the fetus as well. So you can see here the appearance of the kidneys is that they are enlarged, right? So we have the fetal kidneys in this image. They are enlarged, right? And they are also cystic looking appearance, right? As you can see here in the image. On ultrasound, in this image it is not there, but on ultrasound they also look solid ground glass texture, enlarged kidneys with solid ground glass texture. Okay, so this is polycystic kidney disease, okay, presenting in the fetal life itself. So it's not autosomal dominant polycystic kidney disease, because autosomal dominant polycystic kidney disease, right, it manifests, later into adulthood, right, not in the fetal life. So it's autosomal recessive polycystic kidney disease. Diagnosis made. Now you know that these kidneys will not be able to produce urine in the fetal life, right? And that is why the pregnancy will be complicated by severe oligohydramnios, right? Pregnancy will be complicated by severe oligohydramnios or anhydramnios, and then the results and consequences of that, where lung hypoplasia is very, very significant, because they will have early onset severe oligohydramnios, because fetal kidneys start producing urine from, they start producing urine from 12 weeks onwards, but they become the main contributor of amniotic fluid volume from 18 weeks of gestation onwards. So such a long duration of time and almost nil amniotic fluid, right? So that consequences will happen. So especially when it is having this oligohydramnios, severe oligohydramnios, the prognosis is particularly very poor. So what do? We consider palliative care planning. What can we do? We can just counsel the patient. So what sort of palliative care planning would go into? I mean, if there is this anomaly that has been found in the fetus, one can consider MTP as an option, provided yes, the legal criteria is fulfilled. Okay, legalities we have to fulfill as per the MTP acts of the country. Other than that, please remember that it will be decision based on obviously the gestational age at presentation, whether it is fulfilling the legalities or not, right? Based upon the severity of the autosomal recessive polycystic kidney disease, because the more the severe the oligo is, severity of oligo, hydroamnios and hydramnios, then chances of pulmonary hypoplasia are there, right? So risk of respiratory failure is there, no? Risk of respiratory failure is there after birth due to pulmonary hypoplasia, right? So not one fact, but a lot of different factors will go into considering or advising MTP as an option. Okay, and sometimes couple may not choose an MTP, then serial ultrasounds for monitoring the amniotic fluid volume will be done, right? Steroids for giving for lung maturity will be given. Okay, and unnecessary early delivery is not really needed, right? But this is only when the pregnancy is continuing. Okay, now again an integrated question: obstetrics, pediatric surgery, radiology, right? Now 20-week fetal echo reveals hypoplastic left heart syndrome with mitral atresia, aortic atresia, hypoplastic ascending aorta. Parents request counseling regarding prognosis and what are the treatment options. What's the most appropriate advice to give? So parents are asking you, what are the options? You will have to tell them all the options, isn't it? Right? And you have to give the most appropriate among the lot. So again, don't be scared by the images. Okay, fetal echo is something that we really do not expect undergraduates to master or know. So if an image like this has been given, it will come with some text that will help you understand what it is, right? So don't be bothered about that. So the question is about hypoplastic left heart syndrome. Do you think that this is an anomaly or a structural anomaly that is going to spontaneously resolve during fetal development? No, right? Obviously. Now, do you think such a situation or such a condition would have a simple surgical repair? I mean, surgical repairs are simple for ASD, VSD now, right? But not for hypoplastic left heart syndrome, where a new ventricle has to be created, isn't it? So this surgical repair is available with excellent prognosis. This is not something that you will tell the parents. Now you will tell the parents, okay, there is an option for surgical repair. There are options available also, right? But those options available, they have their own limitations. Like for example, there is a 3-stage Norwood procedure. This is something that you must have read in surgery, maybe pediatric surgery. It's 3-stage Norwood procedure. A surgery which is complex, done in 3 stages, offers about 70% survival into adulthood. And if that doesn't work, or if that's not an option, heart transplant is an alternative, which is again a very difficult option considering, right? So, but these are definitely options. Right, this is about the prognosis and treatment options, right? Is the condition uniformly fatal? No, it is fatal without surgical repair. Obviously, if there is no surgical repair done for such a condition after birth of the child, then the condition is going to be fatal, right? But to say that it is uniformly fatal will not be an entirely true statement. I mean, conditions like anencephaly, for that matter, to give you an example, that is uniformly fatal. There is no surgical repair for anencephaly, right? So condition is uniformly fatal is not correct. However, yes, if the patient has been counseled appropriately, told that, okay, there is a procedure that has its own limitations, a heart transplant is an alternative, but that may not be always a choice and an option available and everything. So the couple may choose or may opt for a pregnancy termination, provided yes, the legalities and legal aspects of offering MTP gestational wise and taking into consideration when the diagnosis was made, right? So provided that is all fulfilled, yes, pregnancy termination is also an option that the couple can consider. But for now, in this question, the correct answer would be option number B. That would be your correct answer. A 28-year-old gravida 3 para 2 woman with 2 prior cesarean section undergoes ultrasound at 18 week, and the placenta is completely covering the internal os. So this is yes, placenta previa. And there is also a thick placental tissue, multiple lacunar spaces exhibiting turbulent flow. Right. So what is the diagnosis first of all? So the diagnosis is placenta accreta spectrum. It is placenta accreta spectrum, right? Morbidly adherent placenta. So it's a high risk pregnancy now. Do you think really routine prenatal care until term is advisable? You will have to, counsel the patient regarding the condition. It's no longer a routine situation at all. Right? Vaginal delivery, first of all, it is placenta previa, right? And it is very unlikely, you'll say that this is 18 week only now, later we can see. It's very unlikely that it is going to, the placenta is going to go upper segment, move to upper segment, or it is going to transmigrate later on, and it may not be a placenta previa eventually at term. It's very unlikely because this is 2 prior cesarean section. This is completely covering the os. It's a placenta accreta spectrum looking like on ultrasound images. The description is given to you. Can you see here? This whole thing is the placenta. This is the placenta. This is the bladder in front, right? And this myometrial thinning is there. Okay, and see this vascularity that is extending here, hypervascularity that is extending here into the bladder and the serosa interface. And you can see here lacunar spaces inside the placenta, this lacunar spaces inside the placenta. Sometimes this is also called as moth-eaten appearance of the placenta. So that is from the images, right? So with such a diagnosis, it is very extremely unlikely that the situation is going to change at term. And even then, with a morbidly adherent placenta, you will not allow for a vaginal delivery at all. So, and there's no question of delivering right now. What immediate cesarean delivery at 18 weeks? Out of the question. This option is redundant, right? So the answer is MRI for placenta accreta evaluation. Very good. And plan an elective cesarean section at 34-36 weeks with multidisciplinary surgical team, right? So MRI for placenta accreta evaluation is needed maybe for surgical planning purposes, right? Of course. It's needed for surgical planning purposes. Like for instance, we want to get an idea about whether it is perforating into the bladder, whether it has perforated the serosa, or it's just plain and simple accreta. So what is the depth of penetration? That information MRI will be able to give. So if I'm going for surgical planning, if I want to decide whether I want to have the urosurgeon with me also because it may be penetrating into the bladder, then I will make that decision accordingly. So that sort of surgical planning, right? So please remember here that when you have this placenta accreta spectrum, okay, now, whether the placenta is low-lying or in the upper segment, it doesn't matter as long as it is an accreta spectrum, okay? Then the location of the placenta doesn't necessarily matter. It is placenta accreta spectrum. That is what matters. You have to go for an elective cesarean section at a tertiary care center. Multidisciplinary approach, as I told you. Anytime between 34 to 37 weeks, we have to plan it. So, not before 37, beyond 34, between 34 to 37, we can plan. And also remember that the incision, the uterine incision is given away from the placenta, right? We do not disturb the placenta. We don't want to cut through the placenta. We don't want to do anything that may, get the placenta to start separating, right? So if it is in the lower segment, the placenta, then an upper segment incision will be given. Incision away from the placenta has to be given, right? And this is one of the indications of using an upper segment cesarean section, doing an upper segment uterine incision, right? The point is that you have to give it away from the placenta. Deliver the baby, right? Do not attempt to remove the placenta. Okay, we don't disturb the placenta. We cut the umbilical cord very close to the placenta, right? And we close the uterine incision. And that's not all. The one line that I'm coming to is that we proceed with a hysterectomy. This counseling has to be done to the patient. Very, very important that it just won't be a cesarean section. In that same sitting, one would proceed with the hysterectomy because, see, the moment the placenta tries to separate, for example, or we try to separate the placenta in bits and pieces, what will happen? It can lead to a lot of bleeding and then it would result in maybe an emergency hysterectomy. It's a very high-risk situation. No one wants to be in that situation. So the standard of care is this. The standard of care is to proceed with the hysterectomy. This is what is counseled to the woman. The only and only place for not proceeding with the hysterectomy or not doing a hysterectomy is when the woman expresses a desire that no, I don't want to go for a hysterectomy, and she understands the risks involved because she could end up with an emergency hysterectomy, or she could end up with she could end up with complications because we leave the placenta inside, and then later on infection, a hysterectomy, a couple of a secondary hysterectomy, couple of weeks or months later after surgery. So she has to understand all the risks involved and then make that decision that, okay, no, I'm not willing for a hysterectomy, right? Otherwise, this is the standard of care. Now, yet again, an integrated question from fetal MRI. Now, fetal MRI images, again, undergraduate students, we really don't expect you to know, but in case fetal MRI images are given to you, they would come with, some of the other information to help you crack it. Like, for example, here the fetal MRI shows a lumbar meningomyelocele, also shows ventriculomegaly and cerebellar herniation, that is Chiari 2. Okay, Arnold-Chiari 2 malformation. You know what Arnold-Chiari 2 malformation is. You read about it in embryology, all right. Now, the important thing is that there is cerebellar herniation, right? There's downward displacement of the spinal cord because of this lumbar meningomyelocele. There is downward displacement of the spinal cord, and there is cerebellar herniation. That means herniation of cerebellum from the foramen magnum into the upper cervical canal. That is what it means, right? So the neurological outcome is compromised because of the brain stem dysfunction that will happen as a result of Chiari 2 malformation, right? And you know that this is a type of neural tube defect, right? Now they're asking you what could be an appropriate prenatal management. Prenatal management means management before birth. Is it possible, right? See, meningomyelocele. Nowadays, there's a lot of discussion and a lot of, this is a growing field, that is fetal medicine, fetal surgery. Okay, it's not something that is very widely happening in the government hospitals or something, but yes, the fetal surgery is picking up, fetal medicine has picked up a lot, right? So meningomyelocele was one of the first conditions for which fetal surgery, fetoscopic fetal surgery has been attempted and has been found to be successful, right? So, in utero surgical repair of meningomyelocele, particularly when done before 26 weeks of gestation, has been shown to improve neurological outcome. So, they operate on the fetus in utero, right? So, in utero surgical repair, yes, it has been attempted. That could be a prenatal management strategy. Otherwise, yes, postnatal repair is an option. Postnatal repair after birth, after delivery of the child is an option, but it Even when we do postnatal repair for meningomyelocele, some or the other degree of paralysis, some or the other degree of bladder and bowel dysfunction, right? Developmental delays, inability to walk, they do still persist, right? To some or the other extent. So postnatal repair is also an option. Conservative management, I mean, when you have a diagnosis, like, there's no conservative management. You will gain one gains really nothing with doing serial ultrasounds or anything. And there's no need for immediate delivery also. Once MRI confirms GRE2, for the fetus's sake. Come to think of it, yes, MTP could be an option, right? The option of MTP is also there, okay? Yes, provided the option of MTP is also there, provided the legalities of MTP Act, they are fulfilled. And for now, here they are saying the question was specifically asking what could be an appropriate prenatal management strategy to improve neurological outcome. That would be option number A. So this specific that they had asked, okay. And many times, this option of in utero surgical repair doesn't exist for many patients. And then they choose MTP, and that's fine. MTP is allowed, right? 52-year-old postmenopausal, severe hot flashes, vaginal dryness, recent diagnosis of osteopenia. So she has all of these estrogen deficiency symptoms, right? As we can see, she's postmenopausal. So she is a candidate because of her symptoms in need of hormone replacement therapy. Significant past medical history was that she had an episode of DVT 5 years ago. She's not undergone a hysterectomy, so uterus is present. Which of the following is a possible hormonal management option for this patient? Which option could be considered as far as hormonal replacement or hormonal management option is considered, right? So estrogen therapy, systemic estrogen therapy, oral estrogen therapy is definitely contraindicated. So oral conjugated estrogen, estrogen only therapy without progesterone, conjugated estrogen with medroxyprogesterone acid, basically estrogens are not to be given. Oral systemic estrogens not to be given, right? And then we have option number A and C. Hormone therapy is contraindicated, absolutely, or transdermal estrogen with micronized progesterone could be a possible option. I would say it could be a possible option, transdermal estradiol with micronized progesterone. I'll just come to it in a bit. See, when there is a history of DVT, right, such a patient deserves medical review. Such a patient deserves medical review, to be reviewed by a hematologist as well, right? Because workup will be needed. What sort of workup do you want? I want to know why this DVT happened. Was it an isolated incident? What could be the triggering factor for DVT? Was it because she had undergone a surgery? Was it because she was bedridden for some duration? What was the reason, right? Was it an isolated episode, or was it thrombophilia related? Is she having inherited thrombophilias? How much is the risk? How much is her baseline risk of DVT basically? And other risk factors, other medical risk factors as far as venous thrombosis are there, they would also be considered, and thrombophilia, inherited thrombophilia would also be considered, and one would want to find out why this DVT happened, as an isolated incident, or maybe it was precipitated because of some acute event, or it is a recurrent tendency, right? So all that review would go. And then depending upon the risk versus benefit, one could possibly think about giving hormone replacement therapy, but then that does not have to be systemic. It has to be transdermal. It could be possible, right? So transdermal estrogen therapy. See, the benefit of transdermal estrogen therapy is that it avoids first pass metabolism in the liver, and therefore lesser risk for thrombosis, That is the advantage, right? So transdermal estrogen therapy, let's say for those at risk of venous thromboembolism, right? Let's say obese with metabolic syndrome, right? Let's say diabetic, let's say hypertensive, let's say smokers, but they are having troublesome symptoms that are not getting resolved by non-hormonal means, right? Troublesome symptoms that are not getting resolved by non-hormonal methods, and they want to go for hormonal replacement therapy, then transdermal estrogen therapy could be considered in these circumstances as an alternative, but only after assessing the risks versus the benefits. Okay. 32-year-old G2P1 and 39 weeks of gestation, history of one previous cesarean delivery. She's in active labor. 6 centimeter dilated, fetus vertex, estimated fetal weight is also fine. Now, she's on continuous electronic fetal heart rate monitoring. It is showing category 2 pattern. So remember, category 1 is reassuring, everything okay. Category 3 patterns are the ones which deserve immediate delivery, expedite delivery. Remember that category 3. What was category 3? It was, if there is absent variability, along with that, any of the following: absent variability plus fetal bradycardia, absent variability and persistent late decelerations, absent variability and persistent variable decelerations, right? So that persistent is the word here, right? Category 2 tracing are between category 1 and category 2. So whenever this category 2 trace, we first try the what? The interventions, right, which could correct the non-reassuring pattern. Now, which of the following is the most appropriate consideration for trial of labor after cesarean in this patient? So, in this patient, she's previous cesarean, she has a category 2 pattern. I'll have to counsel her on uterine rupture. I will have to tell her that now, I'll have to inform the OR. I'll have to put it on standby. I'll say, okay, I'm giving some time. I'm continuing the close monitoring, and the possibility of uterine rupture is definitely there. So, at any moment, this does not improve, I'm going to shift you up for, or I'm going to take you up for an emergency cesarean section. So, this is the most valid answer. Not an immediate repeat cesarean delivery. I won't choose that. I'll say immediate would have been the answer if they had specially mentioned category 3 trace. Like for example, if they had specially mentioned persistent late decelerations, right? Or the entire clinical profile, they had mentioned that there is some or the other diagnosis which would have made of impending scar rupture. If the clinical profile would have been such that the diagnosis of impending scar rupture or uterine rupture would have been there, then I would have said immediate repeat cesarean delivery. For now, the information in the question is also not completely given. They've only told you category 2 pattern, that's it. They've not told you other characteristics. They've not told you about whether the membranes are absent. They've not told you about what is the status of the, uterine contractions. They've not told you about whether there's any vaginal bleeding or leaking or meconium. So the entire clinical picture, it's, I wouldn't say is going in the favor of immediate repeat cesarean delivery. In fact, the entire clinical situation is going in the favor of me being prepared for the possibility of uterine rupture, keeping on OR standby, intensifying the monitoring, and doing a complete thorough investigation so that I don't miss out on any signs of uterine rupture or impending scar rupture. So that's my answer. Option A, I am justifying to you why I chose option number A instead of option number B. Augmenting labor with oxytocin is out, and Tolac is contraindicated with previous cesarean section. This entire statement in itself is incorrect. It's not contraindicated per se. The characteristics have to be right. The criteria has to be fulfilled, and then Tolac can be allowed. For now, option number A is correct. Please remember that whenever you have a patient like this, category 2 pattern, right? one would obviously give the IV fluid, start the IV fluids. Maybe she's dehydrated. That is why she's having a non-reassuring pattern. Check the blood pressure, correct the hypotension. Maybe she's hypotensive. That's why she's having these abnormal, maybe that is why she's showing some category 2 pattern. Put her on left lateral position, give oxygen by mask. If oxytocin is ongoing, stop oxytocin. Maybe she's having excessive uterine contractions, and that is the reason for her category 2 pattern, right? Maybe shifting to left lateral position. Obviously, it improves placental perfusion. Maybe there's some cord compression. Maybe she's lying down in supine position, and that is causing hypotension. Maybe there's cord compression, which improves on changing the posture of the woman, right? So you try these things. Meanwhile, one is prepping up, right? Fine. So for now, option number A is the correct answer. Now, this is more of a path genetics question rather than an obstetric question, but yes, the element of obstetrics is there. Let's see this integrated again. A couple with previous child diagnosed with cystic fibrosis undergoes genetic counseling during a subsequent pregnancy. History of 2 child affected, subsequent pregnancy now. CVS has been done, obviously. Right, when they have a previous child diagnosed with cystic fibrosis. Cystic fibrosis is an autosomal recessively inherited condition. If they have a previous child diagnosed, that in itself means both are carriers. Definitely, right? If they themselves are not affected, both are carriers, right? So genetic testing confirms that both parents are carriers. This I already know because there's a previous child with the diagnosis, and I know. So for this, you have to know that it is an autosomal recessive condition. That is the basic thing that you need to know in attempting this question, right? Now, there's subsequent pregnancy. So now in subsequent pregnancy, what is the risk of having an affected child with an autosomal recessive condition? You will say 25%. Autosomal recessive condition, both parents are carriers. You will say 25% of having an affected child. But the twist in the question is that they have integrated it with OPS. Now, with the 25% risk of being affected, what did the couple opt for? Chorionic villus sampling, prenatal, testing, invasive fetal testing already. And it is showing that the fetus has a mutation in 1 copy of the CFTR gene. The reason that they are doing this testing is so that they know that whether the child that they are carrying, it is in subsequent pregnancy, is affected or not. They are telling you fetus has mutation in 1 copy. So, if you look at it, you've not read the question thoroughly, you will pick option B as the answer. But for now, what is the likely risk for the fetus? So, the risk for the fetus has changed because we have done a CVS now. We know that only 1 copy is there. So, the fetus is not affected. We know now fetus is not affected, but is a carrier of the mutation that both the parents are also carrying. Okay. So, answer is option number C. A woman with PCOS presents with anovulation, infertility, BMI of 32. So, she is obese, fasting glucose of 110. What do we have to say about that? Impaired glucose tolerance, right? So, obviously, she is having a manifestation of insulin resistance that is responsible for this impaired glucose tolerance also. First line agent for ovulation induction. We've all read it's letrozole. So, letrozole is the answer. Gonadotropins are anyways second line. Laparoscopic ovarian drilling used to be done earlier, but nowadays not very preferable with IVF, right? Metformin plus letrozole. Letrozole is the ovulation induction drug. Metformin is for the letrozole is the ovulation induction drug, and metformin as insulin sensitizer. That is how metformin helps. So please don't think that women who are wanting to conceive, who are undergoing ovulation induction cannot take metformin. Metformin can be prescribed for them if they have features of insulin resistance, right? So again, metformin safe for women who are trying to conceive, right? So metformin plus letrozole is the best choice answer from the options that is given here, okay? 35-year-old woman, history of migraine with aura, presents requesting contraception. Other information like smoker, obese, no other comorbidities. But the important thing is history of migraine with aura. Absolute contraindication for oral contraceptive pills. Migraine with aura is category 4 for oral contraceptive pills. So combined oral contraceptives, no. NuvaRing is also a combined method. Contraceptive patches that are available, they are also mostly combined. The best is progesterone only method. Progesterone only method are going to be the safest and most appropriate contraceptive option for her from among the options provided. Okay. So for that matter, your COPTs, intrauterine devices, they can also be freely used, right? But from the options, obviously progestin only methods. Among the hormonal methods, estrogen is not going to be used. So estrogen is contraindicated. 30-year-old female, history of 3 consecutive first trimester abortions, recurrent pregnancy loss. Comprehensive workup has been done. Positive anti-phospholipid antibodies 12 weeks apart confirmed. This is diagnosis anti-phospholipid antibody syndrome. Further workup, karyotype of parents normal, hysteroscopy shows normal uterine cavity and anatomy. What is the most appropriate management strategy to improve the pregnancy outcome for such patients where there is a diagnosis of antiphospholipid antibody syndrome? It's low dose aspirin plus low molecular weight heparin together to be continued throughout the pregnancy. Right, so this is it. Now, not low dose aspirin alone, not low molecular weight heparin alone, but together. Okay, progesterone supplementation only. Progesterone supplementation, no role here in these circumstances. Corticosteroids for immunosuppression, again, no role. Second line, so this is the first line and the preferred choice, right? Second line is, yes, IV immunoglobulins, right? That is second line. Plasmapheresis has also been attempted and tried, but the outcomes of these are not that great as far as improving pregnancy outcome is concerned. The one thing that has been shown to consistently improve the pregnancy outcome in pregnancies complicated with antiphospholipid antibody syndrome is low dose aspirin plus low molecular weight heparin, and no intervention is absolutely an incorrect option. 28-year-old primey at 26 weeks of gestation, monochorionic diamniotic twin pregnancy, routine follow-up. Ultrasound shows oligo in donor twin, poly in the recipient twin, and abnormal Doppler studies. So it's not just oligopoly. It's now Quintero stage 3 with abnormal Doppler. So this is twin-to-twin transfusion syndrome that deserves treatment now. And I mean, as long as it was just stage 1, that is just oligo and poly, one could keep under close follow-up, right? So this follow-up is not an option. It needs some treatment. And the best treatment, the most appropriate treatment strategy is fetoscopic laser ablation of the anastomosis, right? And what happens is that entire, like for example, this is the placenta, these are the anastomoses which are shared between the two twins, right? Entire equator. So this is what is called as equatorial ablation technique, also called as Solomon technique. Okay, this is the one that is preferred. Okay, fetoscopic laser ablation. Now, most of the times twin-to-twin transfusion syndrome present between 16 to 26 weeks. Okay, and till 26 weeks, fetoscopic laser ablation can be very safely done. Some people like to do it or extend it till 28 weeks also, but around this time, right? So between 16 to 26 weeks is a very good enough time to do this fetoscopic laser ablation for a diagnosis of twin-to-twin transfusion syndrome to improve the pregnancy outcome for both the fetuses. Right. Now, what about the other? Immediate delivery, the preterm, 26 weeks immediate delivery, no. See, if this situation would have arisen when the fetus viability was there, then one could have thought of immediate delivery. Right now, no immediate delivery. Serial amnioreduction, selective fetal reduction, what are these? You see, serial amnioreduction, what does it mean? It means reducing the amniotic fluid from the twin that is having polyhydramnios. Why would I want to do that? It is not taking care of the situation at hand. Is it dealing with anything with the underlying cause or improving the outcome? The only way it helps, serial amnioreduction, that means it has to be done repeatedly, weekly, maybe twice weekly, maybe. It's just a temporary measure for symptomatic polyhydramnios. For symptomatic polyhydramnios, maybe, right, with a hope that maybe preterm labor can be prevented. See, it's just hopeful. Okay, if it is going to be too much of a polyhydramnios, uterus is over distended, twins are also there, preterm labor will be precipitated, and then outcome for the babies is going to be compromised. So, serial amnioreduction is an alternative after 26 weeks. Right? If the laser ablation is not done, but see, it is not taking care of the underlying situation at hand. That is why fetoscopic laser ablation is the best. And that is also the reason why when we have monochorionic diamniotic twins, they have to have monitoring. They have to have repeated scans from 16 weeks onwards, every 2 weeks. They need more frequent scans, no? So that early diagnosis of twin-to-twin transfusion syndrome can be done. Okay. Now, what about selective fetal reduction? Selective fetal reduction. That means sacrificing one twin. Which one twin? The one that is probably anyways going to die, so that the other can be saved. Now, that is extreme circumstance. That is only and only, let's say, when the death of one twin is just about to happen, is imminent, and there is prematurity also, and there is extreme prematurity also. So, because what will happen if one twin will die? This is monochorionic diamniotic twins. If one twin dies, the other surviving twin is also at risk of dying, is also at risk of suffering, severe neurological impairment and injury. So, with the hope that, okay, if we, selectively reduce the one twin that is anyways going to die, we may buy some time for the surviving twin with hope of, getting a few weeks more because there is prematurity. So, don't muck them up. Try to understand them, okay? And this is only for INI-CET purposes, because see, there's no one clear-cut answer as far as management of TTTS is concerned. It's a very high-end condition, rare condition that undergraduate students don't tend to see it. So you need to be aware that, okay, serial amnioreduction is a possible option, selective fetal reduction under certain circumstances could be an option. And there are times when couples, when there is extreme prematurity is there, couples sometimes also choose the option of termination of pregnancy. Maybe when the diagnosis is made later in pregnancy, there's still a chance that early delivery could save the fetuses, right? So, all of those are case-to-case basis. Undergraduate students, please know that fetoscopic laser ablation is the best treatment right now that is available, preferably done somewhere between 16 to 26 weeks around that time. Till that time, it is generally preferably done. So, this you should know. 25-year-old nulliparous diagnosed with ER-PR negative HER2 positive breast cancer. All this information not relevant in attempting the question. Thing is that she has breast cancer, she needs chemo. She expresses a strong desire for future fertility and wishes to conceive biologically. Given her diagnosis and urgent need for chemo, what's the most appropriate and optimal fertility preservation surgery? What do you think? Fertility preservation strategy, for such a woman. So embryo freezing only. I mean, embryo freezing, you would need a sperm also for that. And she's 25-year-old nulliparous. So this is out. Okay, GnRH agonist during chemotherapy. Now, not during chemotherapy, you want to do something before the chemotherapy. So, oocyte cryopreservation is available, definitely, right? Egg freezing techniques have improved, right, after ovarian stimulation. So, even though she has a history of breast cancer, the important thing is that the one thing that is important, it is ERPR negative, the hormone receptor negative. So that is kind of reassuring, where, you know, ovarian stimulation one could give without thinking about the risks for the cancer itself. So that's why oocyte cryopreservation after ovarian stimulation is fine to do in this patient, and no options available is not correct. So options available are there. During cesarean section, a patient develops uterine atony with 1500 blood loss. So whatever. So she's already lost 1500. Unresponsive to uterotonics, B-Lynch compression sutures. They have been attempted. Bleeding is not controlled. Woman is hemodynamically unstable. Massive transfusion protocol has been initiated. What's the next step? You won't just sit on it. So massive transfusion protocol only out. Balloon tamponade, hypogastric artery ligation. What balloon tamponade? You'd already put a uterine compression suture, has already been put, right? So you already made the choice of a compression suture over a tamponade. So this is out, right? So compression sutures have been done. Okay, compression sutures, B-Lynch sutures have been placed. The choice is between hypogastric artery ligation. This is internal iliac artery ligation, which, you know, just think about it. Okay, just think about it. Retroperitoneal dissection has to be done. Then the ligation has to be done on both the sides. Time it will need. And what is happening? Failure to control the bleeding, unstable patient, the transfusion protocol, massive transfusion protocol has been initiated, right? So just think about it. By the time something is done, maybe the woman will end up with DIC. Think about it. What is the principle of hypogastric or internal iliac artery ligation? It works by promoting thrombosis in the circulation there in the pelvis. Why? Because it converts the arterial into the circulation of arterial dynamics into venous dynamics, slows the blood flow, promotes thrombosis. With DIC setting in, it doesn't work. It can fail. That is why, obviously, DIC, anything has to be simultaneously corrected. But I'm just making you think that in the face of massive bleeding, massive hemorrhage, where you're expecting DIC to set in, and with DIC, or when the thrombosis itself is like with DIC, the internal iliac artery ligation will not work. So two reasons: A, this, and the time, and also it has lesser utility with atonic PPH, right? As far as hypogastric artery ligation, internal iliac ligation is concerned. So considering all that, I would say the best choice is to proceed with a hysterectomy straight away. Okay, so better answer is proceed with the hysterectomy, because the woman is unstable and, you know, bleeding is still not controlled, uterus continues to remain atonic. You know, you need to do something which is going to save the woman's life immediately. So in these circumstances, I think proceeding with hysterectomy is the best choice answer. 32-week pregnant woman, chronic hypertension. Now she develops proteinuria 3 gram per 24 hours. So this is significant. Yes. So proteinuria present now. And she's 32-week pregnant. So she is beyond 20 weeks and elevated liver enzymes also, blood pressure 160 by 110, most appropriate diagnosis and management. See, this is not HELP syndrome, at least you're certain of that. Hemolysis, elevated liver enzymes, low platelets, all the characteristics are not mentioned in the question. So this is not the answer. It's chronic hypertension for sure. That is already mentioned in the question, but is it only chronic hypertension? It's not only chronic hypertension. It's not severe chronic hypertension also. It's not falling in the severe chronic hypertension only range, because severe would be more than 160 by 110 at least. That severe chronic hypertension would be reaching that blood pressure ranges. So the diagnosis is not there. What is the diagnosis? It is superimposed preeclampsia. Why? Because now beyond 20 weeks, a known woman with chronic hypertension is developing proteinuria. They have not mentioned new onset proteinuria, but I'm assuming that they're talking about new onset because they have not mentioned what was there earlier. And also elevated liver enzymes is one of the end organ changes also, right? So I would say it is superimposed preeclampsia, right? And admit, obviously. You need to start antihypertensives also. You need to give corticosteroids for lung maturity of the fetus. Why? Because now early delivery may be needed any time. She's already having superimposed preeclampsia. She's already 32 weeks. So you admit, yes, you would want to at least buy time for steroid cover to act, and then in the meanwhile, you will do the complete workup also. You will send the LFT, elevated liver enzymes are already given, but you will at least have a workup of the kidney function test. You will also, go for the fundus examination for such a patient. You will also evaluate the fetus also for fetal well-being also, right? So all that you will do. And you will be prepared that early delivery may be needed any time. You will also want to watch for signs and symptoms of impending eclampsia in a patient with superimposed preeclampsia, right? So remember here with chronic hypertension, whenever there is a pregnant woman with chronic hypertension, she needs a complete workup also. Isn't it? She needs a complete workup also. We need to send the CBC, LFT, KFT. This we do for hypertensive patients anyways. 24-hour urine protein, right? Apart from that, an ECG. Because chronic hypertension is there, no? So the baseline status of chronic hypertension, baseline status of the chronic hypertension per se needs to be checked. Okay, hypertensive cardiopathy, ECG problematic, symptomatic patient, whatever. So echo if needed. Okay, ultrasound KUB. Why a young woman will have chronic hypertension? So if there's a renal problem there, so ultrasound KUB baseline, right? Baseline fundus examination, fundoscopy, that needs to be done. So this is obviously baseline, and then one needs to have a close watch in a pregnancy. This is a high risk pregnancy. One keep a watch for signs and symptoms of superimposed preeclampsia. Okay, how do you diagnose superimposed preeclampsia? When there is new onset proteinuria or new onset any end organ change beyond 20 weeks in a woman who's already or a known chronic hypertensive, right? Now, what about the treatment? What about the, sorry, not the treatment, management. Management again will have to be close watch, right? Monitoring for maternal and fetal well-being, watching for signs and symptoms of superimposed preeclampsia, right? Blood pressure control and everything, and timing of delivery basically. So when the uncomplicated cases are there, uncomplicated cases are absolutely uncomplicated, only chronic hypertension is the problem, then you deliver anytime between 37 to 38 weeks basically. Between that time is fine. So like for example, if she is on drugs, blood pressure is controlled on drugs, then 37 weeks. And if she is not on any drugs, then 38 weeks also we could go. Remember this broad range, 37 to 38 weeks. Earlier delivery may be needed for complicated cases. Earlier delivery, case to case basis for complicated cases. Okay. And also remember, if there is superimposed preeclampsia, if there is superimposed preeclampsia, then management will follow the same principles as preeclampsia. Goal is to at least go till 34 weeks, at least go till 34 weeks. So, if there's superimposed preeclampsia, the management goes along the lines of preeclampsia, more or less. 28-year-old woman presents with preterm labor at 32 weeks, cervical dilatation of 2.5 centimeter. So, this is established preterm labor. She's already established in preterm labor. Best management to promote fetal lung maturity. Why do you want to look at other options? It is administer antenatal corticosteroids and start tocolysis. She's 32 weeks. You want to buy time to give her to complete the steroid cover. She's established preterm labor. And intratracheal surfactant therapy in utero, no, this is surfactant therapy is usually reserved for after the child is birth. Withhold steroids. Steroids are not contraindicated before 34 weeks. They're supposed to be given before 34 weeks. And the one important contraindication for steroids is if there's established chorioamnionitis. Otherwise, you give steroids before 34 weeks, right? And use tocolysis even if cervical dilatation is more than 4 centimeters. See if she is well established in labor and she's in active labor, I won't want to give tocolysis. So, this is wrong, right? So, correct answer is option number B. A 32-year-old pregnant woman with gestational diabetes, not controlled on diet alone, weight is 70 kg, and they're not mentioning the gestational age, but it is immaterial. Which of the following is the management? So, diet is not controlling, she's 70 kg, she's GDM. What do you want to do now? When it is sugars are not controlled or diet alone, where do you go? You go to drug therapy. What is the drug of choice? It's insulin. Plain and simple, that is your answer. Insulin 0.7 to 1 unit per kg per day, that is usually the starting dose, right? Weight-based regime, and then it has to be titrated accordingly. Whatever the total dose is calculated in the day, it has to be given, then distributed, before breakfast and before dinner, right? So that adjustment needs to be done. So she needs to be admitted to be started on insulin. She's a case of gestational diabetes, so you would say oral metformin is also the option. It is safe for GDM. For GDM, metformin, even glyburide. Glyburide is the same as glibenclamide, that's the same. They are considered safe. Okay, safe to start with, right? But insulin is the drug of choice. And I've kept only if insulin is there, insulin is the drug of choice, and these are not your answers, though metformin and glibenclamide, that is glyburide, are considered safe for GDM cases particularly, but insulin is anyways the drug of choice for sugars that are not getting controlled or diet alone during pregnancy, right? So that's your answer.
Hello dear students, so we'll be discussing the pediatrics questions that were there in this INI-CET Champions exam that you took. So starting with the first question, we had a 6-month-old infant. So a 6-month-old infant who presented with hypoglycemia, hepatomegaly and lactic acidosis during an intercurrent illness. Okay. So this hypoglycemia, hepatomegaly and lactic acidosis, all these point towards an underlying, metabolic disorder which is involving the liver. Hepatomegaly is also there. And hypoglycemia is there, that means this is a disorder of carbohydrate metabolism. So, with these findings, and we go ahead, a glucagon stimulation test shows no rise in blood glucose, okay? So, all these findings still now point towards a diagnosis of glycogen storage disorder type 1, that is Vaughan-Jarecki disease. And liver biopsy reveals glycogen accumulation. That further, confirms our diagnosis. So, which enzyme deficiency is most likely and what is the appropriate emergency management? So, here we are dealing definitely with Vaughan-Jarecki disease. Vaughan-Jarecki disease or type 1 glycogen storage disorder. Which is the enzyme deficient? So, it is glucose 6-phosphatase enzyme that you can see in option A. Glucose 6-phosphatase enzyme, and because there is hypoglycemia, you will need to give IV dextrose. To prevent further episodes of hypoglycemia, frequent feeding would be required, and we would ask the patient to avoid fasting for long hours. Cornstarch diet may also be given. So our best answer is glucose 6-phosphatase deficiency. It is not debranching enzyme deficiency, because in debranching enzyme deficiency, what happens? If you give glucagon in a fed state, there will be rise in blood glucose. But in fasting state, there will be no rise in blood glucose, right? And moreover, Cori disease or debranching enzyme deficiency also involves the muscle. But here in this question, you cannot see any muscle involvement. So B is not the correct answer. Again, liver phosphorylase, we will not think of here, because hypoglycemia, this lactic acidosis, all these are most commonly seen in von Wieren's disease. And of course, glucagon therapy we do not use for von Wieren's disease, we know. And here in the case scenario, you can see that giving glucagon is causing no effect, causing no rise in blood glucose. So this is not the answer. And again, acid maltase deficiency we know is seen in Pompe disease. And in Pompe disease, you have skeletal muscle as well as cardiac muscle involvement. So there will be cardiomegaly, features of heart failure, which are not there in this question. So again, that is not the correct answer. So A, von Wieren's disease is the best answer. Now let us see why, this lactic acidosis and other manifestations are there in von Wieren's disease. So as we know, in von Wieren's disease, there is deficiency of glucose 6-phosphatase. So glucose 6-phosphate cannot get converted to glucose. Hence, there is hypoglycemia, right? Hypoglycemia. Now, excess of glucose 6-phosphate is accumulating in the body, and by pentose phosphate pathway, excess of ribose 5-phosphate, excess of uric acid is formed. So you have hyperuricemia, okay? Hyperuricemia. Excess of glycolysis is also taking place. So excess of pyruvate and excess of lactate is getting produced. So you have lactic acidosis. Lactic acidosis. Excess of acetyl-CoA is getting produced, which is a raw material for all the lipids, for cholesterol as well as fatty acids, triglycerides. So you have hyperlipidemia as well. So that is how you can explain all the findings that we get in von Wieren's disease, okay, or type 1 GSD. Moving to the next question, what we have here is a 7-year-old boy, okay, who presented with multiple daily episodes of sudden staring and unresponsiveness lasting 10 to 15 seconds. So there are multiple daily episodes of sudden staring and unresponsiveness followed by immediate recovery. So there's no, state of drowsiness or anything after that. So this is a typical description of absence seizures, okay. So absence seizures is our diagnosis here. Let us complete the question. So his teacher reports frequent lapses in attention during the class, and an EEG or electroencephalogram was done which showed this pattern. So let us magnify it and see. So you can see that in this EEG, you can see typically what is known as 3 Hz spike and wave pattern. 3 Hz spike and wave pattern. So you can see a spike and a wave, then a spike and a wave, and a spike and a wave, and so on. So there is a typical 3 Hz spike and wave pattern that you get in absence seizures. And we all know the drug of choice for absence seizures in India, we most commonly use valproate. In the West, ethosuximide is used. And this type of seizure has got a very good prognosis or outcome. So our best answer here is ethosuximide or valproic acid. So first line treatment is being asked in expected prognosis. So ethosuximide or valproate is the first line treatment. It has excellent prognosis with 80% remission by adolescence, right? Moving ahead to the next question. So what we have here is a 5-year-old child who has 3 weeks of fever, headache and vomiting and progressive altered sensorium. Now in a country like India, wherever an illness with fever is lasting for more than 2 weeks or more than 10 days, we definitely think of TB as one of the possibilities. Now fever, headache, vomiting, altered sensorium, all these point towards involvement of CNS. So tubercular meningitis becomes a strong possibility here. Now CSF analysis shows lymphocytic pleocytosis. So there are 200 cells, predominantly lymphocytes. Glucose is low, 25 mg per dl. Protein is elevated, 150 mg per dl. And CSF microscopic smear shows the following finding. What do you see on CSF microscopy? So can you see here? What do you make out? So let us take a closer look. So you can see these are AFB, acid-fast bacilli. So if you can see AFB on staining, or you can demonstrate, Mycobacterium tuberculosis by CB-NAT, your diagnosis is confirmed and it is tubercular meningitis. Now, because if it is tubercular meningitis, of course, we need to give ATT or anti-tubercular therapy. Now, we know that in the intensive phase, we need to give HRZE, right? So you have to give 4-drug therapy. And normally we give ATT for 6 months, but if it is CNS tuberculosis, we need to give ATT for 9 to 12 months. And initially, we also need to give steroids to decrease the inflammation and the neurological findings. So, what is the correct treatment regimen is being asked? So, the best answer is option A, that is RIPE therapy. So, RIPE here is nothing but an acronym for rifampicin, isoniazid, pyrazinamide, and ethambutol, plus corticosteroid for 9 to 12 months. We are not thinking of acute bacterial meningitis here, so ceftriaxone and vancomycin, no. We are not thinking of viral encephalitis, so acyclovir not required, and fluconazole for fungal meningitis is not indicated either, right? Moving ahead, you have a 10-year-old who presents with, so a 10-year-old child presents with polyuria, polydipsia, and 15% weight loss over 2 weeks. So polyuria, polydipsia, and weight loss, okay? So, and what else? You have a blood glucose of 450 milligram per dl. So, in the presence of hyperglycemia, that means this child definitely has diabetes. What else? So, you can see the pH is 7.25. That means there is acidosis. Bicarbonate is low, 12 milliequivalents per liter, and ketone is positive. So, our diagnosis here becomes DKA or diabetic ketoacidosis. Now, diabetic ketoacidosis, let us talk about it first a little bit, then we'll come back to the options, okay? How do you diagnose DKA in children? So, there has to be a hyperglycemia, that means a blood glucose of more than 200 milligram per dl. There should be acidosis, that means if you do a blood gas, you will find that the pH is less than 7.3 or serum bicarbonate is less than 18. And there should be evidence of either ketonemia or ketonuria, okay? All these three need to be present to call it DKA. So, hyperglycemia, acidosis, ketonemia or ketonuria. So, a diagnosis of DKA is made. Then what you need to do? You need to categorize the severity. We call it severe DKA if the pH is less than 7.1, bicarbonate less than 5. Moderate DKA when the pH is between 7.1 to 7.2 and bicarbonate 5 to 10. And in our case, it is mild DKA because the pH is between 7.2 to 7.3 and bicarbonate 15 to 18. So, in any case of decay, there is a lot of dehydration. In mild decay, we assume 5% dehydration, moderate 7% and severe 10% dehydration. So, the first treatment for any child with decay, remember, it is not insulin. It is fluid therapy. So, you start fluids, okay? So, you give normal saline. So, usually we give 10 to 20 ml per kg over 1 hour. So, the first thing after ABC, airway, breathing, circulation, you will start fluids in decay, right? After that, after the first hour of starting fluid, we start insulin therapy. Which insulin? We use regular insulin, okay, which can be given IV or intravenously as an infusion, continuous infusion. When to start, we said? So, we need to start it when? So, we need to start it after 1 hour of initiating fluid therapy, okay? And the dose at which we start. So, the dose is 0.05 to 0.1 unit per kg per hour. Remember, there is no role as such of insulin boluses. So, insulin bolus is usually not recommended, right? Okay. So, coming back to our options. So, here we do not have a doubt that the child is suffering from decay, okay? It is mild to moderate decay. So, what will you do? Oral rehydration and metformin, will it suffice? No, the child has already landed into decay, so it will not. Immediate high dose insulin bolus, we said there is no role of insulin bolus in decay, and the first thing that you have to give is fluids and not insulin. IV fluids and then insulin 0.1 unit per kg per hour appears to be the best answer. Observation until pH normalizes is not going to help. So, option C is the best answer here. Okay. Now, moving ahead. So, we have a 3-year-old child. So, a 3-year-old child who presents with acute onset stridor. Stridor means we are dealing with some upper respiratory problem. Drooling of saliva and prefers to sit in the tripod position. Okay, so has a lot of respiratory distress. The temperature is 102 degrees Fahrenheit. So, high grade fever is there. A lateral neck X-ray reveals the characteristic thumb sign. So, thumb sign that you get in X-ray suggests a diagnosis of acute epiglottitis. So, it is the swollen epiglottis that appears like a thumb on a lateral X-ray. I'll just show you a picture and then we'll come back to the options. Okay. So, you can see here. So, this is the thumb sign. It appears like a thumb on the lateral X-ray neck. So, this is a thumb sign that you get in acute epiglottitis. And what is here that you see? So you see a airway narrowing here. So this is called the steeple sign. So if there was a steeple sign, you get it in croup or acute laryngotracheobronchitis. And this thumb sign you get in acute epiglottitis, as in the question here. Okay, acute epiglottitis. Now, there is a difference in the management of these two. That is why it is important to diagnose them. We'll be moving to the management, but you can see that in acute epiglottitis, the epiglottis is so swollen it appears cherry red. So, it is called cherry red epiglottis. Okay, cherry red epiglottis. Right? Okay. Now, what are the differences in the etiology, clinical presentation and management of these two disorders where you get stridor? So, croup is a viral illness. The most common cause is parainfluenza virus. Parainfluenza virus. On the other hand, acute epiglottitis, it is a bacterial illness. Previously, in unimmunized children, the most common cause was believed to be H. influenzae. But now in the pentavalent vaccine, everybody is getting immunized against H. influenzae. So now the most common cause has become streptococcus. So it is the most commonly, it is bacterial in origin, right? Most common is streptococcus in the immunized population. Clinical presentation, croup will be just like a viral illness, any viral illness. So there will be low-grade fever, malaise, coryza, and then of course there will be stridor. But acute epiglottitis is a very severe illness. Bacterial illnesses are usually more severe, more dramatic in presentation, right? So acute epiglottitis, the child will be sick, toxic looking, high grade fever, drooling of saliva, so the child is not able to swallow his or her own saliva. There could be hypoxia in severe cases and severe airway obstruction can be there. X-ray we already discussed. In croup you get the steeple sign and in acute epiglottitis you get the thumb sign, right? The treatment, croup, because it is a viral illness, no role of antibiotics. So what do? So supportive care is same for both. That means do not agitate the child, take care of the airway. If required, start oxygen, start IV fluids. Apart from that, in croup, we give single dose dexamethasone, even in mild cases. And in moderate to severe cases, we also give nebulized epinephrine. Okay. While in acute epiglottitis, apart from supportive care, you need to give IV antibiotics. Usually we give third generation cephalosporins like ceftriaxone. Okay, because it is a bacterial illness, right? So coming back to our question. So this 3-year-old child has got acute epiglottitis. Now what should be the appropriate next step in management? Do not agitate the child, secure airway, IV antibiotics, that appears to be reasonable. Immediate intubation in emergency department. We will not do immediate intubation unless the child is becoming hypoxic and there is severe airway obstruction. So no. Racemic epinephrine nebulization alone will not help because this is not croup, this is acute epiglottitis. Oral examination with tongue depressor again would agitate the child further. We do not want to do it. We have enough evidence to call it acute epiglottitis. So option A is the best answer here, right? Moving ahead, a newborn presents with central cyanosis and poor feeding. Okay. Echo shows detransposition of great arteries. So it is TGA with intact ventricular septum. What is the most appropriate initial management? Okay. So let us first try to understand what happens in TGA, DTGA or transposition of great arteries. So transposition of great arteries, the basic defect is that the great vessels are transposed or are arranged in reverse order. That means in TGA, what happens? In TGA, from the left ventricle normally what arises? Aorta. But in TGA, what will come? Pulmonary artery. So pulmonary artery arises from the left ventricle and aorta arises from the right ventricle. So that is the basic defect that happens in transposition of great arteries. Now, what is the problem if this happens? Let us try to understand the circulation. Okay. So the pathophysiology of TGA. Okay. So what happens is, from right atrium. So from right atrium, we know the blood goes to the right ventricle. Okay. From right atrium to the right ventricle. Now, from right ventricle, normally what arises? Normally, pulmonary artery arises. But this is TGA. So what will arise? So from right atrium, the blood goes to right ventricle And from right ventricle, because it is TGA, pulmonary artery will not come, there will be aorta that comes. From aorta, the blood goes to all the organs of body. And the deoxygenated blood comes via the superior and inferior vena cava. And where does the superior vena cava, inferior vena cava drain? We know it drains into the right atrium. So blood started off from the right atrium, came back to the right atrium without going to the lungs. Now let us see what is happening on the left side. So on the left side, left atrium, the blood goes from left atrium to left ventricle. Normally from left ventricle, what comes out? Aorta. But this is TGA, what will come out? So pulmonary artery. So pulmonary artery blood goes to the lungs. From lungs, the pulmonary veins bring back the oxygenated blood to the left atrium. So blood started off from the left atrium, went to the lungs and came back to the left atrium without going to the rest of the body. So you can see that there are two parallel circulations that are going on. One circulation where deoxygenated blood is going on, one circulation where oxygenated blood is going on. So this is a disease where you get parallel circulation. Now this will become incompatible with life unless unless what will happen? Unless there is a communication between these two circulations at any level. So it becomes incompatible with life unless you have a ASD or a patent foramen ovale at the level of atria, or at the level of ventricle you have a ventricular septal defect, or at the level of aorta or pulmonary artery you have a PDA. So any of these should be there to make it compatible with life. Okay. Now if a child has TGA with intact ventricular septum, so if there is no ASD, no VSD, that means intact ventricular septum, no PDA. So what will happen? The child will become symptomatic at birth. There will be cyanosis, heart failure. What can you do as an emergency measure? So as an emergency measure, what we can do is there's something called balloon atrial septostomy. Okay. So what can we do as an emergency measure? We can do balloon atrial septostomy or Rashkind procedure. So what we do here is, so what we can do as an emergency procedure is we can do something known as Rashkind procedure or balloon atrial septostomy. So what do we do there? Let us see. So in this, what happens? This is the right atrium. This is the left atrium. Okay. And there is no mixing of blood at any level. That is causing problems. So what we do? We take the baby in the cath lab. We introduce a catheter from the right atrium through the foramen ovale into the left atrium. And what we do is we inflate a balloon. Okay. So we inflate a balloon and then we pull this catheter out. So iatrogenically we make a big hole in the atrial septum. So the mixing of blood of two sides will take place now. So the baby's symptoms will get temporarily relieved. So you can do balloon atrial septostomy or Rashkind procedure as a temporary relief. But the definitive treatment, of course, is the arterial switch operation, where you will cut off the great arteries and connect them to their actual position. That means you connect the aorta to the left ventricle, you connect the pulmonary artery to the right ventricle. And in X-ray in a child with TGA, you can get something known as egg on side appearance. Egg on side appearance, right? So moving back to our question, what is the most appropriate initial management? So we said it is going to be Rashkind procedure and then arterial switch operation. It is also called Jetain's repair. So that is the best answer. Norwood procedure is required in hypoplastic left ventricle, not here. Medical management with prostaglandins only can tide over for some while, but not a very long time. Okay. Heart transplantation is not the answer. You can do, this Rashkind procedure and this surgery, arterial switch operation with good results. So option A is the best answer here, right? So what we have next is a premature infant born at 28 weeks of gestation who develops respiratory distress and increasing oxygen requirement on the 10th week of life. So this baby even 10 weeks after birth is requiring oxygen therapy. Now if such an extremely preterm baby born at 28 weeks of gestation, if we give oxygen therapy for a significant amount of time, the baby can develop what is known as chronic lung disease or BPD, that is bronchopulmonary dysplasia, because of the oxygen free radical damage and if you've done assisted ventilation because of atelectotrauma, barotrauma and so on. Chest x-ray showing bilateral diffuse infiltrates. What is the most likely diagnosis and what is the appropriate treatment? So of course, this is not a pneumothorax, right? Because we are not, in pneumothorax, the chest X-ray will not show diffuse bilateral infiltrates. We know we'll get black areas without, bronchovascular markings, without pulmonary markings, okay? So pneumothorax is not the correct answer. Pneumonia again would be, the baby would be septic and you will get some blood parameters which are suggestive. There could be tachypnea and so on. So pneumonia is not the correct answer. Bronchopulmonary dysplasia, optimized ventilation appears to be the best choice. Patent ductus arteriosus, if it would have been there, then you would have got a murmur and hemodynamic instability would have been there, right? So bronchopulmonary dysplasia, as we already mentioned, also known as chronic lung disease, and it is due to the atelectotrauma, the barotrauma, volutrauma, and free radical injury to the lungs due to the oxygen supplementation. So oxygen is a double-edged sword for these babies. You need to give it also, but it does lung damage as well. So BPD is defined for babies born at less than 32 weeks gestation, like in this question, 28 weeks gestation, who require oxygen for at least first 28 days of life. That means first 4 weeks. And here the baby required oxygen for 10 weeks, right? And assessed at 36 weeks PMA or beyond. Now, mild BPD would be no supplemental oxygen required. Moderate BPD, oxygen required, but if to less than 30%. Severe BPD would be oxygen requirement is higher, or CPAP or mechanical ventilation requirement. So here this baby falls in the moderate to severe BPD category. Okay. The next question, a 3-day-old neonate presents with cataract, jaundice and hepatomegaly. Cataract, jaundice, hepatomegaly. So jaundice and hepatomegaly tells me liver is involved. Cataract means some metabolic disorder probably which is involving the eye as well. And this is a small neonate, okay. The urine shows positive reducing substance and culture grows E. coli. So positive reducing substance, that means it is a disorder of carbohydrate metabolism. Which disorder of carbohydrate metabolism causes cataracts? Yes, it is galactosemia. And in galactosemia, the chances of infection by E. coli are quite high. So which enzyme deficiency is most likely and what is the definitive management? So of course it is galactosemia. The classical variety is caused by deficiency of GALT or galactose 1-phosphate uridyl transferase. So A, galactose 1-phosphate uridyl transferase and strict lifelong galactose-free diet is the best answer. It is not glucose 6-phosphatase Von-Guillac disease. We already saw a case scenario. We will not get cataracts there. Fructokinase deficiency again and aldolase B also, you will not get cataracts, right? And the baby will be symptomatic only when fructose is introduced in diet, that is at 6 months or beyond usually, okay? So galactosemia can be due to deficiency of any of these three enzymes, galactose 1-phosphate uridyl transferase, galactokinase or epimerase. And milk in any form, we know milk has lactose. Lactose is a disaccharide that breaks down to glucose and galactose. And this galactose is not getting digested and is causing the problem. So any milk or milk product the child takes, there is a problem. So the baby can have manifestations like seizures, mental retardation, intellectual disability, bilateral oil drop cataracts, sepsis with E. coli is common in these babies, and hepatic manifestations like jaundice, hepatomegaly, GI manifestations like diarrhea, vomiting, and failure to thrive. The treatment, of course, is lifelong lactose-free diet. So you can use lactose-free formulas that are available during the initial few months, and once the child has started complementary feeding, you can use all sorts of food items, but avoid milk and milk products. Okay. Moving ahead, you have a 4-year-old child here who presents with fever, neck stiffness, and photophobia. Fever, neck stiffness, photophobia, it points to a diagnosis of possibly meningitis again. CSF analysis reveals 500 cells with 90% lymphocytes. So lymphocytes are predominant. Proteins of 80 and glucose of 45. So proteins are not very high, glucose is not very low, but on the lower side, and lymphocytic predominance. So we'll think of a viral cause here. Okay. So viral meningoencephalitis. What is the most appropriate empirical treatment while awaiting PCR results? So out of the various viral meningoencephalitis, the one for which we have a definitive treatment available is HSV, herpes simplex virus, and we can give injection acyclovir. So whenever we are suspecting a viral meningoencephalitis, we definitely start acyclovir to give the child the benefit of doubt. So observation without treatment will not help. Ceftriaxone, bacterial meningitis, vancomycin, we are not thinking of bacterial meningitis here because lymphocytic predominance and proteins are not very high, glucose not very low in the CSF. Acyclovir for suspected viral encephalitis appears to be the best answer. Fluconazole for fungal meningitis, we're not thinking because the child is not immunocompromised or anything, so we're not thinking of fungal meningitis here. So the CSF analysis in children gives us some clue towards the underlying etiology. For example, in acute bacterial meningitis, you will have a lot of cells and polymorphonuclear cells like neutrophils will predominate. Protein will usually be elevated 100 to 500 and glucose will usually be decreased to less than 50% of the blood glucose. What about viral meningitis or meningoencephalitis? Cell count might not be very high, it will usually be less than 1000 and mainly mononuclear cells or lymphocytes. Proteins usually not very high, glucose may be normal or decreased. Tuberculous meningitis, on the other hand, you can get cells between 10 to 500 or even more. And early phase, you can get polymorphonuclear cells, but later lymphocytes predominate. The proteins are usually very, very high, can go in thousands, okay? And the glucose is less in most of the cases. So here we are thinking of viral meningitis or meningoencephalitis, so IV acyclovir we add empirically, even before the results are available, okay? Now for vaccine vial monitor, identify the incorrect statement. So we know vaccine vial monitor is this circle and a square-like thing that you see here. It is a thermolabile material. It indicates whether the vaccine has sustained any cumulative damage due to cumulative heat exposure or not, okay? So if the color of the inner square is lighter than the outer circle, we can use the vaccine. So we can use this vaccine, we can use this vaccine. But if it is same color, if the color of the square is same as the outer circle or darker than outer circle, we cannot use it, okay? Let us see the questions. So you have to identify the incorrect statement, okay? Use the vial if inner square is lighter than the outer circle. Inner square lighter than the outer circle, we can use the vial, that is correct. Use the vial if inner square starts to change color but is still lighter than the outer circle. That's also correct. Use the vial if inner circle is same, inner square is same as the outer circle. No, we cannot use. Discard the vial if inner square is darker than outer circle. That's correct. So the incorrect statement here is option C. I hope there's no confusion on this one. Okay. Now what we have here is a newborn infant who presents shortly after birth with central cyanosis, tachypnea, and a prominent systolic ejection murmur best heard in the left sternal border. So central cyanosis, tachypnea, systolic murmur, echocardiography confirms the diagnosis of tetralogy of Fallot. And because it is presenting in the newborn period, it must be severe tetralogy of Fallot. Otherwise, usually tetralogy of Fallot presents in the later part of infancy or beyond. So there is severe right ventricular outflow obstruction. What is the most appropriate initial management, medical management for this neonate to improve systemic oxygenation? Now, whenever tetralogy of Fallot is severe, it becomes a ductus dependent lesion. And in ductus dependent lesions, if we want to improve the saturation of the baby, we can give prostaglandin E1 to keep the ductus arteriosus open. Immediate complete repair might not be feasible. First, you have to stabilize the child. Balloon valvuloplasty will not be the answer because there are other abnormalities in tetralogy of Fallot as well, right? Heart transplantation again is usually not required because we have other treatments available. So prostaglandin E1 or alprostadil is the answer of choice here. Now, ductus dependent congenital heart diseases can be either ductus dependent systemic circulation or ductus dependent pulmonary circulation. So let us have a look at some examples. So ductus dependent systemic circulation means when the systemic circulation is dependent on ductus arteriosus. So let us try to understand it. This is a right atrium, right ventricle, and this is a pulmonary artery. And you have the left atrium, left ventricle, aorta. Now, ductus dependent systemic circulation means there is some obstruction in the systemic blood flow, and so the blood from the pulmonary artery. So there is some obstruction, so the blood from the pulmonary artery has to go via ductus and circulate and spread to rest of the body. Okay. So the examples would be, what obstruction can be there? So examples can be when, there is critical aortic stenosis. So there is a critical aortic stenosis here. So blood is not able to go to rest of the body. So blood has to come via ductus from pulmonary artery. Similarly, severe coarctation or narrowing of aorta. Blood cannot go to the rest of the body. Similarly, interrupted aortic arch, or what happens when a left ventricle has not developed only. So these are conditions where you have ductus dependent systemic circulation. What about ductus dependent pulmonary circulation? So if there is some obstruction to the pulmonary blood flow, so it can happen that there is severe pulmonary, stenosis, or severe tetralogy of Fallot, or pulmonary atresia, or some problem at the level of tricuspid valves like tricuspid atresia or Epstein anomaly. So in these conditions, what will happen? The pulmonary blood flow will not happen properly. So what will happen? The blood from aorta has to come via ductus and go to the pulmonary circulation. Okay. So these are examples of ductus dependent pulmonary circulation. So you can see severe tetralogy of Fallot is an example of ductus dependent pulmonary circulation. So giving PGE1 in the initial phase in severe tetralogy of Fallot may help in improving the saturation of the baby, right? Now, a term newborn presents with poor feeding. Term newborn, poor feeding, marked hypotonia. Hypotonia, that means muscles are involved. Absent deep tendon reflexes. Genetic testing reveals a homozygous deletion in SMN1 gene. So our diagnosis becomes SMA or spinal muscular atrophy. So which of the following is the most probable diagnosis and what is the preferred treatment strategy is the question. So Duchenne muscular dystrophy we will not think of here. Duchenne muscular dystrophy has got a X-linked recessive inheritance. And it usually does not present in the newborn period. It usually presents later in life. There will be calf muscle pseudohypertrophy, Gowers sign positive, progressively increasing muscle weakness, and so on. Okay. Usually hypotonia is not so severe. Spinal muscular atrophy appears to be the best answer. And you have gene therapy with ONA-SEMNO gene, AB parvo-vec. So parvovirus is the vector here. It is a gene therapy. It is traded by the name of Zolgensma. So that is one of the recently approved treatments for SMA. So that is the best answer here. Myotonic dystrophy we will not think of here. We are not getting any features of myotonia or delayed relaxation of the muscle. Congenital myopathy also we will not, suspect here because we already have a genetic diagnosis of SMN1 gene deletion. So SMA, as we mentioned, it is also a progressively, debilitating neuromuscular disorder. It has got autosomal recessive inheritance and it is due to homozygous deletion in the SMN1 gene, survival motor neuron gene 1 on chromosome 5, right? And you have some newer treatment modalities available for SMA. So you have nusinersen or Spinraza, which is to be given intrathecally. Okay. Then you have Zolgensma or the ONA-SEMNO gene with the parvovirus vector that is given IV. It is a gene therapy. And you have a newer oral drug available which is called Risdiplam or Evrysdi. So these are the newer drugs available in the treatment of spinal muscular atrophy from which you can expect questions. Okay. Another question that we had here, a 3-year-old boy who was brought to emergency department after accidental ingestion of multiple iron tablets. And he showed vomiting, diarrhea. So iron causes a lot of GI toxicity. Serum iron level was 450 microgram per dl. The normal serum iron level in children is usually 50 to 120 microgram per dl. So here we can see it is elevated. So we're dealing with a case of iron poisoning. So if there is iron poisoning and the blood levels of iron have already increased, giving activated charcoal or gastric lavage or supportive care is not going to help. You need to chelate that iron and get it excreted from the body. So you have to use desferrioxamine chelating therapy. Other iron chelators that you know of, what are they? So in thalassemia, you must have studied some other iron chelators like deferasirox, okay, and deferriprone. But out of these, the one that can be given parenterally is desferrioxamine and that is the most efficient one. So that is preferred, okay. The next question that we have here is an infant who presents with recurrent seizures, global developmental delay, urine that has a characteristic sweet maple syrup odor. So, of course, we are dealing with a case of maple syrup urine disease. So, organic acid analysis demonstrated elevated methionine but markedly increased branch chain amino acids. Which are the branch chain amino acids? Leucine, isoleucine, valine. So we know there's a problem in the metabolism of branch chain amino acids in maple syrup urine disease. So in the treatment, you have to do dietary restriction of branch chain amino acids. So the question is asking which enzyme deficiency best explains. So the best option is option A, branch chain alpha keto acid dehydrogenase. So it is a maple syrup urine disease requiring dietary restriction of the branch chain amino acids. Phenylketonuria does not present in this way. You will not get the maple syrup odor. You will get hypopigmentation, hypertonia, and so on. Alkaptonuria again will present with urine turning black on standing and ochronosis. Tyrosinemia will present with hepatic involvement usually. Okay. The next question that we have here, a 2-week-old newborn with poor feeding, tachypnea, echo shows a large VSD with pulmonary hypertension. What is the recommended management? So if it is a large VSD, pulmonary hypertension has again begun to develop, then we need to operate the child early. Now, immediate surgical repair might not be possible in a 2-week-old newborn with poor feeding and tachypnea. You need to stabilize the baby first. So the best answer here would be medical management with diuretics and ACE inhibitors, and then surgical closure before 12 months to prevent Eisenmenger syndrome. Because once Eisenmenger syndrome or irreversible changes have developed, then there's no point of doing surgery. So immediate surgical repair might not be possible. Pulmonary artery banding alone is not going to relieve the symptoms. Heart transplantation is usually not required. So VSD, there's a medical management, that is the treatment of heart failure with diuretics, digoxin, and there's a treatment of pneumonia as and when it occurs, and nutritional rehabilitation. Surgical management is required if the heart failure is not improving and if the pulmonary blood flow is more than double of systemic blood flow. You can either do a device closure or a Dacron patch closure. And we want to do the closure before the development of Eisenmenger syndrome. What is Eisenmenger syndrome? Eisenmenger syndrome basically refers to reversal of shunt. So this reversal of shunt can happen in a child with VSD or ASD or PDA, but it is due to irreversible pulmonary vascular obstructive changes. Okay, let us see what happens in Eisenmenger syndrome. It's pathophysiology. So in a ventricular septal defect, to begin with, it is a left to right shunt. So there is excess of pulmonary blood flow. Initially, because of this excess blood flow, there's hyperkinetic pulmonary hypertension. Slowly, irreversible pulmonary vascular obstructive changes develop. Now, once these irreversible pulmonary vascular obstructive changes are developing, the right ventricle has to become hypertrophied to pump blood into the pulmonary circulation. So pressure in right ventricle goes on increasing, and a time comes when the right ventricular pressure becomes more than the left ventricular pressure. Then what will happen? There will be a right to left shunt instead of left to right. What will happen across a VSD if there is a right to left shunt? So if the blood is going from right ventricle to left ventricle, what will happen? Lesser blood will go to the lungs. Lesser blood will get oxygenated. So there will be cyanosis and clubbing. So a child with VSD might develop cyanosis and clubbing if the baby lands into Eisenmenger syndrome. Okay, and we need to operate the baby before that. Okay. A 3-year-old child presents with low-grade fever, coryza, inspiratory stridor, and barking cough. Again, upper airway disorder we are dealing with. Okay, and low-grade fever, coryza, that means it's a viral illness. X-ray AP of the neck shows a steeple sign. We already saw what a steeple sign looks like. So our diagnosis here becomes croup or acute laryngotracheobronchitis. What is the appropriate treatment in a moderate to severe case? So in a moderate to severe case, we mentioned that apart from single-dose dexamethasone, we'll give nebulized epinephrine. So nebulized budesonide only is not the best answer. Single-dose dexamethasone plus nebulized epinephrine, yes. Intravenous antibiotics not required because it's not a bacterial illness. And oral antihistaminics alone will not help. So our best answer is B, right? The last question, I believe, which you had from pediatrics. So, a 2-year-old child admitted with chest infection suffers from febrile seizure lasting 6 minutes. What is the most appropriate initial management? Now, as such, a febrile seizure does not require long-term anti-epileptics. But if a febrile seizure is lasting more than 5 minutes, you will treat it as status epilepticus. So, you have to abort the seizures using IV short-acting benzodiazepines. So, the best choice would be IV lorazepam. Okay. So febrile seizures, what is it? So febrile seizures is basically seizures in a child with significant fever. By significant fever, I mean a temperature of more than 100.4 degrees Fahrenheit. Okay, significant fever, a temperature of more than 100.4 degrees Fahrenheit without any evidence of CNS infection and in the typical age group of 6 months to 5 years. That is what is febrile seizure. It can either be simple or complex. Simple has GTCS, complex febrile seizures are focal seizures. Simple lasts for less than 15 minutes, complex lasts 15 minutes or longer. Simple, you have single episodes in an episode of fever, while in complex febrile seizures, you can have recurrent episodes of seizures, right? Okay. Management of febrile seizures, if they are lasting less than 5 minutes, what you do is you just lay the child in recovery position. Do not give anything orally. If the seizures are still continuing, what you can do is you can give buccal or nasal midazolam. Midazolam nasal sprays are available, you can use that, or you can give rectal diazepam. So that is the home management. But if a child is brought to hospital and the seizures is continuing for more than 5 minutes, you will have to treat it as status epilepticus. And you have to abort the seizures. You have to take care of the airway breathing circulation and abort the seizure using IV lorazepam. And if it persists, then you will have to think of giving anti-epileptics. Usually it is not required. Okay, right? So febrile seizures, no long-term anti-epileptics are recommended. You just abort that episode of seizure if it is prolonged, and you can give intermittent prophylaxis with clobazam if required, right? So these were the very important questions that came from pediatrics in your champion INI-CET exam, and these remain important for your upcoming INI-CET exam. I'm sure you'll do very well in the upcoming exams. All the best.
Hi guys, this is Dr. Pritesh Singh, your surgery faculty. Let's start the discussion of surgery questions. First, you can see question number 1 here. 70 years old patient presents with Charcot striate. So here the patient is having Charcot striate. Can you tell me in which condition Charcot striate is positive? Obviously, it's the cholangitis. So patient is having cholangitis. There is altered mental status, fulfilling the Reynolds pentad. So you know that both Charcot striate and Reynolds pentad, these are positive in cholangitis. Here you can see MRCP, and MRCP confirms the biliary obstruction. What is the immediate management priority? Immediate management priority. So first see this MRCP, what you can notice that here these are the sites of filling defect, and you can see these are the sites of stone. So there are multiple stones obstructing the CBD. Whenever a patient of cholangitis is brought to your emergency, first we resuscitate the patient, and after that we try to relieve the obstruction. And what is the easiest way to relieve the obstruction in emergency? Tell me. Obviously by ERCP if the stones are there. So see the option number 1, IV antibiotics and delayed intervention after 48 hours. No, we are not going to delay the intervention for 48 hours. Option B, emergency cholecystectomy with CBD exploration. We are not going to do cholecystectomy in patients of cholangitis. So surgery, immediate surgery is not required here. Option C, emergency ERCP with sphincterotomy and stone aided कर देना. Option C वाला. Option C, you can see emergency ERCP with sphincterotomy and stone extraction within 24 hours. This is correct. Because there is obstruction, you can see multiple stones obstructing the CBD. We have to relieve the obstruction because for cholangitis, 2 factors are mandatory. One is obstruction, second is infection. So here, how to relieve the obstruction? Emergency ERCP. And if you see option D, percutaneous transhepatic cholangiography and drainage. PTC is done when there is stricture or when there is a stone located in proximal part of bile duct. Here you can see the findings. These stones are located in almost distal part of bile duct. Clear? So here what is the correct answer? We go for emergency ERCP with sphincterotomy and stone extraction within 24 hours. So correct answer is option C. Now see the next question. A 55 years old, you can see 55 years old man presents with sudden severe tearing chest pain radiating to the back. Sudden severe tearing chest pain radiating to the back. On examination, he is hypertensive, unequal, you can see unequal blood pressure in both arms. CT angiography demonstrate the following finding, and here you can notice that this patient is having aortic dissection. Can you see the findings? Clinical findings like sudden severe tearing chest pain radiating to back. Patient is hypertensive with unequal blood pressure in both arms, and CT angio, you are going to notice that patient is having aortic dissection. This patient is having aortic dissection. In this case, what is preferred treatment here? Immediately, we are not going for endovascular stent graft repair. Medical management with beta blockers and antihypertensive, this is not sufficient here. Here we are going for emergency surgical repair with composite graft replacement of ascending aorta. This is correct. Cardiac catheterization to access or assess coronary involvement. This is not required. So what is the correct answer? Patient is having aortic dissection, and here we are going for emergency surgical repair with composite graft replacement of ascending aorta. Correct answer is option C. Now see the next question. During damage control laparotomy, important point, what? Damage control laparotomy. Can you see the grade of liver injury? It's grade 5. Which packing technique provides optimal hemorrhage control? Now let's discuss the management protocol of liver injury and splenic injury. So after blunt trauma abdomen, you know that most commonly injured organ is spleen followed by liver. Easy. Now see, in splenic trauma, what kind of bleeding is there? Arterial. In liver trauma, what kind of bleeding is there? Venous. So whenever it's grade 4 or more, the injury grading is grade 4 or more in both liver as well as splenic trauma, we cannot go for conservative management. We have to go for exploratory laparotomy. So splenic artery injury, so splenic trauma, in splenic trauma there is arterial bleeding, so it's very difficult to control arterial bleeding by packing. So what we do in cases of splenic trauma, if it's grade 4 or grade 4, what we do in splenic trauma, if it's grade 4 or grade 5, we go for emergency splenectomy. So exploratory laparotomy plus splenectomy. But liver is a vital organ. You can save the liver. How you can save the liver? By packing, because here the venous is here. You know that the liver is vital organ and here the bleeding is venous. So we can control the venous bleeding by packing. So how we are going to control it? First option, direct pressure on injury site only. No, this is incorrect. Direct pressure on injury site is not going to control all the bleeding in this case. Option B, there is perihepatic packing with pads around both lobes and in Morrison pouch. This is correct. You have to pack the liver. Option C, Pringle's maneuver with total hepatic inflow occlusion. First you tell me what is Pringle's maneuver. You can see this is portal vein, right? You can see this is the bile duct, right? You can see this is hepatic artery. And you know that on ultrasound this appearance is known as Mickey Mouse view. Can you tell me what are the structures? This is portal vein. You can see this is bile duct. You can see this is hepatic artery. So whenever you are going to perform Pringle's maneuver by placing a soft clamp in foramen of Winslow or epiploic foramen, you are going to control bleeding from portal vein and hepatic artery. But we are not going to control bleeding from IVC and hepatic vein. So IVC and hepatic vein, this bleeding is not controlled. And if this bleeding is not controlled, what is the problem here? You cannot control the bleeding from these two structures. So here it's not very helpful. Immediate hepatic resection is not required because we are going for damage control laparotomy. Here, just control the damage. So how to control the bleeding in this case? We have to go for packing. And what is the preferred packing, guys? Here, option B. We are going for perihepatic packing with pads around both lobes and in the Morrison pouch. So correct answer is option B. Now see the next question. A post-gastric bypass patient presents with symptomatic hypoglycemia, and see the duration. What? 2 hours after meals. After meals, there is hypoglycemia. 2 hours after meals, glucose 35 milligram per deciliter, insulin is elevated, it is 45 microunits per ml, C-peptide that is also elevated. What is the most likely diagnosis and appropriate first line treatment? First, it is post-gastric bypass patient. Most probably, this patient is having Billroth 2. What is Billroth 2? You can see this is stomach, this is duodenum, this is jejunum. You perform the gastrectomy. After gastrectomy, you can see here, this is the proximal part of stomach. And what you do, you perform this kind of anastomosis. So this is loop gastrojejunostomy. This is Billroth 2. What is this? This is Billroth 2. Got it? Billroth 2. In this case, what will happen? After meals, what will happen? The food can directly enter into jejunum, proximal part of jejunum. And when this hyperglycemic content is entering into jejunum, within 2 to 3 hours of meals, what happens? Because of hyperglycemic content, there is increased insulin secretion. And if there is increased insulin secretion, because of that, what will happen? Patient will be having reactive hypoglycemia. Patient will be having reactive hypoglycemia. So what is the name of this syndrome actually? This is dumping syndrome, where hyperglycemic and hyperosmolar content is dumped into proximal part of small intestine. And this is early dumping or late dumping. Early dumping is seen within 15 to 30 minutes of meals. Late dumping, it is seen after 2 to 3 minutes of meals. So this is late dumping. And what is the problem in late dumping, guys? Can you tell me? There is reactive hypoglycemia. Why? Because there is hyperglycemic content leading to increased insulin secretion. So see the options. It's insulinoma. It's not insulinoma because after meals in insulinoma there is no hypoglycemia. It is late dumping syndrome. And how you can control reactive hypoglycemia? Yes, by dietary modification and acarbose. Exogenous insulin administration, no, it's not the case of exogenous insulin administration. This is not a case of adrenal insufficiency. So correct answer, late dumping syndrome, and there should be dietary modification and acarbose. We should give acarbose. How acarbose is going to work? You can see it is going to reduce early hyperglycemic stimulus to insulin secretion. So that's why it is going to prevent reactive hypoglycemia. So to prevent reactive hypoglycemia, we give acarbose in late dumping syndrome. Okay. Now see the next question. A 30-year-old man presents with blunt abdominal trauma. CET abdomen shows retroperitoneal gas and oral contrast leak localized to second part of duodenum. First tell me the diagnosis. Whenever there is retroperitoneal gas and oral contrast leak around second part of duodenum, it means there is perforation of duodenum. Which perforation? This is retroperitoneal perforation. Which of the following is most appropriate management? So in these cases we go for, since it's retroperitoneal injury, in these cases mainly we go for damage control surgery. And what else we do? We go for feeding jejunostomy, we go for gastrostomy, we go for duodenostomy, and this is known as triple tube ostomy. So what is the treatment, guys? Here you can see option A, primary repair with simple sutures, not possible. Option B, conservative management with nasogastric decompression, no, because patient is having perforation. Option D, resection with end-to-end duodenostomy. This patient is unstable. In this case, we are not going for extensive surgery. So what is the correct answer? We go for damage control surgery with triple tube ostomy. Option C. You know what is triple tube ostomy? Here is the perforation, right? What you do? One is gastrostomy, second is duodenostomy, that is retrograde duodenostomy, and for feeding we go for feeding jejunostomy. So this is known as triple tube ostomy. Clear? So this is known as triple tube ostomy. Clear? So this is triple tube ostomy, right? Now see the next question. A patient with 2.5 centimeter, what's the size? 2.5 centimeter invasive ductal carcinoma undergoing breast conservation surgery or therapy has margin showing invasive tumor clear by 3 mm, but DCIS present at the margin. Okay, whenever you are performing breast conservation surgery, sometimes we send the frozen section biopsy, and if you send the frozen section biopsy, it shows that there is DCIS ductal carcinoma in situ present at the margin. In that case, what you should do? Go for re-excision. But suppose you are going to remove the tumor and it is sent to pathology department. After 4-5 days, 7 days, you are getting the biopsy report. Biopsy report says that margin is positive, surgery was already done. In this case, to kill the tumor cells, we give radiotherapy. So here, biopsy says that DCIS is present at the margin. So appropriate next step is go for re-excision. Go for re-excision. If surgery has been done, you receive the biopsy report, and biopsy report later says that there is margin positive margin is there, or presence of tumor cells at the margin. In that case, we give radiation. So here, two options, radiation without re-excision, and first option, re-excision for DCS at the margin. This one is preferred here. Here the preferred answer is option A. We are not going for mastectomy, no further treatment. This is also incorrect. So correct answer is re-excision for DCIS at the margin. See this question. A 55-year-old man is diagnosed with rectal adenocarcinoma. And what is the location? Located 6 cm from the anal verge. This is important. 6 cm from the anal verge. Staging workup reveals T3N1M0. So whenever there is T3N1M0, whenever there is lymph node involvement, it becomes stage 3. So what is the stage of this malignancy? This patient is having stage 3 carcinoma rectum, location 6 cm above anal verge. He undergoes what? Neoadjuvant chemoradiotherapy. So there is neoadjuvant chemoradiation given to this patient, shows good radiological and clinical response. At this stage, what are the appropriate surgical management options for this patient? So in this case, what should be done? So first, let's discuss the management protocol of carcinoma rectum. Imagine patient is having stage 1 malignancy. What is sufficient for stage 1? Here we are going for surgical resection only. But if patient is having stage 2 and stage 3 malignancy, we have to downstage the tumor. And how we are going to downstage the tumor? By neoadjuvant chemoradiation. So what you have to give? First, go for neoadjuvant chemoradiation. And after neoadjuvant chemoradiation, we are going for surgical excision. So neoadjuvant chemoradiation followed by surgical excision. But if patient is having stage 4 malignancy, in this case also, to downstage the tumor, we are giving neoadjuvant chemoradiation followed by surgical excision. And if surgical excision is not possible, in that case we go for palliation. If surgical excision is not possible, we go for palliation. So here the stage was stage 3. So in that case, neoadjuvant chemoradiation followed by surgical excision. What kind of surgical excision? Whenever a patient is having carcinoma rectum, we go for total mesorectal excision. What is total mesorectal excision? Around rectum there is mesentery known as mesorectum, and in this mesorectum there is lymphovascular supply to the rectum. Simultaneously there are lymphatics also and lymph nodes also. So if you resect the rectum, we had to resect it along with mesorectum, and this surgery is known as total mesorectal excision. Who gave this concept of total mesorectal excision? It was given by Bill Heald. And what we are going to remove actually here, there is excision of surrounding tissues up to the plane between mesorectum and presacral fascia. That is known as Heald's holy plane. See how we are going to do it. In this image, you can notice that this is the malignancy, and here we are going to resect it like this. Clear? So this is total mesorectal excision. This is one concept. Second, what kind of surgery should be done? See, whenever malignancy is located more than 5 cm above anal verge, in that case we go for LAR. And if it is located at or below 5 cm from the anal verge, we go for APR. Let me explain. You know, what is the length of surgical anal canal? Roughly it is around 3 cm. 3 cm. And in distal rectum, how much margin you require? You require 2 cm margin. So any carcinoma rectum which is located more than 5 cm above anal verge, we can take 2 cm margin. In that case, we can go for low anterior resection. But if malignancy is located at or below 5 cm from anal verge, we don't have margin and we have to resect the anal canal also. So apart from rectum, if you remove anal canal, this surgery is known as APR. So in which cases you are going for abdominoperineal resection? If CA rectum is located, if it's located at or below 5 cm from anal verge, and if it is located more than 5 cm from anal verge, we go for LAR. Clear? So let's see the question again. If you see the question again, it is located what? 6 cm. Can you see this? 6 cm from anal verge. So here we can go for LAR, low anterior resection. Clear? And apart from that, obviously we go for total mesorectal excision. So option A, no surgery needed after good response to therapy. This is incorrect. Abdominoperineal resection, it is not done. Local excision, it's not done in this particular case. So it's low anterior resection with total mesorectal excisions. What's the correct answer, guys? Correct answer is option D. A 32-year-old male presents to emergency department after a motor vehicle collision sustaining blunt abdominal trauma. So this patient is having blunt trauma abdomen. He is hemodynamically stable. Most important statement, he is stable. But a CT scan of abdomen reveals grade 3 laceration of spleen, grade 3 splenic laceration, and evidence of active contrast extravasation. So this patient is having active bleeding. There is active contrast extravasation. What is the most important next step in the management? Okay. So first, let's discuss the management of splenic trauma, and then we will discuss this question. You can see here, imagine patient is having splenic trauma, blunt trauma abdomen involving spleen. Any patient who is unstable, in that case you go for FAST. FAST is obviously positive, you go for exploratory laparotomy. If patient is stable, go for FAST. If it is negative, we just go and perform the observation. Only observation is required. But if FAST is positive, confirm the finding by CCT. We discussed that we can manage up to grade 3 injuries conservatively. Even if patient is stable, but the patient is having grade 4 or more injury, in that case what should be done? exploratory laparotomy and splenectomy. For grade 1, grade 2, grade 3, conservative management can be done. So imagine this patient is not having pseudoaneurysm, contrast blush, moderate bleed. In that case, go for observation and repeat the scan after 72 hours. But if there is pseudoaneurysm, there is contrast blush, moderate bleed, or there is active bleeding going on, in these cases, you control the bleeding by angioembolization. If it is failed, not available, or patient become hemodynamically unstable, there is peritonitis, in that case, we take the patient for laparotomy. Clear? So see the question again here. This patient is having grade 3 laceration, patient is stable and there is active bleeding, active contrast extravasation. So here we go for angioembolization. So immediate splenectomy is not required. Why? This patient is stable. Observation with serial exam, no, because there is active bleeding going on. Exploratory laparotomy is not required because here we can manage this patient with angiography with embolization. So correct answer is option B. See this question. A 45 years old female undergoes total thyroidectomy for which malignancy? For papillary carcinoma thyroid. During the procedure, intraoperative frozen section analysis of a palpable central compartment lymph node reveals metastatic papillary thyroid carcinoma. So there is involvement of central group of lymph nodes. Central, it is also known as anterior compartmental. This is known as level 6. The patient has no clinical evidence of lateral neck disease on preoperative imaging or intraoperative examination. What is the most appropriate next step in operative management of this patient? So first, what's the treatment of papillary carcinoma thyroid? You know, we go for total thyroidectomy. If there is enlarged central group of lymph node or involved central group of lymph nodes, in that case we go for central neck dissection. And if there is involved lateral group of lymph nodes, any lateral cervical lymph node is involved, in that case we go for MRND. MRND means modified radical neck dissection. Clear? So see the options. If you see option number 1, complete operation without lymph node dissection, this is incorrect. Why? Because there is involvement of central group of lymph nodes. Modified radical neck dissection not required because lateral lymph node levels are or lateral group of lymph node is not involved. Post operative radioactive iodine only. No, this is not required at this stage. Here we go for central neck dissection. So correct answer is option B. A patient with pancreatic head mass. Where is the mass in the pancreatic head? Presence with obstructive jaundice. CA99 is elevated. So you know that in pancreatic adenocarcinoma, the most specific tumor marker is CA99. So carcinoma, head of pancreas, CA99 is elevated. CT scan shows tumor abutting the superior mesenteric artery for 120 degree. What should be the resectability of this tumor? Let me tell you what is resectable tumor in carcinoma head of pancreas. When there is no metastasis and no involvement of celiac axis, celiac artery, superior mesenteric artery, common hepatic artery. But here there is involvement for 120 degree. So this patient is having borderline resectability. Borderline resectability, and a patient who is having borderline resectability, in that case first try to downstage the tumor. And how you are going to downstage the tumor? By neoadjuvant chemotherapy before surgical resection. So this is borderline resectable. So here we consider what we consider in this case, neoadjuvant chemotherapy before surgical evaluation. This is not resectable clearly. Why? Because there is involvement of superior mesenteric artery. This is also not unresectable, and staging laparoscopy required first. No, here first we have to go for downstaging the tumor. So we consider neoadjuvant therapy. So correct answer is option A. See the resectability criteria. Pancreatic head carcinoma is resectable when there is no distant metastasis and no involvement of major arteries like celiac axis, superior mesenteric artery, or common hepatic artery. There should be minor or no venous contact with superior mesenteric vein and portal vein. Or if there is venous involvement, there should be segments suitable for reconstruction. Clear? So this is the criteria for resectability. Okay. So see the next question. Which bariatric surgery is represented by the image given below? So see the image first. Here I have created a gastric pouch. Gastric pouch has been created and the distal part of stomach is bypassed. So distal part of stomach is bypassed. Proximal gastric pouch is small. How much is the content? Approximately 30 to 50 ml. And after that you can see this kind of anastomosis is done with jejunum. So here what's the name? This is Roux and Y reconstruction. So this is Roux-en-Y gastric bypass. Roux-en-Y gastric bypass. It is largely restrictive, partly malabsorptive bariatric surgery. So here what's the correct answer? Which bariatric surgery is represented by the image given below? This is Roux-en-Y gastric bypass. What is sleeve gastrectomy? Whenever you cut the stomach like this. So this is sleeve gastrectomy. Adjustable gastric banding, where you are going to apply a band around the proximal part of stomach, and in biliopancreatic diversion, the bile and pancreatic duct is diverted. In this case, you perform duodenal switch, duodeno-ileostomy, and there is jejunal-ileostomy. So what is the correct answer here? Guys, the correct answer is option A. So these were the surgery questions. All the best, guys. All the best.
Okay guys, welcome to the video-based solutions. Medical science is supposed to be precise, so what I'll be doing here is quick and I'll help you solve out the MCQ options in the shortest possible time frame. Let's get started with the first one. Standard question, 25-year-old athlete, palpitations and pre-syncope. And then the ECG findings are like right in your face. I am very sure you were able to pick this up. That is a very short PR interval. In fact, there's no Q wave present. And just when the P wave is finishing, right in lead number 2, you can see the moment the P wave is finishing, then there is a R wave that is happening. And you are also noticing that there is a slurring in the upswing of the R wave. That slurring in the upswing of the R wave is what will immediately help you identify that we are dealing with the accessory pathway. That would be delta waves in this patient. The delta waves in this patient are upright in lead number 2, 3 and AVF, that is the inferior lead. That also gives me a hint regarding the fact that this person is having a left-sided pathway. How did I know it's a left-sided pathway? I'll just say it quickly. Because of positive delta waves in lead number 2, 3 and AVF. If they're negative, then it is like a right-sided pathway. And then you will also have this query that boss, why is there a ST segment depression present in the ECG? This guy, well, I can call them as non-discordant findings. They would be like pseudo findings of ischemia, because actually there is not ischemia in the heart. It is because of the defective, I can say, vectors that are appearing in the ECG of this patient due to the accessory pathway. The clinical diagnosis in this case is Wolff-Parkinson-White syndrome, where we have a short PR interval and we have is a delta wave. And the moment you are able to identify this, I'm very sure you would have got this question right. That is procainamide is the main drug to take care of that fast reduction occurring through the accessory pathway. If the question says prevention, it's flecainide. If it says ideal treatment, radiofrequency ablation. So this was an easy opening. Let's move to the next one. 45-year-old woman with rheumatoid arthritis is on methotrexate, adalimumab, and presents with progressive dyspnea. Now, HRCT is showing UIP, that is usual interstitial pneumonia, and then is giving anti-MDI, that is melanoma differentiation antigen 5 antibodies being present. So what is happening here is that he is giving us a case of overlap syndrome. You are aware of the fact that if at least 2 or more than 2 connective tissue disorders are present in a single patient, then we have to think in terms of overlap syndrome. Like in this question, is himself mentioned patient is having rheumatoid arthritis. Along with that, he's also giving features of dermatomyositis. And the bad news for this particular patient is that there is a concomitant interstitial lung disease present. Now he's saying, what will you do? You see, the patient is already on methotrexate, and the problem with methotrexate is that it causes damage to the lungs. So in this case, option number A is the easiest one to rule out. I mean, continue all medications and add supplemental oxygen. Well, because I'm aware that methotrexate has a peculiar subset of side effects present, so I cannot continue with all of them. It will make sense to discontinue methotrexate and continue with adalimumab and then start mycophenolate for rapidly progressive interstitial lung disease. I'm writing plus minus after this because this looks maybe like a very logical thing to do. Then is increase methotrexate route. I mean, that's going to be harakiri for any doctor's practice. So methotrexate, you are aware that it's not only hepatotoxic, but it can cause interstitial pneumonia. It can even trigger pulmonary fibrosis. In fact, when you read about methotrexate, normally we write it as MTX. So one of the common things that is taught is that patients who are having, who are taking methotrexate will be coming to us with complaints of mouth sores. Then there would be like hepatotoxicity present. I mean, that's one of the important things that they always love to ask. Apart from this, it can also affect the platelet count. So T can also be used to remember the thrombocytopenia component of this condition.
And normally by this time the fatigue sets in, and that is where he knows that he is introduced a question that the X part is to remember that the X-ray findings in this patient, whenever methotrexate is being given, it can result in development of interstitial pneumonitis, or it can result in worsening of the symptoms of pre-existing lung disease in a patient. Just like you guys are comfortable with methotrexate contributing to interstitial pneumonitis and pulmonary fibrosis, in the same spirit you are anyway aware amiodarone is also asked. One of the big side effects of amiodarone is always lung fibrosis. So I have to select between B and D, and it's always like this fight between two very close options. Switch to rituximab and add a high dose prednisolone. So there are two correct answers in this question, that is B and D. And therefore, what I want to tell you is that in INI-CET, you will be faced with such situations where you will have to select sometimes the more appropriate one. Now, adalimumab, that's a rare fact, it also contributes to development or damage to the liver. So because of the fact that methotrexate can also cause damage to the liver and can contribute to damage to the lungs as well. And in this condition, the lungs are also affected in a patient. So I can say that because both methotrexate and adalimumab have the capacity to cause damage to liver and also capable of damaging the lungs of the patient, the more appropriate answer would be switching to rituximab and a high-dose prednisolone. I did invest a little more time in this question than I should have done, because I needed to deliberate upon two close options here, and the final output is like B and D both are like approaches that can be used, but I have selected the most appropriate one. So obviously in any set there would be some questions where you will have to rack your brains, and in these kind of questions it is advisable that if you're not able to figure out, yes, you can take a wild guess there, because luck favors the brain. So we have a 68-year-old man. He's having heart failure with reduced ejection fraction, and he's having a NYHA class 3 limitation, which tells me that going to bathroom will be troublesome, changing clothes is troublesome, ejection fraction is nasty, 25%. There's a left bundle branch block with a wide QRS complex. He says, what are you gonna do? So the problem is that in this person, the left and the right ventricle are not working in tandem. You see, in all patients of congestive heart failure, what basically will happen is that there would be a non-synchronous contraction of the ventricles that will add up to the worsening of the condition of the patient. So even if I give drugs, it's not going to be very, very helpful. So I'm not thinking about adding digoxin, because that will increase the oxygen consumption of the heart. Giving beta blocker does make sense for this patient, or increasing the dose of beta blockers makes sense. So I'm just keeping it plus minus to say this may be the answer. But then heart transplantation, well, that may not be very, very feasible, in a sense that donor may not be available, brain dead donor. So I'm left with two options. One is make the two ventricles contract simultaneously. So the message here is that whenever we have refractory congestive heart failure, and drugs are not working, ejection fraction is very low, then we need to make the ventricles work in tandem, that is contract at the same time with equivalent amount of power. So we will go for biventricular pacing, and that biventricular pacing is cardiac resynchronization therapy. The correct answer for management of this condition is CRT, and we can put in a defibrillator as well, because if there would be arrhythmias, because anytime if there's a structural damage to the heart, the arrhythmias can come in. So the correct answer to this one is option number C. Now we have a lady with lupus, and she's having a rising creatinine. One of the characteristic histopathological findings here is the endocapillary proliferation with wire loop lesions. The moment you read wire loop lesions, you will notice that we are talking about one of the commonest classes that we encounter, because there are 6 classes, right? And the commonest class that we come across where problems would begin to occur is like class 4. So I need to be aggressive at this point of time, because if it's going to be class 6, then I will go ahead with the like a dialysis preparation. But at the moment I know wire loop lesions, it is class 4, and then the remaining options anyway will fall out of place. Like if you look at class 5, conservative management, he says like, what is the diagnosis first? So that I've said is class 4, and then what would you do in this case is you will be aggressive, and you will be giving steroids, cyclophosphamide, mycophenolate, because you don't want the patient to go into class 5. So the correct answer for this question is option number C. Just remember the fact, wire loop lesions anytime given in a question of lupus is always going to be class 4 lupus nephritis, which has the highest scoring component. When you listen to SLE topic, I've talked about the scoring pattern, right? So when I say the scoring pattern component, then class 4 lupus nephritis comes and takes the spot where immunosuppressant medication is to be given. Now, easy one, a tricyclate antidepressant. The standard question on amitriptyline toxicity. And the problem with this is it causes metabolic acidosis, which is triggering a ventricular tachycardia. How do I know ventricular tachycardia? It's written wide QRS complex, huge 160 millisecond on the ECG. There's an altered mental status also. So initially, I might have to defibrillate the patient. But along with that, the arrhythmia can come back. I don't want the arrhythmia to come back. So the antidote for TCA toxicity discussed so many times in pharma, so many times in medicine is soda bicarbonate, so that we can handle the metabolic acidosis component. Then is a patient who has undergone a HRCT revealing upper lobe cavities and nodules. There is thankfully no acid-fast bacteria. There's bilateral upper lobe involvement. So I was thinking in terms of tuberculosis, but rather what is being found is surprisingly Aspergillus fumigatus, and even antibodies are present in this case. So he says, what is the most appropriate management in this case? So option A, invasive pulmonary aspergillosis. An invasive pulmonary aspergillosis would contribute to even development of hemoptysis. In this particular case, he is mentioning regarding cavities and nodules. In invasive pulmonary aspergilloma, there will always be a mention of a fungal ball that would be growing in a cavity that is caused by, a cavity which is caused by either lung cancer, cavity that's caused by TB. So invasive pulmonary aspergilloma is unlikely one because patient is not presented like with the hemoptysis, and there is no mention of any radiological finding of a air crescent sign or a fungal ball present. So this is unlikely as an answer. Because I'm reading the word Aspergillus fumigatus, I'm tempted to think in terms of allergic bronchopulmonary aspergilloma. But for allergic bronchopulmonary aspergilloma, one, you need elevated levels of immunoglobulin E. You need an association with asthma. And the most important thing is that I've highlighted time and again with Aspergillus is that if ABPA you want as an answer, what must always be written, the buzzword, the keyword in the question that should always be written is central bronchiectasis, which in this particular case is not given. He has just mentioned upper lobe cavities and nodules, but there is no like central bronchiectasis that is given. So therefore, what was looking an answer is actually not the answer. That is allergic bronchopulmonary aspergillosis is not the answer in this question. Between option number B and D, like for surgical resection, well, what I'll do is in a person who's having an infection, will first treat him medically. So the correct diagnosis in this case is option number B, that is chronic pulmonary aspergillosis, and itraconazole would be used. The learning point from this question is just because fumigatus is written, do not be under impression that the question is on allergic bronchopulmonary aspergilloma. Do check out if there is mention of immunoglobulin E elevation, association with asthma, central bronchiectasis, and then more importantly, he should mention regarding eosinophil count. He should mention that an asthmatic has come with thick tenacious sputum, which is not given in this question. That helps us in arriving at the answer. Then is a patient of Southeast Asia. He's having liver enzymes that are deranged along with fever and thrombocytopenia. So first thing that comes to your mind is dengue, and the platelet count is like 30K, so fairly an easy one. So there would always be mixed bag questions where you would get some where you'll have to rack your brains, and then you'll get such an easy one that you'll be wondering. Really, I took a subscription for that, attended face-to-face coaching for that. Some are gonna be damn easy, but some would make you rack your brain, and that's that roller coaster ride that you need to endure. Now we have a woman, she's having morning stiffness, symmetrical arthritis involving the small joints of the hand, and then we can notice a positive rheumatoid factor, anti-CCP antibody present. So everything goes in favor of rheumatoid arthritis, but then he drops a bomb, and the bomb is liver disease present in the guy. So I would not be very comfortable with my standard triple therapy regimen where I will give methotrexate and then I'll give hydroxychloroquine and sulfasalazine. As you know, MSH, methotrexate is one of them. And then we use S, that is sulfasalazine. Yes, the drug that we use in inflammatory bowel disease. The third one is a drug that was famous at the COVID time, that is hydroxychloroquine. So among the options which are given here, I would not select NSAIDs. I'll not take steroids. Either it's gonna be A or it's gonna be C. So what should I be selecting? I'll select like what is more appropriate. What we usually give is leflunomide, or we can use sulfasalazine. So between A and C, I can say both are correct. Both can be used. But then from the perspective of damage in the liver, what I can use is leflunomide or sulfasalazine as a much more, I would say, I can select the worst out of from the perspective of the best out of the worst options that are present. So the correct answer would be A. Then we have this woman with weight gain and purple striae and 24-hour urinary cortisol is elevated. So the moment I read it, I know that I'm dealing with Cushing syndrome. And then it says dexamethasone suppression test shows no suppression with low dose, but it shows a suppression with high dose. And the moment you read that, I have explained that high dose dexamethasone suppression test is used to differentiate whether it is going to be an ectopic source like lung cancer or it is going to be an endogenous cause like a pituitary adenoma. Now you are aware of the fact that you cannot suppress. I mean, howsoever hard you may try, but it is not possible to suppress a ectopic source. A lung cancer cannot be suppressed, but endogenous one like a pituitary adenoma, yes, we are gonna suppress it. So in this case, it turns out to be an endogenous source, that is a pituitary adenoma. Why the keyword written more than 40%? I mean, even if you don't get into percentages, no, I just want you to remember that if you're getting a suppression, whereas ectopic source would not be getting a suppression. So that's the fundamental difference. I mean, you can't suppress a lung cancer by giving steroids, as simple as that. And therefore, the correct answer for this one is A. Then is a diabetic patient with the proteinuria in nephrotic range, hitting nephrotic range. eGFR is low. Yes, he's going into stage 3 of CKD. I am already managing this person with the lisinopril because the BP is elevated. What should I do next? I'm an SGLT2 inhibitor. So piece of cake, man. I mean, for this particular chap, I have to add renoprotection. That is, SGLT2 inhibitors need to be started. Then I have a patient with massive pulmonary embolism. The systolic BP is like 85. There's right ventricular strain, and he's asking about the pulmonary embolism severity index is a high risk. He says appropriate management. Time and again, I've explained if the systolic BP is 90 and is falling, and there's evidence of right ventricular strain, even if you don't focus on the word right ventricular strain, hypotension is there, by clot has to be busted. क्लॉट को डिस्ट्रॉय करना है. क्लॉट को डिस्ट्रॉय करने के लिए हम क्या यूज करेंगे? हम थ्रोम्बोलाइटिक एजेंट्स यूज करेंगे. सो व्हाट वी आर गोना यूज हियर इज thrombolysis or a surgical embolectomy is also a procedure that can be done, but then most of the time it's a catheter induced thrombolysis that can be done for this patient. Now you're having a patient who underwent a blood transfusion and there is like a dark color urine within 30 minutes of starting the transfusion. So I immediately know that I'm dealing with a mismatched blood transfusion, and if that's gonna happen, I have to stop the transfusion immediately. I mean, in this question, even if don't read the next line, haptoglobin levels are decreased because hemolysis, free hemoglobin will come now, and free hemoglobin will be then bound with haptoglobin. So therefore, haptoglobin values will be less, and antibody antiglobulin test is positive. That's because of the antibody mediated type 2 hypersensitivity. But then this one would be stop transfusion. Then we have a patient with the generalized weakness. There is dehydration, tachypnea, and the ABG shows pH being less, PCO2 being less, and bicarbonate being less. So because all are being less, I know I'm dealing with a case of metabolic acidosis. I will now be also applying the Winter's formula, where I will be adding 15 to the value of bicarbonate, and I will calculate the expected PCO2 of the patient and do the matching with the actual PCO2. If I add 15 to this value of 14, this will mean that the expected PCO2 should turn out to be 29 millimeter. It is 28 millimeter, so it is lesser, so that is okay. Patient is patient is compensating. The anion gap is 10, that is within normal limits. So at the moment, I can say my patient is having normal anion gap metabolic acidosis. Along with this, there is a compensation. Well, why did I say normal? Is because of the value 10, and then there's a compensation process. How did I say compensation? Is the expected value is like 29 and the actual value is about 28. So it's lesser. If it was more, I could have thought of mixed disorder, but if it is less, it is compensation. And then he's saying urinary anion gap is turning out to be positive as well. Immediately when you know this, you know the answer cannot be diabetic ketoacidosis as well as lactic acidosis, because if you follow the cult mnemonic, ketoacidosis, uremia, lactic acidosis, I mean, I've explained those are causes of HECMA, high anion gap metabolic acidosis. So I'm left with only two, diarrhea and renal tubular acidosis. And then diarrhea tends to have a negative urinary anion gap, whereas in this case, there is a positive urinary anion gap. So the correct answer for this one is option number A. The mnemonic I would like you to be remembering is once again negative. I mean, when you write the word negative, write GAT ki jagah pe GUT. And the moment you say negative, then the gut word comes in, and the gut word tells you that the intestine is a problem, it's upset, there's a diarrhea component present. So the correct answer for this one is option number A. Now I have a patient who is having a structural damage to the heart. Like he had an MI and now there's a structural damage to the heart. So the doctors put him on amiodarone, warfarin, statins, low dose aspirin beta blocker. I mean the standard paraphernalia drugs that are being given. Unfortunately, due to structural damage, there's a VT. And now you have to manage the patient with defibrillation, and that was also successful. So, like a super lucky guy, he says, "What are you gonna do next in this patient? I don't want him to suffer from tachyarrhythmias again, because otherwise the next time he may not be so lucky. There's a traffic jam outside the hospital, and by the time he reaches, I mean, we may lose the patient as well. So for prevention, what I'm gonna do, I'm gonna start the patient or advise for ICD, that is a implantable cardioverter defibrillator. So we're not gonna go ahead with digoxin and beta blocker, because that could be counterproductive. It can, I mean, digoxin anyway, I mean, not very comfortable, especially in a guy with the damaged heart. And then increasing the dose of beta blockers is not like a very convincing thing to do if a person has already had a ventricular tachycardia. I don't want the episode to occur. So therefore, implantable cardioverter defibrillator needs to be deployed. Now we are having a patient of systemic sclerosis with breathing difficulty. The X-ray is showing ground glass opacities because there's a pulmonary fibrosis component coming in here with anti-topoisomerase antibody. He says, what are you going to do? I mean, solve it by English. No, the question is not on scleroderma renal crisis. The question is not on hypertensive crisis. So therefore, option number A in this case can be ruled out. Now, when you look at B, mycophenolate for scleroderma associated ILD, that looks like the correct thing to do. The question is not talking about Raynaud's phenomenon. Question is not talking about any skin involvement. So what I am going to do in this case is that mycophenolate for scleroderma associated interstitial lung disease by simple English can be interpreted. We have a patient with muscle weakness. Now, ECG shows prominent U waves, so that immediately tells you electrolyte imbalance is potassium, and is himself mentioned hypokalemia. Urinary potassium is high. I mean, urinary potassium excretion is high. The person is hypertensive. I mean, the moment you read about hypertension with hypokalemia, you know that you are talking about a person having increased aldosterone, because aldosterone will act on the epithelial sodium channel and it will cause a urinary loss of potassium. So there will be caliuria, and that is why like potassium values will decrease. So I'm thinking in terms of hyperaldosteronism. The correct answer to this question is option number A. Well, why not diarrhea in this case? Then I can say that in a person with diarrhea, then potassium is less, so urinary potassium will be less. But aldosterone always causes caliuria to be present. So that's like the first thing that would be in my mind with a guy with hypertension. And diarrhea will not cause hypertension. No, I mean, just focus on the word hypertensive patient. Hypertensive person is not gonna be, I mean, diarrhea person is not gonna have hypertension, right? He's gonna be having rather a blood pressure on the lower side. So fairly a straightforward one. The remaining options are dummy ones. Diuretics. Then is, I mean, he means a diuretic abuse in this case. Then even those circumstances, like the remaining things have to be put in the right perspective. Now, hypertension with hypokalemia is a presentation of not a diuretic use. Rather, diuretic use on a long-term basis will cause hypotension. Okay, so standard question, HIV positive patient, CD4 count is low, the lumbar puncture was done, there were lymphocytes. So either it's going to be viral or it's going to be fungal. The protein is 60, that's elevated, little than normal. Glucose is low, so that tells me it's more going in favor of fungal meningitis. And yes, then the cat is out of the bag, cryptococcal antigen test. So the answer is amphotericin B with 5-flucytosine, asked so many times in the exam, fairly straightforward one. Now you're having a patient who's 28 years of age and is having hematuria with hemoptysis. Then he's talked about crescentic glomerulonephritis with linear immunoglobulin G deposits. I mean, how easy do we want it? I mean, that's going to be super easy. Combo of hematuria with hemoptysis, anti-basement membrane antibodies are present here. So the diagnosis in this case would be good pasture. The correct answer for this is option number A. So this is more like a, I would say, confidence building exercise in this test today. And over the period of time, we're going to take you up in the slope and we're going to make you exercise your leg muscles. So gradually you will notice that as you go closer, the difficulty level is going to go up. Now we are having a patient who's a male with hemophilia A, and he's having these antibodies, Bethesda units that are given in the patient. And unfortunately, in our case, person is having an emergency surgery requirement, appendicitis surgery is required. Now you know that if there is presence of these antibodies, that means that this particular chap is actually having acquired hemophilia, right? Acquired hemophilia means that there are auto antibodies against factor 8, and if I will give factor 8 to the patient, then those antibodies will attack factor 8. It's a waste of resources. So I will not be in this particular case giving to the patient like factor 8. Rather, what we will do is, in this case, we will be using is recombinant factor 8 concentrate. And then you can notice there are two options given. One is monitoring via APDT, and second is like focus on the clinical response. Well, if it was the standard hemophilia question, not acquired hemophilia, I would have gone by like APDT monitoring, and I would have given factor 8 concentrate. But now we will be giving is like a recombinant factor A to this patient, recombinant factor 7A to this patient. That's going to bypass the routine clotting cycle and thereby initiate clotting in the patient. So the correct answer in this case is option number B. Remaining options, that is a factor 8 concentrate, I mean, we will not give because there's antibodies already present. They'll destroy that factor 8. So it would be like, I can say, waste, super waste of resources. So obviously this is out of the discussion. Then fresh vessel plasma cryoprecipitate again. If it was routine hemophilia, life-threatening bleeding, yes. But now it's not like a solution to the problem. The solution to the problem is bypass the antibodies which are preventing factor 8 from doing their job, which is why the answer to this question turns out to be option number B. So we now come to a 55-year-old guy. He's a male and he underwent a cardiac transplantation 2 years ago. Lucky chap. The ejection fraction, however, is now decreasing to 40%. And we did endomyocardial biopsy because we were suspecting organ rejection. And what you can notice is that there is a diffuse lymphocytic infiltration that indicates that the heart is being rejected by the immune system of the patient. Now, as far as rejection is concerned, there's specific reasons. One could be that it could be humoral response of the body, that is antibody mediated. Then can be cellular response. The third possibility can be damage to the blood vessels, that is vasculopathy. So I will try to solve this question by simple English only, that because he says donor specific antibodies are negative, so I have ruled out in this discussion that is humoral part. And there's no mention of any damage to blood vessels also. So the only thing that is left behind is the cellular rejection. That is option number D is the reason. And what do you stand for? ISHLT is International Society for Heart and Lung Transplantation. And there's like a grading with respect to how severe the damage is present. The correct answer for this one is option number D. Now we are having a patient who had community acquired pneumonia. He's on lung protective ventilation with tidal volume of 6 ml per kg. You are aware that in ARDS patients, normal ventilation is 12 ml per kg. But in this patient, we are keeping a PEEP which is fairly high. The tidal volume is on the lower side and the PaO2 FiO2 ratio is still 80. So we have given prone positioning. We are putting the patient on standard lung protective ventilation, that is low volume ventilation. There is no improvement. Then increasing the tidal volume will increase the risk of development of barotrauma, so I'm not going to take out that chance. In ARDS, we always go for low volume ventilation between 4 to 6 ml per kilogram. That would be like instead of normal 12 ml per kg. So option number A is ruled out. Then is decrease the PEEP to 8. That will rather decrease the recruitment of alveoli also. Then is high frequency oscillatory ventilation doesn't work here. So I'm left with only one, and I can say ECMO was life-saving for a couple of doctors who at COVID time, I'll just show you a report here. This was in Gujarat, I mean way back, September 2020 is what I'm taking you back so many years, almost half a decade, where like one doctor had actually survived COVID. He had ARDS not responding, so we had to put him on ECMO. So really a miracle story there. And like I introduced this question just to sensitize you to the fact that in ARDS, if nothing works, then ECMO still might be working. So this is a question on refractory ARDS, standard INI-CET kinds, where you could be having some which will go be beyond the syllabus, and there would be some like you'd be wondering, like, are you serious? I mean, good pastoral disease, right? And then suddenly you are noticing acquired hemophilia. Then you can notice that you have to use logic and English, and then is refractory ARDS. So some questions are going to be super easy, and some are going to be like, making you rack your brain, but then you just need to be persistent as you are at the moment listening to me. Okay, a 32-year-old female primary gravid at 28 weeks of gestation, more of like OBGY. She's Rh positive, but then she's having anti-cal antibodies present with a titer of 1 is to 32. So, I mean, antibodies because of aluminization are present and they causing destruction of RBCs of the baby. So, the question is not on Rh incompatibility, but is talking about K antibodies, which are causing destruction of the fetal RBCs, and there's an anemia present in the fetus. So what I'm going to do is to improve the chances of survival. The only thing that I have, the main weapon I have to fight this would be an intrauterine transfusion. The correct answer for this would be option number C, a bit of OBGY at the medicine overlap, like traditionally we read about Rh related aluminization, but now I'm talking about anti-cal antibodies resulting in hemolysis of the child, hemolysis of the RBCs of the fetus. Then we have this patient who's having long-standing diabetes with early satiety, bloating, and postprandial vomiting, and there is like delayed gastric emptying that is documented. So he's talking about diabetic neuropathy, which is contributing to autonomic features in a patient. And well, what would you do? Just symptomatic treatment, like PPIs will not work. Antibiotics are like this. Presentation is not a bacterial overgrowth syndrome. There's no malabsorption that is described there. So I'm left between two situations, extreme ones. One is placed in a gastrostomy tube, second is metoclopramide or domperidone. So makes more sense to go in for conservative medical management. The answer would be A. Now is a question classical for lupus, where multiple correct options can be present. Musculoskeletal involvement. This was last time's INI-CET straightforward one. Yes, correct. Positive double-stranded DNA. No, man, it is anti-nuclear antibody, which is going to be entry-level criteria, not dsDNA. So this is off the radar. And then is increased risk of atherosclerosis. Yes, in these patients is present. Steroids are contraindicated in lupus cerebritis. No, if there's cerebritis, there is going to be cerebral edema and it's going to be vasogenic cerebral edema, then steroids will be beneficial. No? We may consider not to give steroids if there is going to be very severe psychiatric manifestations in a patient. So if you were saying neuropsychiatric, I would have been a little worried. But like for lupus cerebritis, steroids are on. So in this particular here, okay, he has written contraindicated. So that's the wrong statement. No, I mean, this is again a wrong statement. So two are ruled out, B and D, and that makes the answer as option number 1. Steroids are not given in if there is psychiatric profile, which is acute psychosis, but yeah, in lupus cerebritis, I will be giving it. Now have a patient who's presenting with dyspnea and persistent dry cough. There is honeycombing and traction bronchitis that are described. There's no occupational exposure that is given. He says, what will you do? So like in this particular case, the diagnosis is not hypersensitivity pneumonitis because there's no occupational risk that is given. Sarcoidosis, there's no mention of any granulomas, non-caseating ones. Asbestosis, like there has to be some occupational risk that is given in a question. So he's pointing towards IPF, and IPF we don't use steroids. I mean, steroids don't work in idiopathic pulmonary fibrosis. It is antifibrotic therapy with nintedanib and pirfenidone, which are the main like anti-fibrosis agents from the perspective of pulmonology. The answer to this question is option number A. Now I have a patient with renal colic and he's having uric acid stones, and uric acid stones develop in acidic urine. So he says, how would you be preventing the chances of recurrence in this patient? I will try to keep the urine alkaline, and that is giving potassium bicarbonate. So the correct answer for this one is option number A. We will increase urinary output. No restrict urine output. Then calcium excretion is not the concern in this case. And then acidify the urine will worsen the case. I mean, acidic stones will develop in acidic environment, so here worsening can occur. So as a result of this, the correct answer is option A. Then is that, I am so tempted to say the word crushed ping pong ball appearance on a Gomori methamine stain, whether it is INI-CET, whether it is FMG exam. I mean, one question that will always give you bonus mark is like pneumocystis jirovecii pneumonia. And in this case, whether he says treatment, whether he says prophylaxis, it's going to be uniform, and we'll continue like this prophylaxis till the CD4 count is more than 200 for at least more than 3 months. So the correct answer in this case is option number C, that is cotrimoxazole. Then I'm having a patient in thyroid storm. He's having heart failure, and he says like, what's the most appropriate route for giving propylthiouracil? There are two ways by which I can be giving it. One is I can put in an NG tube, not in the options. If it's not there, yes, I can use the rectal route as well. So in this case, the correct answer is option number B. It's just that NG tube was not in the options, which is why rectal has been answered. A patient is developing antibodies against JKA and then FYB and S antigens. Well, this is just again bluffing. This is the MNS system. FYB is for that Duffy, I have taught you that Duffy antigen positive, that means increased risk of infection with Plasmodium vivax, no, not falciparum vivax. And then JKA, that would be for kid system. So the person is having alloimmunization. By alloimmunization, I mean that there are antibodies present in the body of this patient against these different antigens present on the surface of or the membrane of the RBC. So what we are going to prefer in this person is blood that would be negative for the following antigens per se. The correct answer for this is option number A. It's not O negative blood. It's gonna be like, for this particular patient, I don't need to waste O negative blood. Rather, I need blood which is gonna be specifically negative for these antigens per se. So yeah, we can go for autologous transfusion, but in an emergency situation, like, it's not possible for an autologous transfusion. So what we have to do in these patients is like extended typing of donor units so that we get a transfusion compatible blood for this chap. Then is this young woman, she's having easy bruisability. There is a menorrhagia. I mean, you can see first line itself is giving something in relation to von Willebrand. Then he also says platelet functionalizer shows a prolonged closure time. That's because the clot formation would be hampered, and the family history is positive for bleeding. The moment he says family history, like acute leukemia, ITP, liver disease, the door is closed. Only thing that is left behind is like von Willebrand disease for this particular question. Fairly straightforward one. And then we are having a patient on deep vein thrombosis, he's on heparin, and then the platelet count is decreasing. So we talk about HIT, and in these patients, like, what is the antidote? So that would be like option number C, that is argatroban. So all other would rather increase the chances of bleeding in this person. So that would be a discussion for this particular session, guys. We try to keep like fairly easy ones in this paper, and like as we go up in the journey, then the difficulty level is gonna increase. Thank you so much for hearing me out.
Hello friends, so let's discuss the INI-CET Champions Exam radiology questions. So here in this question, we have a 55-year-old who presents with progressive dyspnea for 6 months, and BAL shows increased lymphocytes. HRCT is given, and the diagnosis and next step is asked. So what do we see here in this image? Is look at this HRCT image, and a very important clue given in the question here is basically that there is increased lymphocytes in the bronchoalveolar lavage fluid, right? So looking at the image plus, so what do we look at the image here? There are areas of increased density which are there. There are areas of decreased density which is there. There is some septal thickening as well. Plus the most important clinical clue which is given is increased lymphocytes. So increased lymphocytes, out of the options given here, remember that's a clue to identify hypersensitivity pneumonitis has increased lymphocytes. Plus what it shows on the HRCT is the 3 density pattern. The 3 density pattern, which was previously also called as the head cheese appearance, right? What does that mean is the 3 density is the areas of decreased density, normal density, and increased density. The decreased density is because of the air trapping, because of the small airways which are involved in hypersensitivity pneumonitis. Then there are normal density areas, and there are increased density areas, that is ground glass opacity as well. So in hypersensitivity pneumonitis, which is extrinsic allergic alveolitis, so it's allergy to something. So that is why a detailed exposure history and specific antigen testing needs to be done to see that what the allergy is. So that is why the correct answer is going to be B here. Looking at the other options, how will the CT appear in IPF, sarcoidosis, and organizing pneumonia? So the IPF for the UIP pattern classically shows this honeycombing, right? What do we see in the IPF pattern is this honeycombing that we see in the IPF, where you would see traction bronchiectasis. The bronchi are dilated. There is traction bronchiectasis because there are fibrotic areas. The fibrosis causes the traction bronchiectasis, and you would see this honeycombing one above the other. The subpleural, the basal areas are commonly involved. Then you have sarcoidosis, where you see these lymph nodes, bilateral hilar lymph nodes, and you also see that in the HRCT, this is the fissure, and you can see that the fissure has this nodular appearance. So there are perifissural nodules because there are lymphatics present here. So in sarcoidosis, the nodules that we have, they are present in the perilymphatic distribution or peribronchovascular distribution. There is fissural nodularity that we see. There is nodules, a large nodule surrounded by the small nodules, which is also called as the galaxy sign, is also seen in sarcoidosis. This image here, what do we see is the peripheral patches of consolidation, and if you look carefully, the center is less dense, the periphery is more dense. This is called as the reverse halo sign. What is this called as the reverse halo sign or the atoll sign, which is seen in organizing pneumonia, cryptogenic organizing pneumonia, which has peripheral patches of consolidation with the reverse halo sign. Reverse halo basically stands for the outer is more white as compared to the inner side. Going to the next question. So in this question, important clues have been given here already, that this is a patient who has fever, malaise, right upper quadrant pain, and febrile tenderness. CT abdomen is given. Blood culture is showing Streptococcus viridans. So already given that it is bacteria which is present here. So in that case, based on the clinical history, we are thinking in terms of the pyogenic liver abscess because of the bacteria. Look at the image here. There are multiple hypodense lesions in the liver. Again, telling you it is pyogenic liver abscess because amoebic liver abscess is generally solitary, and there's going to be a history of a pre-existing GIT infection which is going to be there, and amoebiasis will then spread to the liver and cause amoebic liver abscess, which is generally more solitary lesion. They are not multiple, while the pyogenic liver abscesses are generally multiple. They can coalesce together and give the cluster sign as well. So this is pyogenic, so we will give antibiotics and percutaneous treatment. Let's have a look at the other images. What does this image show? So a hypodense lesion with the membrane floating inside. This is water lily sign of hydatid cyst. Hydatid cyst in the final stages get calcified. So when you get a calcified liver lesion, think of hydatid again. This is a hypodense lesion with the enhancing wall, which is solitary. This is amoebic liver abscess. And this is the triple phase CT of the liver, where you see the arterial phase enhancement of the lesion, and then there is washout of the contrast. In the delayed phase, it appears more hypodense as compared to the rest of the liver. So the early arterial enhancement is a very important finding that we see in hepatocellular carcinoma, because HCC is supplied by hepatic artery, so it will enhance early, while the rest of the liver is supplied by the portal vein. So that is why the HCC will enhance early, and it shows a early washout of contrast as well. So it appears dark as compared to the rest of the liver in the delayed images. Going to the next question here, what do we have is a 25-year-old patient with seizures, cognitive decline. Neuroimaging shows a lesion in the splenium of the corpus callosum. So if you look at the image here, this is the corpus callosum, posterior part splenium, and you can see this flare hyperintense lesion in the splenium of the corpus callosum. So this is going to be Marcia-Fava-Bignami disease. So this is generally more common in alcoholics patient and malnutrition because of the vitamin deficiencies. And classically, the lesion is seen in the splenium of the corpus callosum. Glioblastoma multiforme is generally more elderly patient, and you would see a well-defined mass tumor which will have the central necrosis and surrounding nodular enhancement. It crosses on both the sides. It also involves the corpus callosum, but it's going to be a more defined tumor with the central necrosis and peripheral nodular enhancement. Multiple sclerosis will have a different clinical presentation, not seizures, right? And it shows the lesions in the supratentorial, infratentorial areas, and you would see the Dawson fingers. Right, what do you see in multiple sclerosis is the Dawson fingers, the demyelinating plaques at the callososeptal interface. Acute ischemic stroke, again the presentation will be more acute neurological deficit that's going to be there, and there is going to be area of restricted diffusion that you would see depending on the clinical correlation, you would see the area of restricted diffusion, and it's going to be more acute presentation and not progressive cognitive decline. So this is also out. So remember, Marcia-Fava, Bignami disease, alcoholic splenium of corpus callosum is involved. So that's the answer there. Next one, a 60-year-old male presented with chest pain 5 days ago. The troponins were high, but now they are normal. So what imaging modality is gold standard for detecting a recent myocardial infarction? Remember, it is cardiac MRI. Now, what happens when you do a cardiac MRI in a myocardial infarct? So as the scar develops, scar fibrotic tissue is something which accumulates a contrast in the delayed scan. So what you see is LGE, that is late gadolinium enhancement, is going to be the feature of the scar that is formed in MI. So that is how MRI helps us to identify that scar of MI with the late gadolinium enhancement, even when the troponin levels are becoming normal. So for myocardial infarct, or even to look at the cardiac viability, MRI helps us in that. Next one, a 45-year-old male involved in an accident, emergency department. GCS is low, 8, right? Severe brain injury is there. So what is the most critical management priority? What do you see in the image here is this hyperdense acute hemorrhage, which has this crescent shape or sickle shape. Remember, sickle, S for S is SDH. Why this is acute hemorrhage? Because it is white, right? And what other finding do you see here is that there is significant midline shift, as you can appreciate in this image. This is the midline, but the midline has gone to one side. So there is significant midline shift, that is mass effect, which is caused by this hematoma hemorrhage, and that is why it needs evacuation. Since the GCS is also low, that is why we would need something which will help in the complete evacuation of this hematoma. So better than bore hole, it is going to be emergency craniotomy. In bore hole, we just create a hole, put the tube and try to evacuate the hematoma. Craniotomy is where a part of the skull bone is removed, so it gives a better access and more complete removal of the hematoma. So when the GCS is this low, there is significant midline shift, we need to do emergency craniotomy. And remember, SDH is due to rupture of cortical bridging veins. Does SDH cross the sutures? Yes. EDH does not cross. SDH crosses the sutures. Next one, a young man with sickle cell disease presents with left hip pain. So sickle cell, left hip pain, you are thinking in terms of AVN already. So suspecting AVN, MRI is advised. There is subchondral fracture with preservation of the joint space, and the right hip is normal. So how is this classified? So the AVN, avascular necrosis of the femur head, AVN hip classification. We have this Ficart and Arlett classification. So remember that, what is the staging? Stage 0 is when it is normal. Stage 1 is when the MRI starts showing the edema. So remember that MRI is the investigation of choice for AVN because it is sensitive and it picks up the early bone marrow edema changes. The X-ray will be normal, but the MRI will pick up the edema. Then you will have stage 2. So stage 1 is X-ray negative but MRI showing edema. Then you have stage 2, which is pre-collapse stage. On the radiography, there can be mixed osteopenia, sclerosis, and subchondral cyst-like changes, but there is no lucency or no obvious fracture. So there can be some lucencies that you can see, mixed osteopenia, sclerosis that you can see, right? So mixed sclerosis and subchondral cyst will be there. Then you have the stage 3, the stage of collapse, which is there, where the femur head starts collapsing and you will see the fracture as well. So crescent sign, which is, look at this crescent sign that you are seeing here. The crescent lucency, that is telling you the fracture which is there. So crescent sign, subchondral lucency of fracture is seen, and the collapse, the femur head will start collapsing. But the important point is the joint space is not affected. There are no arthritic changes, yes. Then comes finally the stage 4, which is the degenerative joint disease, and we would see secondary osteoarthritis developing. So remember, stage 1 is pre-radiographic. That means the MRI is abnormal but the X-ray is normal. Stage 2 is pre-collapse. Subchondral lucency, sclerosis will be seen. Stage 3 is the crescent sign, the fracture with the collapse but no osteoarthritis. And stage 4 is when there is osteoarthritis as well. So now it is given in this question that the joint space is not affected. So this is not stage 4. There is subchondral fracture which is seen, the crescent sign subchondral fracture. So that is going to be stage 3, right? The crescent sign, remember C for third alphabet C, and it is 3. Crescent sign is seen in 3, right? And stage 2 is going to be pre-collapse where we see subchondral cyst and sclerosis. Stage 1 is when the MRI is abnormal, the X-ray is normal. So the answer here is going to be stage 3 disease. Okay, the answer is going to be stage 3 disease. Right, so that was about your radiology questions in INI-CET Champions test. I hope you've learned out of it and you fared well in the test. All the best for your exam. Thank you.
Hello guys, I hope you all are doing good. I hope the test was good. So now we'll try to solve those questions which came in the test. Starting with the first question, guys. A patient with chronic cancer pain is on morphine 200 milligrams per day and he experiences breakthrough pain. Guys, breakthrough pain is what? Breakthrough pain is nothing but it is sudden severe flaring up of the pain. Sudden severe flare up of the pain, even though patient is on morphine or opioid, but still he'll have a sudden episode that is called as breakthrough pain. For breakthrough pain, we need to go for breakthrough dose of morphine. Now, what is a breakthrough dose of morphine, guys? Remember, it is always 10 to 15% of the daily dose, which should be given every 4 hours as needed. Now, remember why option A is not the answer. Why? Because fixed dose of 10 milligrams, it will be too low. It will be too low. Okay? Now 50% of the regular dose 100 milligrams, again every 8 hours 100 milligrams, it should not be given. Why? Because it will be too high. And the last option, double the regular dose, it should not be done, guys. Why? Because again you have given 200 milligrams only for breakthrough pain. You need to give 10 to 15% of the total daily dose. Okay, so this cannot be given. Coming to the second question, guys. A patient with severe aortic stenosis requires urgent non-cardiac surgery. What are the key anesthetic considerations in managing this patient? First of all, patient who is having severe aortic stenosis, they will be very much sensitive towards what, guys? Towards hypotension, towards tachycardia, towards arrhythmias. We need to avoid these kind of things when a patient is having severe aortic stenosis. And our aim should be what? We should be preventing anything that leads to myocardial ischemia. We should prevent all risk factors leading to myocardial ischemia. Now, if you remember these 2 points, now we will solve the MCQ. Okay? First, we'll rule out the wrong options. Like option B, induced hypotension. Can you go for induced controlled hypotension? Induced controlled hypotension is nothing but a deliberate hypotension you are maintaining. But a patient who is suffering with severe aortic stenosis, if you go for induced hypotension, what will happen? It can induce myocardial ischemia. So you cannot go for induced or controlled hypotension. Can you go for usage of high dose of volatile anesthetics? No. If you use high dose volatile anesthetic, it will basically cause vasodilatation. That can again lead to myocardial ischemia. Why? Because patient is already having severe aortic stenosis. Okay. Can you go for promoting tachycardia to increase the cardiac output? That's totally wrong. Tachycardia should be avoided in such kind of patients. Why? Because if you promote tachycardia, what will happen, guys? What will happen? The coronary perfusion pressure or coronary perfusion, basically, the coronary perfusion decreases. That can lead to ischemia. So basically, these three things cannot be done. So then what can be done, guys? In a patient who is having severe aortic stenosis, your aim should be, I should maintain the BP, pulse rate and all. Yani ki you have to maintain the preload, the afterload and also sinus rhythm. Why? Because these patients are very sensitive to arrhythmias. Okay. So remember, this should be the key consideration. Coming to the third question, guys. 45-year-old male is scheduled for elective shoulder arthroscopy for rotator cuff repair, considering the primary intervention of shoulder joint, which should be the regional nerve block, which should be considered for this patient. For any patient who's being posted for shoulder joint arthroscopy or shoulder pain, guys, remember you need to go for brachial plexus block. This brachial plexus can be approached by many routes. One is the interscalene approach, other is the supraclavicular approach, next is the axillary approach, next is the infraclavicular approach. Which approach you need to go for? Now just look over here, guys. Can you go for axillary approach? Never. Why? Because axillary approach is usually blocking the distal segments, and it is usually used for hand surgeries or forearm surgeries also. You can use axillary approach. Can you go for infraclavicular block, guys? Infraclavicular is also blocking the distal segments of brachial plexus, and again it is used for hand surgeries only. Now what are you left out with? You're left out with the interscalene and supraclavicular. Usually supraclavicular approach is by far regarded as the best approach of brachial plexus for the entire hand, right? But remember, here they are talking about shoulder. Okay? When you're talking about shoulder, you need to understand there is one approach that is basically used for shoulder joint. Which is that approach? It is the interscalene approach. In the interscalene approach, you are inserting the needle between the scalenus anterior and medius. It will block the upper roots C5, C6, C7. As upper roots are blocked, it is best used for shoulder analgesia. Okay, what roots are not blocked? C8 and T1 are not blocked. As C8 and T1 are not blocked, there is a nerve spared in interscalene approach. What is the nerve that is being spared in interscalene approach? It is the ulnar nerve that is being spared. But remember, interscalene approach is regarded as by far the best approach of brachial plexus. Okay, remember, supraclavicular can be given for all, like arm, forearm, hand. But shoulder, when he is asking about shoulder, the answer should be exactly interscalene approach. Now, next, guys, last. A child develops high fever of 104, muscle rigidity, tachycardia, rise in EtCO2 during surgery under general anesthesia, giving halothane and succinylcholine. What is the first step in management? Basically, all these features are giving you or clinching the diagnosis of a condition called as malignant hyperthermia. So he is asking what? He is asking what is the first step of management. Now what are the options? Give dantrolene sodium. That is the drug of choice for malignant hyperthermia. We'll go for other options also. Cool the patient. Yes, that is also done for malignant hyperthermia. Stop the triggering agents. That is also done. Administer bicarb. Yes, when the patient is having acidosis, you will go for administration of bicarb. But the question is asking you what? Be specific. What is the first step in these four? All four things are done. What is the first step? Remember, guys, the first step is what? You need to stop the triggering factors. What are the triggering factors that are leading to malignant hyperthermia over here? Halothane and scoline. Switch off the halothane. Give 100% of oxygen to the patient. Don't give scoline to the patient. Don't give any muscle relaxant to the patient. Just don't give any inhalational agent to the patient. Just you need to stop and give 100% of oxygen. The first step over here is what? Stop the triggering factors. That is your answer. After stopping the triggering factors, now you go for what? You give a centrally acting muscle relaxant. Why? Because in malignant hyperthermia, patient will be having what? Sustained muscle contraction. For that, you need to give what? IV dantrolene sodium. That could be the second one. Then you need to cool the patient as the patient is having a high temperature of 104, and you can also give sodium bicarbonate. So this is the answer. So hope this session was helpful to you guys. Okay. So if you have done good, okay. But if you have not scored also, it's okay. Why? Because it's just a test, right? And all the very best, guys. Thank you.
Good evening, dear friends. This is Dr. Jambukeswaran, PrepLadder's orthopedic faculty for you. We are going to discuss the question and answers of orthopedic section of INI-CET Champions exam conducted by our PrepLadder. We'll move on to the first question. You see, look at the X-ray. A 35-year-old Motor cyclist presents with a pelvic fracture pattern that is given here. I am able to see pelvis fracture, which is highly unstable fracture. Okay. He is hemodynamically unstable with ongoing bleed. Okay, ongoing bleed. What is the recommended initial step for stabilization? Choice A, pelvic binder application, resuscitation and urgent angioembolization. Choice B, immediate external fixation in the emergency department. Choice C, emergency laparotomy for hemoperitoneum. Choice D, immediate open reduction, internal fixation. The question asks the patient, what is the initial step? What will you do if he is hemodynamically unstable? Obviously, a word resuscitation is there only in one choice. See, he is having an ongoing bleed. First thing, you should stabilize him. The vital stabilization is important. The BP pulse should be monitored, respiration should be stabilized. The word resuscitation is given only in choice A. So I will give a pelvic binder which will prevent distraction, resuscitation. If possible, this is a query, urgent, if possible, do an angioembolization. So this should be the right option for this question. See, immediate external fixation in emergency department. If the patient is unstable, hemodynamically unstable, if you go on doing an external fixator, okay, we may lose the patient. So the right option is A. After that, we can do the next step. This is a very, very important question asked, already previously asked question. How to manage a retroperitoneal hemorrhage? Military anti-shock trousers, if available, you can just put it on the spot. Then give a pelvic binder. Shift the case to emergency department, apply an external fixator. So this is number 1, number 2, number 3, external fixator. Okay. Once the patient is stable, okay, you can go for either instead of external fixator, you can go for a pelvic C-clamp. Then definitive management, if the bleeding, everything stops, patient is hemodynamically all right, you go for an open reduction and internal fixation with plates and screw. With the radiologist, interventional radiologist help, anytime we can do angiography and embolization, so that will prevent further bleeding. This is how we will manage a case of retroperitoneal hemorrhage, which is a dreaded complication in unstable pelvic fractures. We'll move on to the next question. A 45-year-old man develops progressive bilateral leg weakness, that's the catch, and new onset urinary retention. MRI lumbar spine demonstrates the following finding. What is the appropriate surgical management? Emergency decompressive laminectomy and discectomy within 24 hours. Conservative management with physical therapy, that is exercise, epidural steroids, scheduled surgery in 2 weeks. When you see this MRI, here I am able to see a very severe lumbar disc prolapse. Okay, you see this place. Okay, you see this place, you're able to see a very severe lumbar disc prolapse which is compressing the cord. Cord compression is there. Whenever a patient presents to you with motor weakness, the procedure you have to do within 24 hours is emergency laminectomy and decompression. So the right option is emergency decompressive laminectomy with discectomy. Remove the disc that is prolapsed. Okay, discectomy within 24 hours. This is the right option. Conservative management, epidural steroids, they are contraindicated. We should not do when a patient already has a motor weakness. When somebody has a motor weakness, the only treatment option is emergency decompressive surgery, laminectomy with discectomy. We will move on to the third question. A 22-year-old athlete presents with knee pain and instability following a sports injury, some sports injury. Latchman test is positive. That one word is enough. Pivot shift test is positive. So the diagnosis, Latchman test is the gold standard test for anterior cruciate ligament injury. Anterior cruciate ligament is torn. You can get an anterior Droyer's test, a Latchman test, a pivot shift test. Okay. So among the three, the best is always Latchman. In our main recording, in our rapid revision, several times I had said this point. In other methods, you have to flex the knee to 90 degree. In Latchman, 20 degree flexion of knee joint is enough. So it will hurt the patient less. Number 2, When there is associated meniscal injury, sometimes your anterior Dryas test may be negative. It may mislead you. Even if there is anterocruciate ligament injury, if ACL injury is associated with medial meniscal injury, when you do an anterior Dryas test, because of doorstop phenomena, you may not elicit a positive anterior Dryas and you may miss an anterocruciate ligament injury. That problem is not there in Latchman's. So Latchman test is always said in all the textbooks, gold standard clinical test for anterocruciate ligament injury, complete tear of ACL. What you will do if there is complete tear of ACL? The only option is ACL reconstruction. So this should be the right answer. ACL reconstruction. Okay, we will move on to the fourth question. A 28-year-old man sustained a tibial shaft fracture in a road traffic accident. He was initially managed with immobilization in a cast. Tibial shaft fracture was treated with POP, cast. 6 months later, okay, it's a criteria. Okay, he continues to have pain and difficulty bearing weight. On examination, abnormal mobility is noted at the fracture site. Then X-ray was taken. A persistent fracture gap with no callus is seen. So 6 months, it has crossed 6 months. Abnormal mobility is there. X-ray shows a definitive gap. This is surely a case of non-union. No way connected with malunion. That is ruled out. It is a non-union. What type of non-union? Is it hypertrophic non-union or atrophic non-union? Very clearly with no callus is there. So it should be a case of atrophic non-union. It should be a case of atrophic non-union. The best treatment for atrophic non-union is open reduction. You freshen the ends of the atrophy, freshen it till you get an active bleeding. Fill the gap with cancellous bone grafting. After that, fix it rigidly. So the best treatment, the correct answer for this is option D. It is open reduction. It is a case of atrophic non-union. So I will do an open reduction internal fixation with rigid fixation with cancellous bone grafting. We will move on to the next question. A 68-year-old man complains of gradually increasing knee pain 3 years after total knee replacement. 3 years after TKR, he developed a gradually increasing knee pain. X-ray shows a radiolucent line around the tibial component with mild subsidence. Okay, and when you analyze, there is no fever or swelling. Look at this X-ray. I am able to see a translucent line between this prosthesis and the bone. Okay, so two things will cross your mind. Somebody after 3 years developing some sort of pain and X-ray shows a radiolucent line. Could it be infection? One question will come. If it is infection, there should be some fever or some swelling or some local signs of inflammation. Nothing is there. Just subsidence is there. You are seeing a translucent line around the prosthesis. This is classically what is called aseptic loosening. Okay, aseptic loosening. It's a very important complication of total knee replacement because we use what is called a bone cement to fix the prosthesis. Okay, so this prosthesis and this prosthesis, you are able to see some white color things. They are the bone cement. So bone cement, we will fix it with bone cement. Bone cement, we know it is made up of polymethoxymethyl acrylate, PMMA. So bone cement, one complication is aseptic loosening because bone cement liberates what is called polyethylene debris, which causes aseptic loosening, causes osteolysis of the bone. So what happens? The prosthesis becomes loose and it will come out. So the only treatment for that is you have to open, remove the prosthesis, clean the area, again fit it with a new prosthesis of the wanted size, again with bone cement, fresh bone cement. That's the only treatment option. So this is a classical history, a classical X-ray, and the diagnosis is aseptic loosening. The treatment is may need revision total knee replacement, fixing it with a new prosthesis and with bone cement. Okay, so this is the classical case of aseptic loosening. Don't confuse this with infection. If it is infection, they would have given fever, swelling, local signs of inflammation. Okay, yes. We'll move on to the next question. A 40-year-old male sustains a high-energy open tibial fracture, compound fracture, Gustilo-Anderson's type 3B, very severe. Okay, motorcycle accident. After thorough debridement, there is an 8 centimeter, underline this word, 8 centimeter segmental bone loss, but the soft tissue coverage is adequate. Soft tissue coverage is adequate. Flap reconstruction can be done. What is the most appropriate reconstructive strategy? See, the only catch here, there is a bone loss. How much bone loss? Massive bone loss. 8 centimeters, a very big, this much size, 8 centimeter bone loss. You cannot fill this with the thing that will confuse you when you see you may want to go for primary bone grafting. That is wrong. That is wrong. You cannot do primary bone grafting for such a big defect. Very big defect, large defect. Okay, where to harvest that amount? Suppose 1 centimeter, 1.5 centimeter, easily you can fill that with your iliac crust cancellous bone grafting. It is not possible, primary bone grafting, for such a big defect. So, the one good technique, a new technique, a very promising technique, the right answer is induced membrane technique. Induced membrane technique. This has a name. This is called masculettes. MASQUELET'. Masculettes technique. This is called masculettes techniques, induced membrane technique, otherwise called masculettes technique. What is that? I am going to that gap, I am filling that gap with a bone cement. Bone cement is nothing but a polymethoxymethyl acrylate, PMMA. Polymethoxymethyl acrylate. So I am filling that 8 centimeter gap with a bone cement and closing that. Bone cement is a foreign body. So naturally what happens? No, a membrane is formed. A membrane is formed. The membrane is formed, definitely that membrane will have some blood vessels. So it's a vascularized membrane that is formed around the bone cement. In reaction to, because bone cement is a foreign body, so your body defense is coming, it's forming a membrane around the bone cement. That membrane contains a lot of blood vessels, vascularized membrane. You leave this for 8 weeks. After 8 weeks, open again, carefully dissect the membrane. You just dissect the membrane. Right? When you open the membrane, you take out the bone cement. Membrane is still there. Now you can fill that place in that membrane, whatever possible minimal amount of cancellous bone, you just put inside the membrane, close it again. A membrane is there, it is living, it has blood vessels. You are putting bone graft into it, cancellous bone graft into it. So bone graft starts growing inside the membrane and will fill up the gap. So it's a 2-stage procedure. First stage, you are filling the gap with the bone cement, inducing a membrane. That's why it's called induced membrane technique. This was by the great Masculette. So it's called Masculette's technique. After 8 weeks, you are dissecting the membrane, taking out the bone cement, filling whatever possible cancellous bone graft, you fill it. So the bone will start growing and the gap will be filled. So this is the best scientific management, most appropriate reconstructive strategy for managing a big bone defect. You'll move on to the next question. A 35-year-old male sustains high velocity road traffic accident and presents with back pain and paraparesis. Image reveals a bust fracture of T12. T12, you know, it is the most weight bearing vertebra. So bust fracture of T12, 50% canal compromise. The load sharing classification 8, very high. Okay, so it is compressing the nerve root. What is the most appropriate management? You should approach posteriorly, okay, decompress it, then for stabilization, because that vertebra is totally fractured. To stabilize that, do a fusion, spinal fusion. So the only management, the 4 choice that is available is posterior instrumentation with fusion. That's the best answer among the 4. We'll move on to the next and last question. A 25-year-old man presents with a painless swelling in the proximal phalanx of his middle finger. X-ray, so phalanx, you know what is the most common tumor. X-ray shows a well-defined lytic lesion with popcorn calcification. Diagnosis is over within the medullary cavity. So it is intramedullary, within the medullary cavity. Cortex is intact. Okay, cortex is intact. What is the diagnosis? Obviously, this is a case of N chondroma. Okay, this is a case of N chondroma. You know, enchondroma is the most common benign bone tumor of the fingers, phalanges. Usually it happens in the ring finger or little finger. It can happen in any finger. Here it is given middle. Most common is ring finger, little finger. It can happen middle. And X-ray shows three classical findings. One, it's an osteolytic lesion. So it can be in the form of one of the three forms. Characteristic O-ring sign. When you see, exactly the lytic lesion is like a ring, O-ring sign. It can be in the form of O-ring sign, or it can be in the form of mottled calcification. So this is called stippled calcification or mottled calcification. Otherwise, the calcification is little bigger, especially like in the upper end of humerus. It look like a popcorn, so it's called popcorn calcification. So enchondroma presents with an osteolytic lesion, either with a O-ring sign, a ring-shaped osteolytic lesion, or a stippled or mottled calcification, otherwise a popcorn calcification. Okay, so we have completed the discussion. Thank you so much, dear friends.
Hi everyone, this is Dr. Ankit Goyal, your Psychiatry faculty at PrepLadder. Let's discuss in this video the INI-CET Champions Exam Psychiatry questions. So let's talk about the first question. The question is that a patient who has been on lithium therapy for 5 years presents with tremor, confusion and diarrhea. Laboratory tests show a serum lithium level of 2.2 milliequivalent per liter and elevated creatinine. What is the appropriate management approach for this patient? So the options are A, discontinue lithium, IV fluids, consider hemodialysis if severe neurological symptoms are there. B, reduce the lithium dose by 50% and continue monitoring. C, add thiazide diuretic to enhance lithium clearance, or is it D, switch to valproate immediately without a washout period? Now, as you can see here, we can see that the lithium levels, serum lithium levels are increased 2.2 milliequivalent per liter, and also the signs and symptoms are suggesting that it is a case of lithium toxicity. So let's talk about the lithium levels. We know the therapeutic range of lithium. It has a narrow therapeutic index. It is 0.5 to 1.5 milliequivalent per liter. For acute mania, the required level is 1 to 1.5 milliequivalent per liter, and for maintenance, it is 0.6 to 1.2 milliequivalent per liter. And we know that the toxicity occurs when the levels are more than 1.5 milliequivalent per liter. So let's also talk about the signs and symptoms of lithium toxicity. In mild lithium toxicity, when the levels are somewhere between 1.5 to 2 milliequivalent per liter, a lot of GI symptoms like vomiting, abdominal pain can be there. Then CNS signs and symptoms like ataxia, there can be nystagmus, muscle weakness can be there. Patient may also have polyuria. So these usually suggest mild toxicity. In moderate lithium toxicity, when the level is 2 to 2.5 milliequivalent per liter, more of GI symptoms and more of CNS symptoms you can see, such as anorexia, nausea, vomiting can be there. In CNS, hyperactive deep tendon reflexes, convulsions, stupor, coma can occur, and even circulatory failure may occur. In severe lithium toxicity, when it is more than 2.5, generalized convulsions can occur, oliguria, renal failure, and ultimately death can also occur in lithium toxicity. So it's very important to identify, to suspect lithium toxicity if it is present, and also the management. Now coming to the treatment, first and foremost, very important, if you're suspecting lithium toxicity, you have to stop and withhold lithium. Correct hydration, also carefully monitor the renal function, because we know that lithium is excreted unmetabolized from the body via the kidneys. Removal of unabsorbed lithium from the GI tract. So if there is any unabsorbed lithium, we can remove by polyethylene glycol, that is PEG, sodium polystyrene sulfonate. Remember, activated charcoal has no role in the management of lithium toxicity. Now, hemodialysis can also be used in severe cases. So many cases with the toxicity levels more than 2.5 milliequivalent per liter, and along with that, if there is neurological symptoms or there are severe cardiovascular symptoms, then we can use. And also for any patient, if the lithium level is more than 4 milliequivalent per liter, there also hemodialysis can be used. Now let's talk about the options. So again, you can see here we are suspecting the patient is having lithium toxicity. So the treatment, the next important approach is we will discontinue lithium, give IV fluids, and consider hemodialysis if there are severe neurological symptoms. Now again, we will not reduce and continue monitoring, we will withhold. Now see this Option C, add thiazide diuretic to enhance lithium clearance. Now, very important, remember that lithium has interaction with a number of drugs. One of them is thiazide diuretic. And what does thiazide diuretic do? It decreases the lithium clearance. So in fact, it increases the lithium levels. It can again further worsen lithium toxicity. In fact, there are various risk factors for lithium toxicity. For example, if lithium is given above the recommended dosage, if there is any renal impairment, and also drug interaction like this one. In fact, one of the common causes of lithium toxicity these days is thiazides, which are used as antihypertensive agents. So this is also incorrect. Switch to Valproate immediately without a washout period. Again, if you want to shift to another mood stabilizer, first we'll manage lithium toxicity. So the next important appropriate management step would be option A. Let's now discuss the next question. A patient with a history of alcohol use disorder presents 48 hours after the last alcohol intake with tremors, diaphoresis and visual hallucination. The SIVA score is 15. What is the most appropriate initial management in this case? So the options are lorazepam 2 mg Q 1 hour PRN, that is every 1 hour as needed, monitor for seizures, haloperidol for hallucinations, observation without medication, immediate intubation for airway protection. Again, you can see this is a case of alcohol withdrawal. So patient was taking alcohol and suddenly he stopped taking alcohol and he has developed some symptoms. So let's talk about the alcohol withdrawal symptoms. So let's talk about these symptoms. So suppose the patient has stopped or has significantly reduced the alcohol intake. So in the next 6 to 8 hours, patient may present with tremulousness. So tremors is the most common or earliest withdrawal symptom. Other symptoms can be there. There can be sweating, there can be anxiety, increased blood pressure. So all these symptoms can be seen. If this withdrawal state continues, so in 8 to 12 hours, patient may develop perceptual disturbances such as alcoholic hallucinosis. For example, patient may have auditory hallucinations. Patient may have other hallucination like visual hallucination, tactile hallucination. These may also be seen. If this withdrawal state continues, so in the next 12 to 24 hours, patient may develop seizures, which are generalized tonic-clonic seizures, also known as rum fits. So fits due to rum or alcohol, it is rum fits, and sometimes also referred to as cluster seizures. So you may see in a short span, patient may be having a number of these seizures. So they may occur in clusters. And if this state continues, patient in up to 72 hours, that is peak in 48 to 72 hours, patient may develop delirium tremens. So patient may eventually, so these may be seen, seizures, delirium tremens, they may be seen in severe withdrawal state. So what is delirium tremens? As the name suggests, patient now is having delirium. So what is delirium? We know delirium means there is impairment of consciousness. So there is impairment of consciousness, and we can remember some important points. So any of these 4 points I've mentioned in the question may tell you that there is impairment of consciousness. So remember this mnemonic A, C, D, C. So A for altered sensorium. Remember C for clouding of consciousness. D for disorientation to time, place or person, and C for confusion. So many times they may use these terms, which is telling you that now there is impairment of consciousness has developed. So now you will say that patient is in delirium tremens. Remember, delirium tremens, it's a medical emergency. So these are important symptoms which can be seen in the withdrawal state. Now also let's talk about what is this SIVA. In fact, now we use this revised version SIVA AR. It is Clinical Institute Withdrawal Assessment of Alcohol Scale Revised. It is a 10-item scale, and a score of more than 10 in SIVA, it should prompt assisted withdrawal. So if the score is more than 10, that is telling us that assisted withdrawal. So we would want to now give the patient medicines. So let's talk about the treatment. In the treatment of alcohol use disorder, we discuss in 2 phases. One is the detoxification phase, where we are going to manage the withdrawal symptoms, and another is the maintenance phase. Now, what is the drug of choice? If somebody asks you what is the drug of choice for alcohol withdrawal, remember it is benzodiazepines. So we can use benzodiazepines such as lorazepam, diazepam, oxazepam, chlordiazepoxide. So these are benzodiazepines which we can use. Now, suppose in the question somewhere they tell you that the liver function tests are deranged, or there is hepatomegaly, or there is liver cirrhosis, or there is icterus. So somewhere they're trying to tell you that patient may be having liver disease. In that case, which benzodiazepine you will prefer? Remember the mnemonic liver OK. So remember the liver OK, benzodiazepine, lorazepam or oxazepam. So these can be used when the patient is having some liver disease. In the withdrawal state, we can give these benzodiazepine. Now, along with these benzodiazepines, can we add something else as well? So remember, many times patient who is consuming alcohol for a long time may be having deficiency of vitamin B1, that is thiamine. So thiamine can also be added. So remember, if it is a drug of choice for alcohol withdrawal, it is benzodiazepine. So we'll start the benzodiazepine at a dose depending on the symptoms the patient is having. So we'll select a dose and subsequently we'll taper and stop the benzodiazepine. So within 7 to 14 days, we can taper and stop and the withdrawal state is managed. So if option is benzodiazepine or option is benzodiazepine plus thiamine. So benzodiazepine plus thiamine may be a better answer. But remember, if they ask you between benzodiazepine and thiamine, then of course we'll say in the withdrawal state, benzodiazepine are the drug of choice. So this is how we manage the withdrawal state. Now let's talk about the maintenance. So in maintenance, one drug we have is disulfiram, which is an aversive agent. And what is the mechanism of action of disulfiram? Remember, it inhibits aldehyde dehydrogenase enzyme. We also have anti-craving agents, and two anti-craving agents which are FDA approved for alcohol. One is naltrexone. What is naltrexone? It is opioid mu antagonist. And another is acamprosate. What is acamprosate? It is a NMDA antagonist. So these are some important drugs which can be used in the management, and of course in the maintenance we can also use non-pharmacological measures such as therapy can be used. Now let's talk about this question. So the answer here is we will give lorazepam 2 mg every 1 hour as per needed depending on the withdrawal symptoms, and of course we'll also monitor for seizures. Now let's talk about the next question. A patient with major depressive disorder has not responded to 4 adequate antidepressant trials including an SSRI, an SNRI, bupropion and mirtazapine. What is the most appropriate next step in the management? The options are A. Switch to another SSRI, increase dose of current antidepressant, C. Electroconvulsive therapy or esketamine nasal spray, D. Discontinue all the medication. Now, when we are discussing these questions, I'm also trying to, discuss how to approach these questions. So I'm trying to highlight the key words in the question. So in this question, you can see patient is a case of depression and at least 4 of these antidepressants have been given for adequate trial. Adequate trial means for adequate duration and for adequate dose, but the patient is not showing any improvement. So this is suggesting it's a case of treatment-resistant depression. Now let's understand how do we approach any patient with MDD, that is depression. Now the first step, we can use first line drugs like SSRI, SNRI, these can be used, and if there is no improvement, then the second line approach is to increase the dose, to switch to another antidepressant with a different mechanism or of same class, but another drug can be used. And another strategy which we can use is augmenting agent or adjunctive therapy. So there are certain augmenting agents which can be added to these antidepressants, such as lithium has found to be useful in these scenarios. Atypical antipsychotics like quetiapine, aripiprazole can be used. Even olanzapine, risperidone has shown some good results. Thyroid hormone, that is T3, can also be used, and we can also give another second antidepressant with a different neurotransmitter action. For example, patient on SSRI, we can add bupropion, which has a different mechanism of action. Now let's also discuss some other approaches. Now we also have some newer drugs. One is esketamine. It is S-enantiomer of ketamine. Now ketamine, we know it's an anesthetic agent. It is given in this scenario as IV drug, can also be given by other route. Usually by IV route it can be given, and remember it has a rapid onset of action. So ketamine has a rapid onset of action, and also remember ketamine has anti-suicidal property. So esketamine, the mechanism is similar to ketamine. It is a NMDA antagonist. NMDA, it's a glutamate receptor, so N-methyl D-aspartate antagonist, and it is available as nasal spray. In fact, remember it has been approved by the FDA for treatment-resistant depression. So lack of response to two different antidepressants. So in conjunction with oral antidepressant, esketamine can be used. Also, for MDD with acute suicidal ideation or behavior, it can also be used. Again, it has anti-suicidal property. Now remember, because of risk of abuse, self-administration is done, but usually under the supervision of doctor, and also observe the patient for at least 2 hours because of risk of sedation, dissociation may occur after giving the drug. So esketamine is an option in such scenarios. And also remember, when we talk about ECT, there are certain indications of ECT in depression. One of the indication is if a person having depression, along with this there is suicidal risk, then ECT may be a preferred treatment. Can we give ECT in pregnancy? Yes, remember, even in pregnancy, ECT can be given. A patient is having depression, suicidal behavior, and the patient is pregnant, then also we can give ECT. Then other indications in depression: severe depression with stupor, psychotic depression, and remember, depression refractory to other modalities. In those scenarios also we have seen that ECT shows improvement. So let's talk about this question. So here the answer is we can use option C, that is ECT or esketamine nasal spray. Let's discuss the next question. A patient with bipolar disorder on therapeutic lithium develops nephrogenic diabetes insipidus. What is the appropriate alternative mood stabilizer? So we can just correct this question. The question, could be that what is the next step in the management? So here what we are seeing, that the patient is having therapeutic lithium levels and has developed nephrogenic diabetes insipidus. So first let's see the options. Option A, increase lithium dose. B, continue lithium and treat diabetes insipidus symptomatically. C, switch to valproic acid. And D, add thiazide diuretic. Now let's talk about some important side effects of lithium, which we can remember with the mnemonic lithium only. So some of the important side effects, remember: L for remember, loss of hair or appetite. Let's discuss the next question. A patient with bipolar disorder on therapeutic lithium develops nephrogenic diabetes insipidus. Just correct this question. What is the appropriate next step in the management? So the options are: A, increase lithium dose. B, continue lithium and treat diabetes insipidus symptomatically. C, switch to valproic acid. Or is it D, add thiazide diuretic? Now as you can see in this scenario, the patient is having lithium in the therapeutic range and has developed diabetes insipidus. So in fact this is one of the adverse effects which can occur with lithium. So let's talk about some side effects of lithium which we can remember with the mnemonic lithium itself. So what are these important side effects? So remember, L for loss of hair and also loss of appetite can occur with lithium. Increase in the leukocyte, that can occur. Tremors can occur, and usually these tremors are resting tremors, fine resting tremors can occur. And what is the treatment of these tremors? Remember, beta blockers like propranolol can be used. Remember, H for hypothyroidism. Even other endocrinal abnormalities such as hyperthyroidism can also occur with lithium, and in fact remember, even hyperparathyroidism can also occur with lithium. And also there are a lot of drug interactions with lithium. Remember some of these important drug interactions. One of them we have discussed, like thiazide diuretics. Urine increase in the urine output, it can ultimately lead to polyuria, polydipsia, and nephrogenic diabetes insipidus. And miscellaneous adverse effects like weight gain can occur because of various factors. For example, because of increase in oral intake, because of hypothyroidism. So weight gain is associated with lithium. And if the mother is pregnant, she takes lithium, abstinence anomaly of the tricuspid valve can occur in the fetus. So these are some important side effects with lithium. So let's talk about the renal adverse effects. So most common is polyuria and can lead to secondary polydipsia and diabetes insipidus, and it occurs because lithium inhibits the effects of ADH. Now in the management of nephrogenic diabetes insipidus because of lithium, first is we can manage by fluid replacement, and if required, drugs like thiazide or potassium sparing diuretics, these can be used. But as we have discussed that thiazide diuretic, they decrease the lithium clearance, so hence we should reduce the lithium dose to half when we are using thiazide diuretics, because otherwise lithium toxicity can occur. Then there are certain other adverse effects with renal, with lithium. Some of the other rarely seen renal effects you can remember. Non-specific interstitial fibrosis can occur, nephrotic syndrome can occur, distal RTA, renal tubular acidosis, microcyst can also be seen with lithium. So let's talk about this question. Now in this question, if they ask you the next step in the management, should we increase lithium dose? Of course, that is not the case. And should we add thiazide diuretic? That is one possibility. Switch to valproic acid. So again, here we want to manage lithium adverse effect. So again, we can manage it, continue lithium and treat diabetes insipidus symptomatically. So yes, that is the next step. See, if the question is changed and if they ask you what is the appropriate drug used in this scenario, then you can go with option number D. So first we can manage symptomatically diabetes insipidus. So the answer is continue lithium and treat diabetes insipidus symptomatically. So depending on the language of the question, what they're asking, the answer may change. So remember how to treat it. Now let's talk about the next question. An 80-year-old male presents with a 2-year history of progressive memory impairment, recurrent visual hallucinations, and fluctuations in attention and alertness throughout the day. His wife also notes he has developed a slow, shuffling gait and mild rigidity in his limbs. A DAT scan, that is dopamine transporter scan, reveals reduced dopamine transporter uptake in the striatum. What is the most likely diagnosis and appropriate management strategy? Options are A. Alzheimer's disease, start donepezil. B. Parkinson disease with dementia, levodopa therapy. Vascular dementia, control the vascular risk factors. Or is it D. Dementia with Lewy bodies, treat with cholinesterase inhibitors, avoid typical antipsychotics. I'm sure by now you must have understood what is this scenario. Yes, this is a case of Lewy body disease or dementia with Lewy body. Here, progressive cognitive decline is seen. Memory impairment may not be prominent in the early stages. And remember, both the cortical and the subcortical features are seen. And in fact, we have remembered the core features of Lewy body disease with a simple mnemonic. So let us say there is a person, Mr. Lewy, he goes for an interview. So the interviewer asks him, show your CV, Mr. So CVMR. What is C? There is fluctuating cognition. So there is variation in attention, alertness, as in this case. V for remember visual hallucinations, which are usually complex, recurrent visual hallucinations can be seen. M for motor features of Parkinsonism like rigidity, tremors, bradykinesia. And very important, this has been recently added in the core feature, that is REM sleep behavior disorder. Now what is this REM sleep behavior disorder? We know in REM usually there is atonia. So when we are in REM, the muscles are in a state of paralysis. But what if this atonia is not achieved in REM? So in REM, we know that the dreams which we have, we remember the dreams. So if there is no atonia, the person may start enacting his dreams. So the person is sleeping and he may start enacting by punching, kicking movements in the sleep. So REM sleep behavior disorder can be seen as a core feature in Lewy body disease. Now also, there are certain supportive features of Lewy body disease. Severe neuroleptic sensitivity. Neuroleptic is antipsychotics. So person is sensitive to the neuroleptic induced extrapyramidal symptoms. So usually we should avoid antipsychotics in the treatment of psychotic symptoms. If required, try to avoid those antipsychotics which have a higher risk of EPS. Some other supportive features include repeated falls, syncope. There can be transient loss of consciousness, severe autonomic dysfunction, hyper or hyposomnia. Also, hallucinations in other modalities. So, visual hallucination in the core feature, other hallucination can also be seen. Even systematized delusion like delusion of persecution. And remember, even Capgras syndrome can be seen. What is Capgras syndrome? Close person replaced by stranger. Many times patient may have this in the initial stages of presentation, and if we take a history and we examine, we may see patient may be having Lewy body disease. Also, other features like depression, apathy, anxiety, these may also be seen. Also, remember some indicative biomarkers for Lewy body disease. Decrease in the dopamine transporter uptake in the basal ganglia in the DAT scan, as has been mentioned in this question. Also, decrease uptake in the meta-iodobenzyl guanidine myocardial scintigraphy. Also, polysomnographic evidence of REM sleep without atonia. So we know that REM sleep behavior disorder can be seen, and even in polysomnography, you may see the evidence. Also remember, in the SPECT PET perfusion scan, generalized low uptake with decreased occipital activity. In fact, in the FDG PET scan, there is a sign, posterior cingulate island sign, if you can see, can be seen in especially in the initial stages, and this may help initially in distinguishing Lewy body disease from Alzheimer disease. So these are some important points. Also remember, in the pathology, what do we see in the pathology microscopically? So remember the name, it is Lewy body disease. So in the pathology, Lewy bodies can be seen. So you can see these are spherical intracytoplasmic eosinophilic inclusion bodies. So there is a pinkish central core surrounded by a halo, and these are basically fibrillar deposits of alpha synuclein. So again, if you see the options tell us the answer here is option D. It is dementia with Lewy bodies. In the treatment, we can use cholinesterase inhibitors, and also, as we have discussed, avoid typical antipsychotics. Now also remember that a close differential diagnosis of Lewy body disease is Parkinson disease with dementia. So both may be having similar features, and sometimes clinically we can differentiate them. Remember, Parkinson disease with dementia, it is a subcortical dementia. So here usually you will see in the history that motor symptoms would develop first, and after some time the cognitive symptoms may develop. And in fact, in the research criteria, we use this 1 year rule, that after start of the motor symptoms, usually 1 year later the cognitive symptoms would start. While in Lewy body disease, dementia occurs and Parkinson symptoms may occur during that time or may occur afterwards. So here the answer is option D. Let's discuss the next question. A 40-year-old patient with bipolar disorder on lithium presents with tremor and polyuria. The lab show lithium level 1.8 milliequivalent per liter, therapeutic range they have given 0.6 to 1.2, and rising creatinine. What is the most appropriate management? Options are discontinue lithium supportive care, consider alternative mood stabilizer after clearance, reduce lithium dose to 50%, add thiazide diuretic to improve lithium clearance, continue current dose with dose monitoring. So again, we are suspecting lithium toxicity here. So again, what is the answer here? We'll discontinue lithium supportive care. We have discussed the management, and we can consider another mood stabilizer after the clearance if required. So the option is option A. So, or we can even continue with lithium after managing the toxicity. So these were the questions of the INI-CET Champions exam. And again, thank you all of you. And as I always say, take one session at a time, take one day at a time. Try to again revise all the important topics and keep a smile. So keep smiling, keep moving forward. Thank you, and may God bless you all.
Hello everyone. So here I will be discussing the dermatology questions. So the first question is, a 65-year-old patient presents with tense itchy bullae on trunk and extremities. Direct immunofluorescence findings have been shown below. So I have an old patient who has itchy tense bullae. Now even if I didn't have DIF finding, the diagnosis is very clear cut here. But let's look at the DIF finding. I see linear band here. Linear band of fluorescence or linear deposition of fluorescence here. So all of this matching together, the diagnosis becomes bullous pemphigoid, right? Now the question is that what is the target antigen and what is the appropriate first line management? Now bullous pemphigoid, the target antigen we all know is BP180 and BP230. So that is there only in one option. Let's look at the treatment provided. So topical corticosteroid, yes, it is used in localized lesion of BP, and Dapsone is used when my BP is more extensive. So A option would be correct, right? Desmoglein 3 we know is seen in pemphigus, type 7 collagen seen with EB and SLE, laminin 332 again subepidermal bullous disorder, which is not matching the clinical picture here. So the best answer here would be option A. A patient started allopurinol 3 weeks ago and now presents with widespread erythematous macules and papules, facial swelling and enlarged lymph nodes. Lab test reveals eosinophilia. So I have erythematous macules and papules which are happening after intake of a drug which is allopurinol. There is facial swelling and there are enlarged lymph nodes also. What is the most likely diagnosis? So this is clearly a case of drug reaction to something. Allopurinol is the drug here. Now we have to figure out what kind of drug reaction it is. So here let's look at the first option. The first option is DRESS. What do you mean by DRESS? DRESS means drug reaction, eosinophilia, and systemic symptoms. So all of this are present in this patient. We have drug reaction in the form of maculopapular rash, there is eosinophilia, and there are systemic symptoms. Patients have facial swelling, enlarged lymph node. So DRESS is the correct option here. Let's look at the other options. Stevens-Johnson syndrome, we know presents with targetoid lesions, with bullae, with erosions, which is not here. Fixed drug eruption is present in a particular area, single lesion, usually can be 2 or 3 lesion. Bullae, which heals with PIH, again not there, or a violaceous lesion which heals with PIH, which is again not there. Urticaria will present with wheals, which is not here, so my answer should be DRESS. And yes, if you have DRESS syndrome, you discontinue the offending drug, which is allopurinol here. You give systemic corticosteroids and monitor organ function. So answer should be A here. A 45-year-old presents with violaceous papules on wrist with white lacy patches in the oral mucosa. Biopsy shows lichenoid inflammation with civet bodies. What are civet bodies? They are apoptotic bodies. So this is a very, very clear-cut case of lichen planus. We know we have violaceous papules which are present on the flexures. There are oral lesions in which white lacy reticular pattern is very common. You have apoptotic bodies on biopsy, so the diagnosis will be lichen planus, and yes, you use topical steroids to manage it. The other options, lupus erythematosus, biopsy does not fit, clinical does not fit, contact dermatitis, psoriasis, again, all of this do not match our clinical findings and the histopath findings. A 55-year-old female presents with 7th month history of progressive difficulty in climbing stairs and raising her arms. Basically, proximal muscle weakness. When you see proximal muscle weakness, something strikes here. In addition, you have been given violaceous papules on knuckles, purplish discoloration around the eyelid. So what is this? These are Gottron's papules, and this purplish discoloration is the heliotrope rash, right? Lab test reveals elevated creatinine kinase suggestive of muscle inflammation, positive Jo-1 antibodies, again specific for DM. So what is the crucial screening and what is the diagnosis? So here, even if I have to just find the diagnosis, the option D, which is dermatomyositis, is correct. And in DM, we screen for interstitial lung disease and malignancy. Rest of the options do not match our clinical findings. An elderly patient presents with tense bulla over extremities. So again, we have tense bulla and this time they are over extremities. DIF shows linear IgG again at the basement membrane zone. Now on salt split, antibodies are localizing to the dermal side. So what is the most likely diagnosis? So what do you do in salt split? We put the sample in 1 molar NaCl and it splits the sample at lamina lucida. So lamina lucida, it splits the sample. So now if I get fluorescence here, that means it is positive to antigens which are there on the epidermal side of lamina lucida. Whereas if we get a fluorescence here, it is on the dermal side of lamina lucida. It's a part of basement membrane zone, but which part? So now we know that BP antigen 180 and all are in the epidermal side or in the lamina, above lamina lucida. Whereas my collagen 7 and anchoring fibrils, they are down in the dermal side. So if I am getting antibodies which are localizing to the dermal side, then the probable answer becomes epidermolysis bullosa acquisita. Salt split is done to differentiate BP versus EBA because sometimes they clinically match each other. BP would show fluorescence on the epidermal side, whereas EBA will show fluorescence on the dermal side because the target antigen is collagen 7 here. So answer would be epidermolysis bullosa acquisita, right? Thank you so much.